Very good morning, all of you. A warm welcome to all of you at the SHAPE Summit 2026. Can we start with a big round of applause? Structural Heart and Access Percutaneous Excellence. We'll be starting this beautiful, enriching day filled with back-to-back session. I'm sure all of you are looking forward. We'll be starting with the lamp lighting ceremony. I would like to invite on the dais Dr. Monotosh Paja, sir. Can we have some applause? Dr. Anil Mishra, Dr. Pratap Kumar, sir, Dr. Rajiv Menon, sir, and Dr. Dilip Kumar, sir, on the dais for the lamp lighting.
या कुन्देन्दु तुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमाम् आद्यां जगद्व्यापिनीं वीणा.
Thank you. Before we proceed, I request all of you to please kindly stand up for the national anthem.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंधु गुजरात मराठा द्राविड़ उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंगा तब शुभ नामे जागे तब शुभ आशीष मांगे गाहे तब जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
I now request Dr. Dilip Kumar, sir, to kindly share the welcome address.
So, good morning, everyone, and thanks for coming here. I welcome you all to this SHAPE Summit, and the vision of this SHAPE Summit is the structural heart intervention in Eastern India. It has to come up and catch up with the national level, international level, which has attained at this moment. And to begin with, let me tell you some word of inspirations. Last evening, I called up Dr. Ramesh Dagubati. I was not sure whether he was in India or US at that time when I was framing the agenda. So I put it somewhere there, and I told him that it is flexible as per your timing. Tell us, then we can change. So last evening he said, no, it is 3 a.m. In US, and so I told, okay, I will make it at 5:30, 6 o'clock US time, so that you will be okay, comfortable. Then he told me, no, I don't want to change the flow of the program. So I will be going with your agenda. I will be 3 o'clock up, and I will be there maintaining my time. So this is kind of the inspiring instances. Dr. Panja sir, came at 9 o'clock. 8:59 he said me, Dilip, I thought it was 9 o'clock, and I am there. So no, sir, it's 9:30. So see how the professional world goes. And Dr. Pratap Kumar landed at 2:30 a.m. in the morning. I thought sir will take rest. He came from all the way from Japan, and then he was there 9:25. So, these things inspire us and tell us to, keep ourselves. At least we should try to be there in their, as far as professional work conduct is concerned. We should be at least approaching them. We may not reach there, but we can definitely get inspired from them. So I will not take much of time. We will, with these words, we will go ahead with the first session, and I will request the moderator for the first session is Prasant Dwivedi, and he will be reaching here 5 minutes. So I will be doing that job for the first session, and now we'll announce the panel and the chairperson for the first session, and we'll go straight away. Thank you so much.
I request Dr. Anupam Jaina, sir, if you're here, as the moderator of the first session. Also, I would like to invite the honorable chairpersons, Dr. Monotosh Paja, sir. I request her to please come on the dais. Dr. Anil Mishra, sir, to please grace the session chair. And the panelists of this particular session, Dr. Shupradeep Kundu, Dr. K.N. Siddiqui, Dr. Varun Sibbal.
First of all, let me thank Dr. Dilip Kumar for organizing such a wonderful conference. I think it's going to be educative. Structural heart disease programs have taken off fairly well in all hospitals in Calcutta and around. I think there are a lot of people now doing these interventions. And it's very important because when you do TAVR, EVER, etc., when you graduate from EVER to TAVR, we are not worried about the valve so much if it's an uncomplicated case, a usual case. We are more worried about the vascular access, because most of the complications I find is related to vascular access and closures and other things. So this is a very hot topic, and we need to understand that if you really want to have a successful program with structural heart disease, you really need to have a good access to the vessel, main vessel, and of course, good management of the vascular access site as well. It's a very important topic. We know about 7 to 8% complications related to TAVR are related to vascular access and so on and so forth. There are various techniques. I'm going to ask one of the speakers to really discuss that in details. We have angiographic, we have ultrasound, we have combinations, we have wire-guided, etc., etc. So I won't go into details. And I request my co-chair, Dr. Manatosh Pandya, to say a few words.
So I am happy to introduce Anupam. He is very dynamic interventional cardiologist in India. And you know that the subject today mastering the large bore access. During, you see, 30 years before you have published the balloon dilation aortic valve is percutaneous, and our postgraduate used to compress, I think at least half an hour to 40 minutes. Then Ilan when come, the first case is done by the TAVR, and that time there is that all these recent technique and not available, and is also mechanical compression is the hazardous and complications. So everything come across, so everything nowadays is available. Now it will be presented. Dr. Jana, please come forward to present your article, sir. Oh, Greece, okay, change the subject. Dilip Kumar. And Dilip, Dr. Dilip Kumar, actually I am proud of him, and he used to work with me during postgraduate student under my team, and he's very dynamic. So he used to do how to learn the intervention. After death of the patient, he's trying to get the venous subclavian punctures. I'm Dilip, what are you doing? We are practicing. So therefore, at that time, we understood he will be a great interventional cardiologist in India. Dilip, you, please go present your.
It's a matter of honor to present before you, sir. So we are before time. Our first session was to start at 9:45. We have started 9:42. And where is Anupam? Anupam, he has to moderate the session. Anupam, please. So the format is like this. The 15-minute session, 9 minutes will be presentation, and 6 minutes discussion will be totally guided and maneuvered by the moderator of the session. So we have each session we have moderators. 6 minutes is for you, Anupam. You have to guide and ask questions and take everyone's comment and insights. So we'll go ahead. This is large bore access management, where we start the Structural Heart Summit, and these are my disclosures. So in fact, these two angiographic pictures, we can make out what was the problem. In one, there was a high puncture, and you can see the bleed. And the second, it was a low puncture, and below the femoral head. So, and sometimes you require cover stent to manage these situations. So idea is to avoid these unnecessary problems and hassles by exactly knowing the anatomy and guiding the procedure well in a safe manner. So this is the site of the puncture has to be in the middle of the head of the femur, and we can appreciate the two kind of landmarks. One is the bifurcation of the femoral artery into SFA and profunda, that is the lower margin, and the upper margin is the inferior epigastric artery. And in the middle of the head of the femur, we can compress the vessel, and that is why it is important to locate that area and puncture there. And we can see here how the vessel is diving deep into the pelvis. You can't compress if you puncture little higher. So it has to be between the inferior epigastric artery and lower in the SFA, above the bifurcation. And when we look at the inguinal crease and then try to guide our puncture, it may fool you many times. You can see here you are looking at the femoral crease, but what you see here, in the fluoro, you are so lower down. So we have to combine your inguinal ligament surface anatomy with the fluoro marker if you don't have ultrasound guidance. And if you have ultrasound guidance, that is the best. So these were the days when we used to guide through angiogram, the puncture. And now we have many evidence which supports that ultrasound guidance is far better than the fluoro punctures and any other way of doing that. So you can see here the femoral head and the bifurcation. This is the longitudinal section. You located the bifurcation, you go cross section just above the bifurcation, and you can appreciate the femoral head. You can see the femoral head so well visible, and then once you make it cross sectional, you can see the circles, and the two circles goes into one, and there you puncture. The puncture has to be just at 12 o'clock. If you miss it or angle it, you are not going to close it properly through the prostyles, because that will not able to capture the vessel, the segment of the vessel appropriately. This is how we prepare the entire setup in a sterile manner. You can see the fluoro cover. We take jelly inside that. We take the probe inside, and then rubber band, or you can use gauze piece to just cover it, and then you are ready with the marker on the probe corresponding to the P which is there in the monitor. You go cross sectional after looking at the size, looking at the basically the place where you have to puncture. Now, and the distance has to be akin to the distance which you assume from probe skin to the femoral artery. That distance you maintain from the probe to where you are puncturing. And you can see here 12 o'clock puncture. And the vessel, the flow which comes here, it is not a spurt which we usually see in our femoral artery puncture. It will never come in a jet. It will come like this. And you have to take the wire, and the wire has to be taken inside in a under the fluoroscope. You can see here it is going this way. It can create problem. So you need to see where it is exactly going, and this advancement has to be under fluoro, the wire. So once we are done, we can reconfirm that we have punctured rightly, and this is the distance which I just told. We have to come little down when the patient is obese, and this is a case which I will just show where we had used 4 prostyles and 1 angioceal to manage. Just briefly, I think we have some time, 4 minutes. I will show run the video. This is the ultrasound guided puncture which we did, and both sided ultrasound guided puncture, because this was an endovascular procedure where we required 22 French access from left and 18 French access from right. So it was totally endovascular. You can see the bifurcation. Then we go a little up, and you see the circle here, and you can see the femoral This is the femoral head, this is the suckle, and then we are puncturing right at 12 o'clock over the artery. And then flow comes, you take your wire in, and after 2 axes, you need to see how we take the prostyle in. So prostyle has to go over the wire. You have to make the track before by dilating it with the artery forceps, because the suture has to go in and it should not be somewhere entangled inside the tract. So once you reach this wire exit port to the skin, you remove the wire, and this 45-degree angle has to maintain. This is one of the most important thing. Once the blood starts coming, you go to 11, because we are using 2 prostyles here, and then you lift the lever and retract the device so that it hinges against the wall. Then your plungers are down, foot plate down, then you pull out the sutures, give a quick cut, and then you go little in, the foot plate down, and then you come out, harvest the sutures. This suture harvesting is important. You don't have to change the relationship. It has to be clamped with a artery forceps together. If one is tightened with other, then this knot can happen in the tract, and then you can really fail. You may not push the knot to the vessel wall. And once you are done with this suture harvesting, you can reintroduce the wire, and you can here see the wire exit port is there. There is a two white markers. There is a exit port. So you reintroduce the wire. Please allow me when we are 8-9 minutes. And once it is inside, then repeat the procedure again with the second. You are done with 2 prostyles in the left. Now we are doing 2 prostyles in the right. So there are 4 prostyles we have taken. Now we did the endovascular procedure. So we have this, basically we have done the device. You can see here the endovascular graft of 22 French axis. We have done the procedure, and we are coming out. You can see here the upper limb is, the upper body is deployed, the lower ones are deploying. And once we are done, this is how we take over the blue wire. We take the knot pusher down. Yes. Knot pusher down. And since it was bleeding with 2 prostyles, we give 1 angioseal. So we have a lot of other talks are there. It will be amply clear to everyone how to deploy this. And then we could finally close with these 2 prostyles and 1 angioseal on one side and 2 prostyles on other side. And this is the final picture after the deployment of the valve. So this is the final result. You can see here, it's flowing well, the vessels flowing well, closed, and the result was good. Thank you so much for the patient hearing, and I hope we will have some more discussions in sides.
Thank you, sir, for the excellent demonstration of the entire technique, because everybody knows that the mortality happens from femoral complications most commonly. So, sir has already highlighted, but I would like to just quickly recapture that ultrasound guided has given us the additional advantage of puncturing at the top of the vessel, because we are very habituated to fluoroscopic punctures and tactile punctures, but we need to puncture at 12 o'clock for large vessels. Otherwise, this 16 French, 22 French, if we puncture on the side, we might miss some part of the vessel. Then just one more point I would like to add is that now we have Manta device also, where a single device is enough for the large bore access managements also. Thank you, sir.
So we can have some discussions, our chairpersons, Dr. Siddiqui.
Yeah, I think as we go, if you go by ultrasound guidance, older people are used to doing angiographic guidance, but I think a combination of both is what is really most accurate, because in ultrasound guidance, sometimes in almost 20 to 24% of cases, there's a high bifurcation, and you may really miss the femoral head at that time. As you said, you can see the femoral head sometimes, but sometimes it may not be very well seen when people are obese or something. So at that point, angiographic and ultrasound combined together may have a better option sometimes. And that is what I tend to follow more or less, most of the time.
Sir.
Dilip, on another thing is the under fluoroscopy control and micropuncture, very useful technique you used to do before also. Thank you very much
Sir,
indeed for presenting.
one more point needs to be discussed. What is the flip side of ultrasound guide puncture? Maybe Dr. Rajiv, Dr. Anmol, Pratap, anyone can give their comment. Flip side of ultrasound guide puncture. You see any flip side, or what we see that it's 100% the way to go?
As I said, higher bifurcation. That's the one main.
Any other points in the field? Yeah.
Let's make it in another way. What are the common mistakes we make during ultrasound guided puncture?
Yes.
Yeah, I think. Yeah.
This is drastically, this way they drastically reduce the rate of peritoneal hematoma. This is very advantage of that thing.
So can I comment? So one thing we need to be very careful about doing when we are doing the ultrasound guided puncture, that we need to see exactly the tip of the needle, where we are actually puncturing. So you often don't see and go on puncturing, then you are not actually puncturing on the right point. It may be up or it may be down.
Yes.
So it is important to visualize the tip of the needle, that it is indenting on the 12 o'clock of the artery. So that's one thing we need to keep a mind on. And second, I would like to emphasize that when we are putting the prostar, it's important to make the track as well with a forceps little bit. Otherwise, you would not be able to push the knot down up to the arterial wall. So making a little bit of space is also important. So these are the two things that I would say.
Yeah, I guess as rightly said, the groin is an Achilles heel for the structural heart because it is a large bore. So my usual take is whichever technique you are doing it, but master it first. Don't try to flip on one axis technique, then another axis technique, and not master of everything. So whichever technique you are good at it, confident and reproducible, you should do it. Ultrasound, yes, it is a learning curve, but you should learn ultrasound guided technique. It is very useful. And calcium, sometimes if your angle is little tilted and all, you might miss an entry wall calcium. So you have to be little more careful, because if you take a proglide or prostyle in that calcified area, there is a good chance you might fail with your closure. So you have to be more careful.
Yeah, excellent point. So in line with that, the previous comment and this one, normally our practice is to put around 1 centimeter cut in the skin and then to properly dilate the subcutaneous tract so that we can really deploy the knots at the vessel wall. And another advantage we have is the pre-procedural CT. From the pre-procedural CT, we have a fair idea where is the bifurcation, how is the calcium distribution, and that also helps. But ultrasound, the flip side is, I think, a learning curve. We have to do some cases imperfectly to learn.
I think Dr. Mishra sir and Dr. Majumdar and Dr. Anmol clearly highlighted. If we are not looking at the proper things like tenting, the vessel has to tent 12 o'clock. So it is indenting. It means you are puncturing there. So if you're puncturing and blood is coming, but you can't see the tent, it means you are not puncturing at the site which you are seeing. That is the flip side. And I think Dr. Menon will also give a little more insight. So it can be combined with your fluoro. Exactly, once you are there, just in fluoro, that you are in the same, you are not going beyond the femoral head or lower down. Yeah, Dr.
So, just add one point here. Since you are often having a second axis, suppose you have a left femoral axis as well, you will put a J wire right at the femoral head where you want to be.
We can do
and that can be seen in ultrasound very well, and that could be a good guide as well.
Yes.
Yeah, few things which we are doing differently nowadays is one, CT, we are trying to actually look at the inferior epigastric also. So we know previously we used to just check the bifurcation. Now we look at the inferior epigastric. So we know exactly where we want to puncture on the femoral head. So as Dr. Siddiqui just mentioned, our general practice is always first localize on fluoroscopy because we are more comfortable. We just make sure where the femoral head is, and then use the ultrasound to make a puncture at 12 o'clock position. The second thing is slightly scraping the needle so that it's a big challenge. Many times we can't see the needle tip, and that makes a significant difference. But this CT planning to know exactly where we want to puncture has significantly helped us in trying to know where to do it. The last point is, nowadays we have gone to ProGlide with one angioseal, but in case when we are using two ProGlide, initially when we started off, we used to go at around 10 to 2 o'clock position. Then we realized that the chances that you'll develop a stenosis are much higher. So the concept is the closer we are, the knot is more tight, but it doesn't cause stenosis. So now it's 11, 1 o'clock, or probably even narrower than that, in case we are using two ProGlide for the axis.
So this is the thankful to Dilip. Our basic aim to puncture the common femoral artery above the bifurcation of the promontory femoris and superficial femoral artery. It can accurately puncture and prevent the various complications of the large bore. Thank you very much indeed, Dilip.
Thank you.
Big round of applause for our honorable chairpersons, our moderator, as well as all the panelists, as well as our speaker. We move on to the next session. So the next session, I would like to invite Dr. Anmol Sonaved, sir, as the moderator of the session. The chairpersons, Dr. Dipankar Ghosh Dostidar, sir, I request you to please come on the dais. Dr. Ranjan Sharma. The panelists of this particular session, Dr. Shondipta Roy, Dr. Nilesh Giri, Dr. Shubir Ghosh. I request the moderator to please start the session.
Okay, I'll invite Dr. Menon, Raju Menon, for the access site complication. I think we all learned about the puncturing and getting into the access, but it is equally important as being it is an Achilles heel for the structural and large bore access techniques and procedures. We have to know how to maintain and close that access also. It is not only getting in, should be right, but you should come out also rightly without any problem. I'll tell Dr. Raju to start.
Good morning, everyone. Thank you, Dilip sir, Panja sir, everyone for having me here. So next 9 minutes or so, we'll look at the complications. I think the stage was well set with Dilip sir actually telling us how we should do. And when we don't follow that, we'll see what happens. So before we start off, a few disclaimers. One, this presentation is not for weak-hearted. So anyone in the audience has some vulnerable plaque, it's better they step out at this point. Now, not all complications which I am showing are done by me, but at the same time, not all salvages have been done by me. The most important buzzword here is teamwork. So it's the teamwork which saved the day for us repeatedly. And touch wood, fortunately for us, we have not had any on-table mortality till now. And hopefully we'll continue with that safe practice in TAVR. Now, all of us know there are multiple complications which occur, and vascular complications in general are considered to be around 1 to 2%. And this is what we are going to discuss today. Now, how do we prevent? So the management is the second part of it. The most important aspect is prevention. So very detailed CT analysis where we look at the diameter, the calcification, the tortuosity, and if there's any dissection. Now, many people have a wrong concept that once we have done the CT analysis, ultrasound is only to find out where we need to puncture. That's not true. Ultrasound gives a lot of significant information. We can see the plaque, we can see the calcium. Many things which may not be clear on CT, you might actually see when you're doing the ultrasound. So do a detailed ultrasound before you actually find out what is the site where you are going to puncture. Then always do fluoro during the procedure, one, to know the puncture site. And as was mentioned, the most complications of micropuncture occur because you tend to push the wire without doing fluoro guidance. So always do it under fluoro guidance. Do an injection, always follow the protocol, don't violate it, and don't push against resistance. After the procedure, always wet ProGlide. So this we learned the hard way. If we have surgeons in the audience, they will tell you that always they keep the sutures wet so that they don't break. And you have done a fantastic TAVR procedure. You are in the last step, you are just tying the knot, and that's the time when the ProGlide snaps. The reason is because you have not wet the sutures. So always make sure that the ProGlide sutures are wet before you close. any place where you are suspecting that this patient might have a vascular complication, always put a safety wire V18 and always go for a dry closure. You have everything in control. In case if some problem occurs, you can always come out of that situation with a surgeon's help. So we'll look at some of these examples. Now, a common misconception again is the French, when the company people come to you, is the inner diameter. What we are looking at is the outer diameter. So if you look at the outer diameter, generally Navitor has the best. Then you have the Evolute and the Accurate, and KPN is around 5.5 to 6. So keep these numbers as a rough estimate, below which you should not actually try to use that particular company TAVR valve. Now, what about calcification? Now, you might come across a CT which has a calcification like that. The question is now, should we go transfemoral here or should we go to alternate access? So there are a few things which we need to look into. One, the length, the circumference of the calcium and the lumen, in addition to the tortuosity. So if you see here, the length is more than 20 mm, the circumferential calcium is around 270 and the lumen is around 4 mm. Now, based on that, how do we decide? So if the length is less than 20 mm and you have 270 degrees calcified lesion, then about 3 mm is sufficient for you to go through. If it's 360 degrees, more than 4 mm. If it's more than 20 mm, you add another 0.5. So if it's 270, 3.5. If it's 360, around 4.5 mm. So keep these numbers in mind to go with transfemoral. If it doesn't fit into this, then you try to go by an alternative access. So in our case, it was more than 20 mm, but it was 4 mm, so we could go transfemoral. And always go with upfront IVL in these type of situations. So this was a 7x60 IVL balloon. And after that, we go ahead with a semi-compliant balloon. When you can see here the V18 wire which is there in place to make sure that things are under control. You do a dry closure, and when you follow all the steps, you get a pristine result like that without any complication. When we try to violate something, that's the time when we get into a problem. Now, what about tortuosity? When you have tortuosity, always use the less tortuous vessel, use a stiff wire, pre-dilate with dilators, even if it is a balloon expandable valve. So that will help in putting the sheath in. Always make sure you keep a safety wire, go ahead with a dry closure, and don't push against resistance. Now, pushing against resistance, I'll just take 30 seconds here. You can actually see the operator pushing this particular sheath. This is a 18 French Cook sheath, and you see what amount of force he is using. It's almost as if the whole of aorta, iliacs, everything is moving along with the sheath. And he continued with it in spite of that resistance and didn't stop. And almost all the way to the aorta, that pressure was put. And so what happens when you do something like this? Your heart stops when you see a complication like that. So this was a complete rupture, patient cardiac arrest, on cardiac massage. By God's grace, somehow we managed to salvage this patient, but never push against resistance. Now, this is a V18 wire. So the advantage is it is a 018. You can just keep it there and continue with your procedure. And you can push in all the balloons and stents over that. So this is a great safety mechanism. And whenever you are suspecting that the patient can have a complication, this has to be the first wire which goes in. It has to be the last wire to come out. So don't, again, prematurely pull out this wire. Again, you land into trouble. So after you have finished everything, that's the time when you come out with this V8 wire. So after preventing, in case you land into complication, how do you manage? So know your hardware. Management depends upon what complication you're dealing with, whether it is stenosis or whether it is a perforation. Again, you have some coils. These should be kept on your shelf. These are the glues. We mix the Zoin along with the poppy seed oil to make the glue. And the Prograde is the microcatheter which we commonly use. It's usually used in neurointerventions and it's readily available. Now, Coda balloon is a fantastic balloon. It is like a normal balloon which we use in birthdays. So whatever the diameter of the vessel, it tends to expand. So it has a big advantage. The other balloons like Armada can be there to immediately develop a tamponade. Now, you should know few hardware. This is the Fluency, which is self-expandable covered stent. Now, this is a protective cover. So at least you should practice once how you remove the cover and pull back to deploy the stent. The reason I'm telling is first time when we did it, we didn't know that we have to remove this. And all of us were struggling and the patient was bleeding there and we had a narrow escape. So make sure that you know your hardware, how to use that hardware. The graft which we are using nowadays is the Bentley graft. It is a very flexible graft because you're putting in the iliac. Most of the other covered stents, they can fracture over a period of time, but Bentley has that advantage that it's extremely flexible. So these are some of the things which you should have. When you have a wire perforation, something like this is an inferior epigastric artery. You can see the leak which is there. And then you go ahead and put a coil and glue, and then it closes. Now, a question which arises is, do you do a CT angio first or an angiogram first? Of course, if the patient is unstable, you have to do angiogram. But the advantage of CT angio is it can identify a bleed of about 0.25 ml per minute. Whereas if you have an angiogram that can identify only 0.5 ml per minute. So when the bleed is very low, you might miss the bleed if you do only conventional angio. So this is a great example. We had a patient who developed a hematoma. We were not able to identify what is happening. So you see the venous phase and the delayed phase, you can see the leakage here. But you do a conventional angiogram, you can't see an inferior epigastric leak. So here you prophylactically put the coil and glue. So if CT was not done in this case, we would have again come out thinking everything is all right, and we would have missed an inferior epigastric bleed. Now, once you have a rupture, the easiest thing is to first push back the sheath so that you have some time to think and then decide what has to be done. Do a balloon tamponade, put a Lima catheter, exchange length wire, stiff wire, Balkin sheath, and balloon or stent. So this has to come automatically. That's the Balkin sheath there. And you generally go by about, I'll just take 1 minute. I'll just take one more. You go with a 20% oversizing. This again is important. Generally, the iliacs are around 7 to 8 mm and femoral 6 to 7. So you oversize by about 20 mm. So this is just to show you a CFA bleed. The Balkin sheath is there. You cross over. Once that is done, you put a stent, and you get an excellent result once the stent has been put. What about stenosis? This again happens when you are overzealous while putting the ProGlide, and it catches the posterior wall, and then a thrombus can form over that. You gently balloon dilate here, take about say 4 mm balloon or something. The idea here is not to get a perfect result, but make sure that flow is established and there is no limb ischemia which is present. So that's how it looks like once you have done the balloon dilatation. So this is a comprehensive approach to complications. Suppose you have a ProGlide failure. First might be just put back the sheath and do surgery. Now, second ProGlide is present, yes, then you can use that to close. If it's not present, you do a balloon tamponade. Again, perforation, push back the sheath, call your surgeon, he'll just put 2 sutures and it will close. Balloon tamponade fails, covered stent, everything fails, surgery. If you have stenosis, you do balloon dilatation. And Manta device is something which can be used nowadays. So the take-home message would be vascular complications post-TAVR can range from relatively benign to life-threatening. Careful CT analysis helps in mitigating. Percutaneous therapy we should be abreast with and use in the Cath lab. And surgeon is your greatest friend in the most hopeless situation. I would also take this opportunity to welcome you on July 18th and 19th, where we'll have our second session of AAG Structural Master Class, which is a different kind of a program with hands-on training. Thank you so much.
Excellent presentation, sir. So access site, taking the proper access, and then the to prevent the complication is the most important thing. That V18 wire, putting the V18 wire, that just take extra 5 to 10 minutes, but that save your life later on, because sometimes if there is any trouble later on, the patient might be having a bleeding, and then it would be a panic situation. And in those panic situation, then we have to cross over and from the left to right or right to left, and then we have to put all the way the stiff wire, and then this is all a panic situation. In those situations, the patient might be losing the patient. But that putting that V18 wire, O18 wire, just keeping it contralateral side, and then putting the balloon or the covered stent, whatever you want, we can do it. It saves the time, it saves the patient. So excellent presentation. We can have a question from the audience or the panel.
Sir, one question. When you are putting in covered stent, do you care about branch loss, like profunda is getting off or inferior epigastric is off? What are the consequences?
Generally, profunda we won't put across the profunda. There we'll go more for a surgical repair. But inferior epigastric canal, we are not much worried because there it's a life-saving procedure. go ahead and then put
You
it.
are encountering resistance. So what do you do then? You take out, once you are pushing and you feel a lot of resistance, you take a smaller diameter dilator and then go ahead, or?
Yeah, we need to first think why that resistance is there.
There can be, the artery may be deep dive into the pelvis.
Yeah, so that's a very important point. So in addition to the diameter, the other thing is how is the tortuosity and how is it dipping beyond the femoral head. So many times the reason for proglide failure as well as the ruptures will be because the bend is so tight and the sheath is not going in, and that actually causes that friction and causes a rupture. These generally happen with hook sheath. So in case if you have the Medtronic sheath, if you have the Centron sheath, that's almost like the Edwards sheath. So if we are having some resistance, always better to use that sheath. Now the advantage of Medtronic inline sheath, we have done away with 18 French hook sheath. Hardly, probably we have never used 18 French hook sheath. So automatically the vascular complications come down. But we can change the sheath, or just give yourself 1 minute and think why it is not going. If you know the reason, then you can find how to correct it.
Rajiv, excellent presentation. You have covered everything. I just want to make few points. See, we don't have to be just an intervention cardiologist. We have to be a good peripheral interventionist also. So you should be very well versed with all the hardware, technique, and everything. And that should be not available on call. It should be on the shelf. When you are taking a borderline cases where you are anticipating a growing complication, safety is first, because it is, as I always say, it is an Achilles heel. Even after the best TAVR or a structural case, you might land up into the major complication. I just want to ask you one question. Like majority of the centers, what I have seen, when you close the groin, you close it on a normal O35 wire or a stiff wire?
So our closure, generally we do it on a O35 wire. Again, it depends upon what we are suspecting. Many times even the proglide, we'll have to put it on a stiff wire. So suppose we are in a situation where we are expecting the significant tortuosity, we might lose the access or we may not be able to hold. Then we generally try to put stiff wire up front.
Okay.
But
so,
if it is a straightforward, then we use the O35.
Yeah, so just wanted to make a very important point here. See, we always try to close the first proglide closure on a stiff wire. While removing the sheath, the large bore access, majority of the mortality are mainly because of common iliac problem, either rupture or perforation or everything. Even if you have a complete mess at the puncture site, the patient usually don't die. So always make an habit to pull the sheet down just above the femoral head, take a shoot, check the hemodynamic. If the patient crashes and BP drops, you already have messed it up at the common iliac level. If you are already doing it on a stiff wire, just forward the same sheath ahead and you can tamponade it. Just remove the dilator, take a cover stent from the same sheath, just withdraw it and put it there. So it makes your life easy. You get a good amount of time and it makes the procedure very simple. But if you are doing it on a normal O35 wire, then again to do a lot of exchanges and all, you lose a lot of blood and everything, and it is a chaos. So that is the only important point I want. You should first closure of proglide should be on a stiff wire. Switch it on a shorter sheath, 6 French or 7 French. Then pull your second proglide or a angioseal, whatever you want to do it.
Yeah, I have 2-3 points. So I think we have all been doing safety wire technique, but I think time has come up even with one radial femoral access, many centers are doing. So V18 is now a choice. It always gives you a security, and that you can quickly do that. But the same technique, when there is a bleeding, you can quickly put the same dilator and sheath inside, you tamponade, and then you can do ultrasound guide puncture, you can do everything. And second is, once we go, especially as a proctor, we ask that we have to cover stent. Yes, it is available. But once you go there, the size of the vessel is 6 and they have got a cover stent of 5. So that should not happen. One should be very clear that, okay, if you are going to intervene this patient, this size and dimensions, cover stent should be available. So any choice of balloon expand before we end, before balloon expandable and sub-expandable cover stent for that. So I don't think there is any kind of liking or disliking, but both should be okay, isn't it?
Yeah, generally balloon expandable nowadays, I think we are.
I have one question. Of using only single proglide device and then removing the sheath later, because that is also the practice which is coming up. because of the navigator valve and the E-sheath.
Sorry, I couldn't get your question.
So using only one vascular closure device, like one ProGlide, and then removing the sheath later, is it there in your practice?
So that's the institutional preference. Generally, we base it on the vessel diameter nowadays. Our go-to strategy is to use one ProGlide and angioseal. But there are times when just with one angioseal you can close the vessel, especially short ladies, small annulus, those kind of patients who have small femorals, just one ProGlide will be sufficient. I don't think it's very rare that we use two ProGlide nowadays. But that's a safety mechanism again. In situations where you are suspecting there could be a vascular complication, it might be better to put two ProGlide up front so that one fails, the other you can use it.
So, suture failure, what do you do?
That's a very dangerous situation actually. So we just press and then call the surgeons.
We can.
Hello.
We can have last question.
I have one question, the very simple one. Do you give anything to the patient before admission so that they do not develop constipation during hospital stay? I have seen cases where devastating complication had happened after a very good procedure.
Correct.
Because of constipation and straining.
Okay. So upfront we actually give some laxatives in the night, at least some Diflac or something in the night we keep.
It should be started before admission.
Correct. No, actually we have seen one patient where the closure was good and after 24 hours they developed because of this.
See, I think I'll just try to answer his question. The suture failure, it is as Dr. Rajiv said, a very devastating situation. So here is again an importance of a stiff wire. See, if you remove completely and just pull the suture and everything, you lost the access completely. Then it is a completely messy situation. You will keep pressing. By the time surgeon opens, it is a torrential bleeding and it is a messy situation. So always try to maintain an access. And even if your suture breaks, you can just, if your stiff wire is in the place, you can advance your stiff sheath again, 14 French sheath again, and have a tamponade by a time. Then do crossover and everything. If your puncture is good, you can safely cover stent, put a cover stent. If at the bifurcation, send for the surgery with a tamponade effect.
In the interest of time, we will move on for the next session. Yeah. Thank you.
Thank you so much. Big round of applause for our chairpersons, moderator, panelist, as well as our speaker. We move on to the next session, of course, after this group photo. I would like to request the moderator of this next session, Dr. Anil Dhal, sir, to please come and take the dais. The chairpersons of this particular session, Dr. Rana Rathore Roy, Dr. Shumanta Chatterjee, panelist, Dr. Kaushik Dashgupta, Dr. Dipankar Ghosh Dastidar, Dr. Shupradeep Kundu. I request all of you to please come on the dais. I request the moderator to kindly start the session.
So can we have Srinivas? So this is a very important topic as in continuation of the last session, which is largely for vascular closure before, during and after the procedure. And I think we all have many questions in our mind, and I would urge everybody to ask those questions. Actually, can we get him? No, we can't hear you. Either get this.
Is this fine now? Yeah, good.
Yeah, now it's okay.
So good morning all, and thanks to Dr. Dilip for inviting me to this session. So today's the first talk is vascular closure devices. I'll just try to brief upon various aspects of this vascular closure devices and troubleshooting in main, because that's the one which we all are worried about. So when to use vascular closure devices? These are primarily used to achieve rapid hemostasis after the procedures requiring arterial access like cardiac catheterization, angiography, PCI or TAVR. Primary goal is faster hemostasis, reduced time to ambulation and discharge, and improved patient comfort compared to manual compression. Who are the ideal candidates? Patients undergoing any diagnostic or interventional procedures via common femoral artery, patients at risk of prolonged bleeding with manual compression, especially obese patients or on anticoagulants, or specific devices are available for use in large arteriotomy when you are using more than 8 or 9 French sheets using per-close or pre-close techniques. Contraindications, if at all, if you have done a puncture site below the bifurcation or above the inguinal ligament, then not to use this vascular closure devices. If there's a significant peripheral artery disease, severe calcification, the puncture site, or existing local infection, better to avoid or exercise caution. Morbid obesity or unusual anatomy where device cannot be properly deployed, extreme angulated tortuosities should be avoided as well. So which device to use? Broadly, they can be categorized into active closure devices as well as passive closure devices. Active closure devices are where the devices actively approximate the vessel wall or deploy a mechanical seal or a suture, providing immediate hemostasis. These are basically suture based. It can be a pro-glide or a pro-style. The mechanism is place a suture to mechanically close the arteriotomy. The pros are it's versatile for both small and large bore closures. Single or double techniques leaves a minimal foreign material intravascularly. Cons is it requires a good skill and anatomical knowledge. The other one is collagen based. So basically it deploys an anchor against the inside vessel wall and a collagen plug in the extravascular space. Very fast hemostasis, less operator dependent. Cons is it can leave a foreign material inside the vessel, so risk of distal embolization if the anchor dislodges. So re-access can be complicated if it had to be performed too soon in the same spot. So people say around 30 to 45 days you need to avoid accessing at the same spot. So clip-based are no longer available in India, so I'll not talk about it. The passive closures are the one which most of our cath labs have started using this as an access.
Constricts the wound along with the blood vessels and the surrounding tissue.
So what I'll do is I'll not go into the mechanism of those things. In summary, we have an intravascular as well as extravascular devices. So what we all know is suture-based devices and collagen-based devices are a patch or membrane-based. There are various devices available. The most common we all use is a ProGlide, Manta, and AngioSeal. So these things we should know in detail, like how to use. Of course, our own indigenous Merrill Subtura and Aptura Neo is also there. And even they have a ProGlide version as well. So again, this is the various animation videos. I'm sure these are available on internet and YouTube's. One can go through and refine your techniques of deploying it. I'll not go into detail of these things. So there's an AngioSeal. If somebody needs this presentation, it's already there in the deck. You can collect it as well. So various ways of deploying various things. We'll come to the major discussions. Why use VCDs? We all know the advantages. Faster hemostasis, earlier ambulation, reduced staff time because it frees up your clinical staff from prolonged manual compression, and lower complication rates. What is most important of this talk is troubleshooting and complication management. This is all we need to know. So if at all, when you're using a ProGlide and if there's a poor arterial flow or no flow, what does it mean? It means that the ProGlide is still not inside the vessel or the marker port is against the vessel wall. Do not deploy the ProGlide with the vessels less than 5 millimeter, or it could be because of the side wall stick. So gently rotate the device to move the marker port off the vessel wall, you might get it, or the patient might be having a significant hypotension. So slow drip might be acceptable in that case, but ensure that the BP goes up before you start actually deploying your suture. Or sometimes it could be a clot or tissue plugging the marker porter, because most of us don't give apparent before we actually get a big large bore access. So sometimes device itself is not in the lumen. So drip can occur when the marker port is near the vessel lumen, but not completely in the vessel. So continue advancing the pre-close or per-close until the brisk pulsatile flow is observed. And also the other important thing, you might see that already you have entered the skin, but the blood is not flowing because there might be a lot of obesity, and major portion of your ProGlide might be in the subcutaneous tissue because of the Z tracking. This is one important thing which we all should look into. The other thing is a cuff miss. So when you withdraw, you see that there's no suture present in the plunger withdrawal. So tips of the needle did not lock with the cuff. Why is that? Either the tissue is too thick and the needles cannot lock the cuff. That is, there is a significant atherosclerosis in the vessel is diseased, or you're not advanced it enough, or probably you are at a very bad angle and you need to change the angle or rotate or clocking. So whatever it has happened, so the resolution is insert the wire, exchange for another device. You cannot use the same device again. So device failure and persistent bleeding. Somebody was asking about this. Apply immediate manual compression. If you had a stiff wire, obviously you can go to the other side, identify what is exactly happening and do. There was also a debate like, should we ask the vascular surgeon and closure, especially if there is a rupture or a major this thing. And what about the side branch loss? Whatever cases I've seen, both proctored as well as the institute, across the hospital, across the India. So whenever the vascular surgeon gets involved, the repair, even though whatever it is successful, 1 in 4 cases do have a prolonged stay, prolonged morbidities, limb is very much swollen, patient is in a pain. If at all, if your puncture is at least 1 centimeter above your bifurcation, don't worry about the profunda. You can go ahead and place your covered stent over the femoral puncture head, because the rupture is one thing which vascular surgeons also may not be able to localize at that site when the patient is actually in a hemodynamically bad shape. Occasionally, I've seen people closing off profunda artery also, and the patients are doing well because most of them are very elderly and their activity itself is limited. Having a profunda occluded and expecting the patient to develop a claudication is too long thing. So if they're already 80 years plus, I think sacrificing profunda is always okay in comparison to sending them for a vascular surgery and so on. The other dreaded complications of foot break, it has occurred to me a couple of times. So potential causes are either somebody has rotated or rocked the device excessively, or it is a shallow deployment. So the third thing is, what you can see is basically there's no suture or link, or sometimes only a link or no suture, or sometimes a missing foot plate. So this is what you can always see, and this is where we start potentially think about the foot break. So prevention is always ensure that the angle of deployment is not less than 45 degree. It should be at least between this 45 and 70 degree. Raise the device and maintain an even and gentle tension before even applying the suture. Press down in the plunger with a gentle increasing pressure to advance the needle, because if there is a small calcium speck, your needle can get deflected. And that might be one of the cause for these things. So device entrapment is another thing. Sometimes the foot plate gets in, but it is not coming out. So this can be because there is a separation of the proximal guide and the distal guide. So what you need to do is, or there could be malfunction of the liver foot wire control, and you'll be unable to close the foot due to tissue interference. So what generally we can do is, when the foot plate is not coming out, rather than trying to pull it out, try to use an ultrasound. Look at this. We can see that the foot plate is stuck here. We are trying to visualize this. And what we noticed here is the foot plate is behind this posterior wall calcific nodule. So what has happened is, at the puncture site, there was a plaque below. And without knowing that, or without looking for that, we only concentrate on the anterior location and we try to put the foot plate. And when the foot plate is coming back, it is catching the posterior plaque. And this is where it can come back and start suturing both the things together. And you can have an issue like an steno artery at the end. So ultrasound guide can save a complication. The other reason for device entrapment is you are unable to pull back the foot plate completely or remove the device. For this, what we did is we also tried some manual methods externally. So you can manually disengage the proximal and distal one, and you can try to open up with an artery forceps. Once you dislodge these things or dismantle these things, so what you can see is, you can see that the foot plate is stuck in an open plate here. What we are trying to see is if you can manually unlock and lock the device. You can see the foot plate is stuck in an open position here. What we are trying to do is hold both the ends together and try to push this and manually close this foot plate. So in this way, you can release the foot plate and then take out the entire device, and probably you can again take a new device and do that. Suture breaks. Suture may look thin and elongated. Rail or non-rail limbs can be broken. Prevention is keep the suture limbs coaxial to the suture trimmer and tissue. Do not pull laterally or medially on the suture. Always should be coaxial. Lack of hemostasis can be because of incorrect order of knot advancement. Sometimes locking the second suture instead of the first can happen, or it could be because of the tangled suture. So this is one of the reasons that we say that once you deploy a ProGlide, you should ensure that there's no suture slack inside the wound, and suture should be kept in a tight one and wetted, obviously. So current practices of mine is one suture-based VCT followed by collagen-based VCT, if at all if needed. So if at all, if the major trauma, obviously retroperitoneal hemorrhage, other things has to be managed surgically or with a covered stent. One of the unusual cases, it was closed so badly, catching the posterior wall. There was a calcific block also. They had to use a rotablator, and this was published in 2025 in Journal of Invasive Cardiology. Infection is one more thing which we need to be mindful of, maintain sterile precautions as much as possible. So right now, my practice is, what I do is after my procedure, over the stiff wire, I will reinsert my microsheath. And with the ProGlide tightened over the microsheath, I take a micro injection over here. If the sheath is good, if there's no ILL perforation, anything, I just tighten this VCD or repass a wire, close this ProGlide, and then put an angioseal and then come out. So this has been my practice now. So I'll stop here. I've run out of the time. I will take another couple of minutes.
So, but you would still concede that a good closure begins with a good access.
Exactly.
So I think all of us need to be sensitized on the fact that evaluating the vessel, and you've very rightly pointed out, it is not only the anterior wall that you have to look for calcium, but also on the posterior wall. That is a very good representative case which you actually pointed out. So there are a few questions in everybody's minds with the surfeit of choices available today. In your practice, is it always a ProGlide or whatever its iteration and an angioseal, or do you think you waver from that and try some other devices like a Manta, or when do you do it, when do you not?
Okay, so single access Manta, sometimes we do use it, especially when I use a newer valves like a Vienna or something which a bigger sheath. But if at all if somebody has got a peripheral arterial disease or somebody is needing a multiple other interventions in the future, I try to stick to the suture-based devices, because in the suture-based, if at all if there is some re-access is needed, I can always re-access even within few hours.
More control.
Sir, how do you decide the number of ProGlides you are going to use in that case beforehand?
That's a good question, sir. If at all, if my vessel size is more than 6 millimeter, and if my puncture is very neat and above, and when I take my first micro injection after putting the micro sheath, if things are very stable, there's no posterior calcification, I generally go with a one suture, one angioseal technique. If at all, if the vessel is slightly lower side, say less than 5.5 millimeter, I don't want collagen or anchor to be inside the vessel and cause a distal embolization on an already compromised vessel. In those cases, I preferably use a two suture-based techniques, that is two ProGlide or ProStyle.
Any questions? Your point regarding the profunda is a very interesting point, because it has harassed me for a very long time. And then you go back to the basics and understand that critical limb ischemia requires 2.5 levels of occlusion. We keep teaching our students that profunda is like the left main of the lower limb. But at the same time, if your rest of the vessels are disease-free, and this is a life-saving or limb-saving measure, I would urge that you do save the life at that point in time, because it really saves a lot of vascular surgery morbidity which would happen. Any other questions?
Sir, suppose we are dealing with a patient who ultimately requires repuncture maybe in the future, maybe after 1 month or 2 month time. Then what should be our choice among this Manta or the ProGlide or the suture techniques?
So any collagen based, after 45 days of a user, you can re-access it.
Yeah.
I don't know how many of you have done a puncture in a collagen based vessel access at the same site. If you have done it, puncture is okay. Putting a 6 French sheath is okay. If you want to put a bigger sheath, there will be huge resistance. It will be like as if like you are going through a ligament. That you should be mindful of. So if at all, if you really need a bigger bore again, you need to dissect the soft tissues or a subcutaneous tissue and then track your device. I generally do a serial dilatation in those cases. Put a 6 French dilator, then a 7 French dilator, then take the bigger device, bigger sheath, whatever I want.
So in femoral and
And nowadays there is some other things because when you are dealing with angioshield and it's failure and if there is no wire, so it's almost over. So they are saying there's double wire technique. They put another wire there and then if it is failed, then you can do another wire, another angioshield.
So that only leaves some more small hole there and somebody has to manually compress. The very purpose of VCD will be defeated. What I do is, if at all, if you need that kind of a thing, that is where I have changed my practice. So after my ProGlide, so when I'm about to close my ProGlide, I put a micro sheet, take an injection over the ProGlide which is being tight. Now I know my 14 French hole has become a 4 French hole. So, and if there's no leak, I can just remove this and tighten that. If at all maximum, if there is a leak also, it's a 4 French hole. All you have to do is a manual compression of 4 to 10 minutes.
Srinivas, any time you do one VCD with a manual compression is possible? One VCD with a manual compression. Earlier people were doing with...
So, yes sir, we also do an one VCD at most of the time. So, it's not like every case we do an angioseal or we follow with a collagen base. So, especially when we are using some of the self-expandable valves like a Navita, which requires only a 4.5 to 5 French axis, most of the times what we see is if the ProGlide is deployed well, that itself over a wire would have sealed off anything. Before locking the second suture, I remove the second wire also, lock it perfectly, and there's no bleeding at all. So that happens in almost 20 to 25% of our cases.
Sometimes in femoral angioplasty, when we use 7 French or 8 Frenches, there is hematoma around the sheath. In those cases, do you prefer manual compression or you need some muscular?
That's a good question. So that's a practical problem as well. So once you put a sheath and if the vessel is diseased, there is going to be a perisheath ooze. Or if you're using an aux catheter, obviously there's going to be a perisheath ooze. If you identify it early, you ask one of your Cath technicians, somebody to keep it holding so that there's no major hematoma collection. If already some hematoma has occurred, then generally what I prefer to do is I put a bigger nick, drain out all the hematoma, then put the second one as a one more suture based this thing and place the axiostat inside that wound. It makes the entire blood oozing over there to clot over some time and then seals off everything. So there will be an axiostat also in that case. So it will be 2 suture plus an axiostat. I'm sure most of us know how axiostat works, right?
If there are no further questions,
from the please, can somebody get him the mic?
As there is a recommendation to puncture minimum 10 millimeter above the bifurcation. If there is a high bifurcation that is above it is touching particularly obese, very obese patient. In that case, how you do the puncture?
Okay. So that's a very good question. Like around 10% of the CTs, if you look at the vascular axis, not that bifurcation is always lower at an appropriate site. You can have as high as it is at the brim of that femoral head. So in those cases, look at the SFA's diameter. If that SFA diameter is more than 6 millimeter, then you directly puncture the SFA or go to another axis, like a different femoral axis, a subclavian and so on, rather than puncturing inside the peritoneal cavity.
So thank you, sir, for the nice talk. So thank you, everyone.
Thank you all.
Big round of applause for our moderator, all our chairpersons, panelists, as well as our speaker. Well, we'll move for a 10 minutes short tea break post this. Parallelly, there is a hands-on workshop, advanced vascular closure device going on parallelly. So we'll be joining back right after the break at 11 o'clock. We'll be starting the next session. Please come inside the banquet hall. We'll be starting our next session. I request all our doctors to please come inside the banquet and take down the seats. We're about to start the next session. Requesting all of you to please come inside and take down the seats. We are about to start the session 2. Requesting all of you to please come and take down the seats. We are about to start the session 2. I request all of you to kindly come inside. So I request the session moderator, Dr. Prashant Dwivedi, sir, to please take the dais. Chairperson of this session, Dr. Jayanto Shaha, Dr. Shubhro Banerjee. Panelists of this particular session, Dr. Madhurima Roy, Dr. Arya Chaudhuri, Dr. Shuprutim Nundi.
So the next session would be on how to do a step-by-step three-dimensional analysis. So we can start.
Turn it this way because we can see better.
Yes, sir.
So it's a little different kind of, presentation will be there. It will be a live three-dimensional demonstration, and we'll go to that. We'll have a discussion amongst ourselves, and we'll pick up smaller points where there can be some, misconceptions, and maybe you can point thing at wrong place and you get the wrong idea of dimension, and entire procedure can be in trouble. So we have Prashant, Dr. Shubhro Banerjee sir, Dr. Sinova Prasada sir, and myself will driving the discussion. So once patient of tower comes to us, we ask for a CT audiogram, and we can start with Prashant to what are the recommendations for CT acquisition of these CT protocols. So is there any kind of nitty-gritty smaller points to tell your radiologist?
So the CT tower aortogram is completely different from the CT coronary angiogram. We need to understand that the CT tower aortogram, it has to be a ECG gated. It has to be 0.5 to 0.6 millimeter slice thickness, and it has to be a contrast CT aortogram. And the ECG gated has to be at the level of aortic root complex. While we also need to look for the peripherals, including the descending aorta, descending thoracic, abdominal aorta, and then the peripheral up to femoral bifurcation. And sometimes the femorals are narrows, then we also need to evaluate the subclavian or the other axis like carotid and other axis.
So it has to be ECG gated.
ECG gated, that is very important.
And then Shubhro sir, about the contrast. So do you tell your radiologist if the patient is having a borderline GFR about the contrast, and what is the lowest contrast you have used so far in these tower protocols? So you can take this mic.
Yeah, I think what I do is if it's necessary, firstly you dilute it. You dilute it and give as less as contrast as possible. But having said that, I think giving contrast is inevitable. And what I do in that case, of course, I warn the patients and family and tell them there would be some rise in creatinine. That cannot be avoided. Anything else that you think you do in your case?
Can I add something to that, sir? So generally when we ask for a contrast CT, the volume of contrast used is around between 80 to 120 ml, depending on the body weight and the kind of an image we need. But there's a lot of innovations and improvements on the CT technology also. There's something called as a fast CT, which can scan in 2 minutes. And all they need is only 30 to 40 ml of dye. So in that way, the contrast amount has also come down. If your hospital has got that facility of a fast CT, go for that. And usually I try to image from the mandible to almost mid-thigh so that I cover all portions of the arch of aorta, branches, and also look out for the aortal rentaxis as well.
So once we order the CT is acquired, and then now the CT has come to us, and then we put it into the 3-measure software, and now the interface comes like this. So we will just go to do 3-measure analysis of a tricuspid valve and a bicuspid valve, and maybe a small valve-in valve. So we'll divide it in 15 minutes, 5 minutes, 5 minutes. So first, let's start with the tricuspid valve. Can we have a tricuspid valve to be there? And we can open that, and the analysis has to be done in systolic frame around 45%, because why do we take systolic 45%?
Yeah, so if you look at the cardiac structure, it's a moving structure. It keeps changing its dimension with every phase of the cardiac cycle. So aorta is maximum open when there is a maximum ejection. When does a maximum ejection occurs? It's in the peak systole. So the peak systole roughly corresponds to 30 to 45% of the cardiac cycle, and that's where we take those as the images.
So we take it 45, percent, because if you take at 10%, 20%, the aortic valve may not be open properly. You may not have a correct idea of annulus, which you are going to measure.
One more extra point I would like to add here is, it may not be exactly 45% always. Try to look at the mitral valve also. The mitral valve is completely closed. You know that you are in the peak systole. If the mitral valve is partially open, then it may not be the actual peak systole, and your annulus dimension can vary. Of course, not a lot, but by around 50 to 80 millimeters square.
Could I ask one question about this? What if there is a say septal bulge? In that case, what if there's a septal bulge, and if you take it during systole, the bulge may actually increase, and does it cause a problem? Or
No, so
that gives us insight. So how to deal with that case? So it's important to notice these all observations also. Suppose if you're missing that, it will be more detrimental for us.
Right.
So looking at this, observing this, it will help us an idea about our depth and how to take that problem on. Yeah, Prashant, you want to
get the septal bulge? It is more favorable for us because we will
Correct.
more
use the mic, please.
So if we get the septal bulge on the CT, it is more favorable for us. The reason is we will be more prepared for that situation.
It's an observation which we notice. So now we start with this interface. We can see here the LV, and we can also get an idea how smaller is the LV, and then what is the thickness of the LV wall, and you can see the most upper frame, and then the next part is to have a good annular.
So just to
measurement.
add a point over there, since we are discussing about the LV size and the cavity, if at all, if in a CT and if there is an LV dilatation, there are only 2 or 3 possibilities. One, it is not a systolic phase, it is wrongly labeled. Second, there is a significant ER, and that's why the cavity is dilated. It may not be a pure ES, it's an ES and ER. Third, there is an LV dysfunction, and that's where the cavity
so the observation is also very important. If it's very hypertrophied, it can be a societal LV kind of situation which can happen that time. And now the next thing which we do is to making 3 dots for the correct annular plane, measurement. So you can go ahead with
what we actually need to do is we need to cut the anatomy in 3 different views: sagittal, coronal, and the longitudinal view, and then we will get the annulus anatomy and all the structures anatomy. What is important is to identify the annulus. So annulus is basically not a true anatomical landmark. It is the virtual landmark which we derive through the CT scan.
Yes.
Because the question is, all the 3 cusps of the aorta, whether it's a non-conic cusp or left or right, they are not at the same level. So what we do in these CT analysis, we identified the nadir of all the 3 cusps, and we give 3 dots to all the 3 nadir of the cusp, and then we analyze it. So this is what he is doing. So we are taking all the 3 sections, and then we are identifying the nadir of all the 3 cusps. So the red dot is basically the nadir of left conic cusp, the green dot is basically the nadir of right conic cusp, and the yellow dot is nadir of right non-conic cusp. And once we got these dots, then we combine all these three dots, and that will give us a geometry.
You want to tell them like how exactly to identify the nadir of that cusp?
So don't go so fast, Rizwan. That is where the most important, kind of step. You have to have a good, proper another dots, three dots. So you have to see that the cusp is finishing. You take one cusp left, you go in the middle, you come down. Yes, sir.
In three-dimensional
It's a
system,
coded,
they have
sir.
given
So
like
three-dimensional
this.
has coded like that. Yes, sir. So we go back to, you don't confirm it. Please go back. Don't confirm it. Yeah.
I mean, we
Yeah.
just want to show how to identify the nadir
Yeah,
of
so we
this.
can go ahead. So,
Yeah.
So you go up to, sinuses, Rizwan. Go to sinuses. Source the sinuses.
So what exactly we
Don't
need to
confirm it. Go back. Go back.
No,
Put
he's
the dots
saying
again.
Don't adjust the analyst.
Dot.
Just
Yeah.
go back.
Yeah. Now you go again.
Now go automatic. So now what first we need to define the center line. So
Go
first
to
we
left
need
cusp. Go to left cusp, please.
So first we need to see
First
whether the
central line.
in all the three views the line is central or not.
Correct.
Then what we need to do is we need to bisect all the three cusps. So how to do is go up in the sinus of Valsalva.
Go up,
Can you
please.
go up slightly up at the level of sinus of?
No, you're
up,
coming
up.
down. You go
Not
up.
down. Go up.
We were in sinus of Valsalva during
Yeah,
that. Yeah.
so go up.
Yeah,
Yes.
yeah,
Yeah.
yeah,
Stop
yeah.
here. So now you can see that. And can you rotate the empty pink dot on the left side?
What we do is we
Yeah.
catch hold of that dark.
So what
brown.
exactly?
That dot.
So whatever the empty pink dot is showing, the same thing will be there. So can you rotate the
Identify.
empty
Just rotate
pink
it
dot?
180 degree, okay?
Can you rotate 180 degree?
180 degree.
Yeah, keep
Just
rotating,
go-
keep
yeah.
rotating, keep
180
rotating,
degree, 180
keep
degree, 180
rotating.
degree. Yeah, yeah. So now
More-
this is the
yes, that's it. So now you can see the empty dot is towards the left cusp.
Empty pink.
Pink.
This one.
This one. So that is at the LCC.
Yeah.
And if you look on the upper section, you know what is the major nadir over there. Accordingly, you can identify the annulus point over there.
So on the RCC side, you can see above the RCC. Can we have a pointer? Yeah, yeah. So
Yeah,
we can
see
see the RVOT also above that annulus. So that's how we identify which one is the right cornicus, which one is the left cornicus.
Correct.
So now you please put dots on three dots. Now you come down. The cusp
Now,
is
what
disappearing.
So we need to bisect the sinus first, and then we have to come down slowly and at the level where the leaflet tissue has been disappeared, and now only the annulus is visible. So this is the point where this is the nadir of all the three cusps, and we have to confirm in both the view. You can see the longitudinal view as well as the coronal view that our red dot is corresponding to the nadir of both the cusps.
Now you go to right and go to non-coronary and do it. So put
Now
3
we
points
have to rotate the cursor, the pink cursor, towards the right coronary cusp, and now we are bisecting the right coronary cusp, and we can come down and where the leaflet tissue has disappeared, and that will be our. There we can give
Put the dot
another
there.
dot. That will be a green dot.
3 dot.
Now come to the non-coronary now. So you see this, the sinuses. Now come to non-coronary. Make it in middle. Then again you go down. You see where the leaflets are. You're losing out lowest part of the cusp, and then you don't see any leaflets here. You put the dot there. So now your 3 dots are done, and you can reconfirm here that you are in the middle more or less, and you can confirm that. You can see there the manual and confirmation. You can confirm that.
And now, can you everyone look over here? And now, can you rotate everything and look over there? So right now, this is the nadir of non-coronary cusp. Keep rotating. Yeah. Now, this is the nadir of right coronary cusp. Keep rotating, and then this is the nadir of left coronary cusp. So this is how we need to identify the nadir of all the 3 cusps, and then we need to combine all these 3 dots. So now.
Yeah, once we confirm, then you will get the polygon. Okay, you confirm it, and then you measure the annulus.
Once you confirm, what you need to do is you need to
You go
scroll
up
down
and then,
and up.
yeah. Now you can see go to the polygon and measure it. You can measure it automatic or also manually also. Now he is doing a manual tracing,
One
and you
more
will get the annulus. Yeah.
One more step I generally do is I try to scroll up and down and see whether all the 3 dots simultaneously disappear and simultaneously appear. That gives me that our identification is good, and then I go for this measurement.
So there are 2 parameters. One is area derived, one is perimeter derived. So why it is perimeter derived is taken in self-expanding and area derived in balloon expandable? Can you highlight, Dr. Srinivas?
So what happens? So when we got this anatomy, whether it could be circular, it could be oval shaped, we got different landmarks. It includes a minimum dimension, maximum dimension, average dimension, and then area and area derived diameter, and the perimeter and perimeter derived diameter. So perimeter is basically by the 2 pi r, and the area is by the pi r square. So that's how we derive these diameter. So area is important for the balloon expandable wall. The reason behind is the balloon is basically, if the balloon expandable wall is crimped over the balloon. So when we inflate the balloon will have a fixed area and it will not expand further. It will have a fixed area, whatever volume will be applied. So it depends on the area. That's why the balloon expandable wall is being preferred by the being done by the area. But for the perimeter subset, it is a self-expanding wall. So if the self-expanding wall take the shape according to the perimeter, whatever it is, so whatever is the shape of the annulus, the self-expanding wall will take the shape of that annulus. So that's why the perimeter is important, because if it doesn't matter whether it's what is the area, but the perimeter is important from the.
Yes. So if a balloon expandable is deployed, it's not going beyond that circular the dimension. But perimeter, that self-expanding will just expand wherever it gets the place. Yeah. That's why it is perimeter derived.
Balloon is a non-compliant one, whereas the self-expanding balloon
will
is
just
self-expandable nitinol, which can keep expanding up to 24 hours.
So once the another plane is fixed, then we go on for other measurements like sinusoidal salva. We go sinotubular junction. Please go ahead, Rizwan.
Importance of annulus is why we need to identify the annulus is because this is the most important parameters.
Yeah, sinusoidal salva. Yeah.
This is the most important parameter to define the size of the wall, to define what type of wall we need to take, whether it's a small annulus, large annulus, or average annulus, and all the other parameters, whether it's LVOT, sinus of wall salva, STJ, ascending aorta, they will be marked from this landmark. So all the measurement will be taken from this.
So this is the LVOT measurement. He is taking 3 millimeter below the another plane, because this is the LVOT dimension, 3 millimeter below that. And now he will measure sinusoidal salva dimension, and he is taking a screenshot, keeping it in the report.
So why is LVOT is important? So,
yeah, please.
Okay. So if at all, if LVOT is more narrower than your annulus, that means to say that your device is going to get constrained at the LVOT. So this is a place like where the conduction system can be there, and your conduction abnormalities are going to be very high. One more factor which adds on to that prediction of the conduction abnormality is the perimembranous septum length. If at all, if it is less than 4 millimeter or less than 2 millimeter, very high chances, because even for a balloon expandable, we are going to keep a depth of around 2 to 3 millimeter. For a self-expandable, most of the time it is 3 millimeter. And if your perimembranous septum is lesser and your LVOT size is also smaller, device is going to impinge on your conduction system. So that's one of the important prediction parameters for conduction abnormality.
So now he's gone to sinusoidal salva and he will measure the left, right, and non-coronary. Please measure that. Yeah,
so we need to measure from the center of the cusp to the opposite commissure, and we have to measure for the left, right, and non. So this one is for the left, this one is for the right, and this one is for the non. So left cusp is important. Sinus SOV of the left is important for the left coronary artery, and the SOV of the right is important for the right coronary artery, unless the coronary doesn't have any anomalous origin.
Yeah, what is normal in this case is the next question. Is this okay? Is this measurement acceptable? What we know is the device is going to expand into the valsalva. So in the valsalva, there is going to be a native leaflets which have been outstretched now. Will the native leaflets can be accommodated here? Will it go and occlude the coronaries is a question. And will the device itself is smaller than this valsalva for each of those sinuses? How do we say that? Generally, we used to say that if sinus of valsalva is more than 30 millimeter, it's roomy enough. However, nowadays, if you're using a smaller annulus, what we generally want is it should be device plus 4 millimeter extra, so that your valsalva space is adequate enough for that particular size of device.
So we've taken a 23 mm valve. If it is more than 27, 28, we are okay.
Good enough.
And previously when tower was started, 30 millimeter was kept as a good roomy sinusoidal salva, where the coronary obstruction, even if it is lower down, there is no concern, there can be flow from the side. So we measure the sinus valsalva, then we go up for sinotubular junction. And so, Prashant, can you tell us sinotubular junction measurement and chances of sinus sequestration?
So why we need to understand the STJ dimension? The reason is, if suppose STJ is narrow, what is going to happen? If STJ is narrow and if you are going with a balloon expandable valve, there is a possibility that that balloon expandable, the valve is not going to touch the STJ, but the balloon over the valve is going to touch the STJ. So if suppose we are going with a 26 millimeter valve and the STJ is just 24.5, then there is a chances that the balloon of that valve might rupture the STJ. Second thing, we also need to understand, is there any calcium over the STJ? That if there is a calcium, there is a high risk of rupture if the anatomy is very constant. And third thing is, if the STJ is narrow and the annulus is large and we are taking a larger size valve, then there is a chances that the STJ might push the valve downward. So it might embolize the valve towards the LB. These are the importance of STJ.
One more point, if the sinus are effaced and STJ is narrow and it is also lower, it's less than 15 millimeter, then your skirt of the self-expanding valve, especially self-expanding valve skirt, height is around 13 millimeter to 15 millimeter, and the balloon expandable is 8 millimeter. Especially self-expanding valve, if your sinus STJ is lower and effaced and narrow, then your skirt will be totally occluding that. There will be sinus sequestration. There will be no flow going down, and it will be just a closed, and just like a cover stent will happen. And it's more kind of a matter of concern in valve cases.
Exactly.
Yeah. So we can go.
Yeah. So now we can measure. So this is all the STJ dimension. So the average dimension is 22.4.
We are now. This is the
27.4.
aorta. This is STJ.
Then after STJ, we can measure the ascending aorta and then the coronary height.
Coronary height.
Yeah.
So we can go to coronary height. This one. And this is double oblique MPR is important here. So it's not going on the same MPR mode. Double oblique MPR mode is important for having a good coronary reconstruction, and you can then the chances of errors are less. Now from annular plane, you see he is taking the lowest part of the coronary, left coronary, and left coronary will always point down, and then the lowest part he is measuring the height, and that is the left coronary height.
So how are we determining whether it is a left or right? Is look at the short axis. We are rotating over there and then identifying the artery and then measuring in this longitudinal view on a double oblique MPR. And whenever we talk about the coronary height, it's at the lower cusp.
Yeah, and also the coronary, left coronary will point down and the right coronary will point up in this sagittal plane. Yeah.
Yeah.
So now measure the right coronary. This one. That one is right. Yes, that one is right. And this one is. You see the right one, which is
you
going
can see,
up.
You can see this green, empty green dot over this side. So this is on the right side.
This is also
and
right.
so same thing. This empty green dot is over here. So we can see this is the right coronary.
Correct.
So with this coronary height of 13 and 14 millimeter with sinus roomy 27.8 something like that, and loss of 22, there should be no concern as such of much concern of coronaries. Now we can go ahead with this hockey puck and some idea about the calcium, and also we see the calcium in these projections. LVOT, how is the calcium distribution at the annulus, or is the LVOT? And LVOT calcium, we can have little discussion on that.
Okay. So LVOT calcium, especially when you are using an balloon expandable devices, there is going to be a chances of annular injuries or LVOT injuries. Particularly so if the calcium is more thicker, more than 5 millimeter, and also extends by more than 5 to 10 millimeter in length, this can happen. So that's why we try to look at the LVOT calcium. It's not only dimension, it is also about how bulky is this calcium and how spiculated is this calcium. Sometimes there can be a tiny calcium, but if it is more spiculated, even a small balloon dilatation can poke into the LVOT and cause an injury. So you should be mindful of all these things and select your device or a strategy accordingly.
If there is a large chunky LVOT calcium, and then we can avoid this balloon expandable valves. They can push this calcium, they can cause annular injury, they can any
have a different take on
self-expanding can be a better option, but in these situations, self-expanding, there is a trade-off between the leak, the paravalvular leak, and the injury.
Could I ask one question here? say when you are measuring the annulus, if there is a chunk of calcium, does it actually cause a problem in correctly measuring the annulus?
Yeah. So what exactly happens is calcium is a double-edged sword. Very low calcium, there will be difficulty in holding the wall. Too much calcium, there is difficulty in opening of the wall. If there is annular calcium, then for the measurement perspective, what we do is we usually cut the section from the middle of the calcium. So we cannot take it completely extruded, but yes, we usually take it from the middle of the calcium.
That is very larger concern in bicuspid aortic valves. Bicuspid, you have a rough way, you have a calcium, and then you have to take the correct annular size, ICDs. So that is a different ballgame. I think we can have one presentation on that and discuss that. So we can now move on to peripherals. Now I think quickly angle, show us the angle, how to measure the angle, and yeah, you can see here we can go exactly to cuspal,
show horizontal aorta angle.
Overlap view as well as coplanar view. Get an idea from here only, which is the coplanar view angle, the angle for coplanar view and the angle for cuspal overlap view.
We have a question there. Yeah.
Any question? Yeah.
How we look for membranous septum? क्योंकि जब calcification या shorter LBOT या calcified है, how we look for in CT where is the membranous septum?
Yes, show us the membranous septum. Yeah. So you can see there. Rijwan, show us the membranous septum length.
Yeah.
Yeah, you can. Are you looking at that frame? That one. And there you can see the membranous septum length he will go to measure. Yeah, this one. Now go a little back. Go a little back. Yeah. So this is okay. You can measure that.
Okay. This is one of the way
come
to
down.
measure.
Come down. Yeah, from here to go down. Yeah. Then go down. Not up. Come down.
Remeasure it.
Come down. So yeah, so something like this. You have a good membranous septum length here. Prashant, you have to add here something.
Generally, I don't measure it in this way. I generally measure it even
Usually
before
we go into the diastolic phase and then we go into identify the non-cornicus and then we go scroll down and where the contrast is started appearing, where exactly is the membranous septum.
Yeah.
So the membranous septum measurement is many times having an observer bias, because if suppose I am measuring, it might be 5 millimeter, you are measuring, then it might be a 4 millimeter or 6 millimeter. But yes, it will give us some idea that whether there is a membranous septum is very short or not, that can predict whether there will be any conduction disturbance or not.
And that's more important when the LVOT is more narrower than annulus. If it is bigger, generally we are not more worried about it.
So we can go to the angle, the aortic angle we have done.
So aortic root angle is basically important for to identify whether there is any horizontal aorta or not. So horizontal aorta means if the angle is more than 50 degree, we call it a mild horizontal aorta. If it's more than 60, it's moderate, and if more than 70, it's a severe horizontal aorta. So what is the importance of it? Because if there is a horizontal aorta, there might be a difficulty in negotiating the wall. There might be difficulty in positioning of the wall, and there might be a proper deployment at the time of.
And if
so
you have
more than 70 is horizontal aorta.
If it is a complete horizontal aorta where you don't have a deflectable devices like self-expandable, it might be difficult to track also. And as Dr. Prashant said, it's not only about tracking, it's also about how you're going to position your device, how it is going to expand, or how it is going to get deployed.
So I think early days when there was a basically evolute and all, and if the aorta was very horizontal, there was a point of taking snare up front. So many times it doesn't go down, and then you have to have a snare there. So now we can move on to the peripherals.
You want to talk about the calcium score?
Calcium score, I think, yeah. So we can.
So 2 points about the calcium. It's not only the calcium score, it's the calcium distribution which is more important. Because even if the calcium score is even a 1500 or 2000, that is not a problem for us. But if the calcium is situated at the level of annulus, and if it's annular nodular calcium, that might be a problem because it might lead to injury, whether it's a balloon expandable valve or if it's along with self-expandable valve, there might be a significant paravalvular leak, and if you are going with a post dilatation, then again there will be an injury of angle.
So one point we all should know is whatever calcium score which is given in a Tremencio is not an actual calcium score, it is only a volume of the calcium. So look at that, it's millimeter cube. So Agatston score is what we actually use it to quantify whether it is heavily calcified or especially in a low flow, low gradient AS. If you want to use AUC score as a cutoff for an intervention like more than 2000 in a males, 1600 in a females, then it should be AU score and not this Tremencio score. You want to talk about the conversion factor for that?
I think, Dr. Srinivasan, we have 5 minutes for this session.
We'll go to
we'll go with the peripherals. I think peripherals is not difficult. You can see the how he measured that. He put 3 dots, confirm the vessels, 3 dots, and then you get the vessel there.
This was the segmenting of the vessel, and now we have to identify the segment where we actually need to measurement.
Yeah.
And then once we are done, then we have to define the central line. So we have to look whether the line is center or not across from the distal descending to, abdominal aorta to common femoral bifurcation.
Yeah. So we have to just measure it, throughout the length, and you can see the calcium distribution, a word calcium distribution that site while puncturing, and you have a fair idea how we do that. So we can quickly move on next 5 minutes to bicuspid aortic valve annular measurement, and then a small valve to valve, case where we can have 2-3 minutes discussion. So just annular plane. So as a bicuspid aortic valve and identifying the annulus there. Just a quick one. So can we talk on the small precautions which we take in measuring and going for annular dots in bicuspid aortic valve?
So in bicuspid aortic valve, we need to define whether it's a type 0 bicuspid or it's a type 1 or type 1B bicuspid. If it's a type 1A or 1B bicuspid, it will be same like a tricuspid valve. And then if it's a type 0 bicuspid, we have to go with a dedicated platform of the Tremencio where they have mentioned for the dedicated bicuspid valve. Second thing, when we are measuring for the bicuspid valve, we need to measure the supraannular measurement also at the level of 4 millimeter, 8 millimeter, 12 millimeter to identify how that bicuspid wall is behaving, whether it's a tubular, whether it's the conical, or whether it's a flared. So that we will get an idea what exactly is happening at the level of annulus and what exactly is happening at the level of supraannular level. Because the dictum in bicuspid wall is never oversized. Because if suppose supraannular is narrow and the annulus is very large, we will go with a supraannular dimension because we never oversize the wall, because in bicuspid wall the sealing happens at the supraannular level, not at the level of annulus.
Yeah, so depending on the annulus versus intercommissural distance above your annulus. If at all, if your ICD at 4 millimeter is more constrained than annulus, it is going to be a raphe based anchoring rather than annular based anchoring.
So tubular and tapering is not that bad, but if it is funnel, in lower down it is LVOT is smaller, then you have to be little more concern and precaution should be taken. So bicuspid just show us annular measurement in type 0. You have a type 0. So if you type 1, no problem. We have 3 cusps, and then you can look for the measurement.
There is one
you can
type this is mentioned. So this one is for the tricuspid, this one is for a bicuspid. So this one we have to select if it's a dedicated bicuspid wall. If it's a type 1A, 1B, then you can take this one.
One of the important thing is identifying the morphology. So sometimes what happens is when you're assessing the systolic frame, the exact morphology of the bicuspid valve may not be very obvious. So in those cases, try to use a diastolic frames, that is 75%, and look where exactly it is coapting, where exactly is the raphe. There are around 20% chances that type 1A has been relabeled as type 0 bicuspid. So entire measurements can be entirely wrong and oversizing can be a different way.
So this is a type 1A bicuspid with a non-calcified raphe.
Type 1, it looks just like you can go for a tricuspid and do that. So if we have, now we can move on to last valve in valve. Any valve in valve case we have?
When we talk about the oversizing, for a tricuspid, generally we go for around 8 to 12% oversizing if it is a balloon expandable. If it is a bicuspid, we try to limit it to 4 to 5% oversizing.
Dr. Girish will tell us sizing and
so there's
everything.
another talk, complete talk.
Just you know, a little nitty-gritties in valve in valve. So valve in valve, basically the saving ring is the new annulus. So, and many times saving ring you can see on fluoro, and many times you can't see, and many times saving ring you assume, and you have to should have an idea how the saving ring is in relation with the frame. So in epic valve, the saving ring corresponds very clearly, it is seen, but in Carpentier and you know, trifecta, the saving ring is just at the bottom of the frame. You can make out. So here in valve, you look for the we have app which can give us an internal diameter. You can also measure it, and
So in valve also what we need to measure is we need to measure the nadir of the previous surgical valve. So we go down, we identify the nadir of all the three sides of the nadir of previous surgical valve, and then it will gives us an idea of the true annulus. Then we also need to measure at the mid of the previous valve and then at the upper level of the valve, so that we will get an idea how the valve is.
yeah, so we get an idea about dimensions which are there, ID diameter, true ID, and then here the most important part is VTC and valve to STJ, you know, dimension. And if that is there, most of the information we have, and then we can plan our thing.
Yeah, I just want to re-emphasize on what Dr. Prashant said. Like, so most of the time the valve may not expand kind of a diploid. There can be an constraint at the upper end or the lower edge. That's why measuring the ID at various planes are important. Not only that, sometimes there can be extreme cantings that can actually increase your risk of coronary occlusion and so many things. So looking at aortoventricular axis versus the valve's axis is very, very important, and identify how much degree is the canting. And third, obviously, to assess for the coronary risk, you are going to measure the VTC. Not only VTC, VT STJ is also important in this case, because some of this valve post can go above your STJ, especially if it is lower side. And once you deploy an TAVR valve, the surgical valve will act like a covered stent portion over there, and that's where it becomes more important.
So valves are, we feel that surgeons, they do perfect job, but many times we see canted valves, and then you have to be a little more careful how you measure and do that. And just we'll finish up with the VTC and VT to STJ measure, you know, how you measure that and its importance. So we'll
can you go up and measure the VTC?
Yeah.
Can you go up and measure the VTC?
Probably since there is another
Just
session
skip
on
this and go for the measurement of VTC.
So
So what is VTC is basically it's a wall to coronary distance. So why it is important? It is important to assess whether there is any risk of coronary obstruction or not. Because what happens when we deploy a new valve inside the previous surgical valve, the leaflet of the previous surgical valve will be plastered towards the sinus of Valsalva. So if there is a less distance between the previous surgical valve and the coronary artery, then the chances of coronary obstruction will be high. So the usual dictum is if it's less than 3, the chances are very high. If it's up to 3 to 6, the chance it's intermediate, and if it's more than 6, we are pretty much safe. But we also need to consider the VT STJ also, because sometimes what happens, the STJ is very narrow, and there is a very small distance between the previous surgical valve and the STJ. So what happens, even if the sinuses are good, but when we deploy the valve, the previous surgical valve leaflet touch the STJ, and then it will make a tube-like structure from the ascending aorta to STJ to sinus of Valsalva and up to the valve, and there will be no flow from the ascending into the coronaries. So that is called the sinus sequestration. So that's why we need to understand the VTC and VT STJ.
Yeah, thank you. I think we will conclude here with VTC. If it is more than 4 millimeter, we are more or less okay. And VT to valve to STJ, if it is 2 to 4, this borderline less than 2 is you know, dangerous, and there's very high chance of sinus sequestration. And that also, if it is more than 4, then we are comfortable. So 4 is the marker, and 2 is for VT to valve to ST junction. Any final comments, Subra sir, and then we can finish.
Yeah, I think if at all, if it is an high risk coronary and if you're planning for an unicorn,
Sir, if we are going, you know, deep deployment, then it increases the chance of, you know, conduction system injury and heart blocks. if it is self-expandable, and especially with high radial strength and lower flaring up kind of design like in Evolute and all. If it is non-tapered or sorry, it is a tubular like Hydra or less radial strength, they can cause lesser conduction system involvement. Balloon expandable, if we are that depends on where we are positioning. If again a deep, then chances of conduction injuries more. So essentially, if it is self-expandable valve, it gives more chance of heart block, deep deployment, and less smaller membranous septum length. So these three predictors are there, and then also the calcium. Finally, if you have LVOT calcium, annular calcium, they can cause and press the conduction system. Any other points?
Just to put it out in a refined way, sir. If at all, if the perimembranous septum is very, very small, and if you are able to do a 0-degree employment, then I may not be touching. If it is small, but the LVOT is roomy, still our device interaction may not happen, nothing would happen. So, but if it is still adequate, but the patient already has an RBB, though we might just touch and go, there might be higher chances of a CHP. That we should remember.
One last point. Not every patient is feasible for tower. We need to understand the CT analysis, and there are a patient where the tower risk can be high, even more than the surgical risk. So that's why we need to identify those hostile feature like a annular calcium, LVOT calcium, coronary risk obstruction, risk of stroke and everything. And that's how then we have to decide whether the surgical risk is high or the tower risk is high, depends on the CT anatomical finding. And if the tower risk is high, even if the patient is 80 years, don't send the patient for the tower, shift the patient for the surgery. That would be the better approach for that patient.
Thank you.
Well said.
Thank you so much. We have a dedicated three-dimensional workshop there. People who can who are interested can go there. Rijwan and the team, their team members are there. They can guide you doing three-dimensional yourself. Thank you so much.
Big round of applause for our chairpersons, speakers, moderator, and panelists. We move on to the next session. As moderator, I would like to invite Dr. Amit Chaurasia sir on the dais, please. As chairpersons, I would like to invite Dr. Lipika Odhikari, Dr. Nomonil Biswas on the dais. Panelists of this particular session, Dr. Pronobesh Chakraborty, Dr. Dilip Kumar Sinha, Dr. Tomal Bormon. I request all of you to please come on the dais.
Good morning, everyone, and I can see the discussions going very well, and this is the kind of conferences we need to have in the present day scenario as you are developing the TAVR valve program. So the next session is on choosing the right valve and size. The talk will be given by Dr. Girish. So there's going to be 6-minute time for discussion, so it is going to be a great talk, I think. Dr. Girish, stage is yours. Thank you.
Good morning, and it's such a pleasure to be here, and thank you, Dr. Dilip, and all the chairpersons. It's such a big topic. 6 minutes is too small, but I'll try and do justification to the topic. Oh, okay. Thank you. I thought 6 minutes, all right. So I will not waste my time. Why sizing matters and consequence of errors of sizing. If you undersize, there's a paravalvular regurgitation, valve embolization, poor anchoring and migration, it may move up and down, hemodynamic failure, and suboptimal leaflet coaptation, which may cause halt. Then what is ideal is optimal sizing. This secures sutureless complete anchoring of the TAVR valve, minimum or no paravalvular leak, excellent hemodynamics with minimum gradients and no leak, durable leaflet function and predictable deployment. This is what you want. So focus on optimal sizing. And what happens if you oversize? If you oversize balloon expandable valve by more than 20%, there's a higher risk of annular rupture, then conduction disturbance, pacemakers, prosthesis under expansion, reduced valve durability and asymmetric expansions. That's why assessing the size is very, very important. Anatomy first. 3-step. We used to do an echo before, but I think we have, and balloon in the beginning, they were looking at, if you have a challenge with imaging, balloon can be done. How do? You need to choose between the hinge points, pace it well, and dilate the balloon of appropriate size if you're not an MDCT. And remember that there has to be 4 indirect signs of correct balloon sizing. No balloon movement in the valve when you are fully inflated. Waist at the annular level, tightest portion. Third, no residual contrast regurgitation between the maximally inflated balloon and the hinge points of the aortic annulus. And then calcified leaflets played against the coronary ostia. If you see all of that, if you've not had a great CT scan because of severe calcification or whatever other reasons, you can use this as a surrogate method. But the most important is MDCT. I think we had such an excellent talk. I would just put a little more words into what was discussed. You need to look at multiple things. Look at the virtual annular plane identification, minimum maximum diameters both in sagittal and coronal. Perimeter is very, very important, derived diameters, then area derived diameters. I think these two are more important than just the diameter that you measure. Also, you look at sinus of Valsalva dimensions, STJ diameter and height, coronary ostia heights above the annulus, and look at the aortic angulation, how horizontal it becomes, so that you can, plan whether you need a balloon expandable valve or a snare if you're using self-expanding. Then you have LVOT eccentricity, it's important, and calcification, especially if you have bicuspid aortic valve. And finally, the axis, iliofemoral vessel dimensions. So when you start at the aortic root, very important to know whether it's tricuspid or bicuspid. Also spend few minutes at the LVOT, if it becomes smaller or larger compared to the annulus. So you know what it looks like, whether it is flared, tapered, or tubular. These 3 gives you what kind of size and how aggressive can you be on sizing, larger device and post dilations. Then sinus of Valsalva diameters are very important. You need more than 30. Again, as the diameter of the TAVR valve increases, you need more diameter in the sinus of Valsalva, along with coronary heights of 10 millimeter. But if you have a large sinus, about 35, and then if you have a coronary height of even 5 in a 26 mm or 23 mm valve, it really doesn't matter. You need to factor in all of that. Sinotubular junction diameter is also important, especially if you're using balloon expandable platform, because if that is severely calcified or smaller than the annulus, you may cause damage to the sinotubular junction with the balloon. In which case, you may have to load the balloon slightly deeper when you're loading the device onto the balloon, or partially you inflate, and the second inflation has to be balloon more LV oriented than the aortic oriented. Now coming to the aortic root anatomy, I think all of us have, very beautifully all have looked at it. It may become, repetitive, but I'll still look at the hinge point planes. Means you need to look at these are the things. Look at these 3 bottom, the Nadir's hinge points, then hinge point plane. You put a virtual ring, that is where you are probably aiming your device when you are considering. It is the tightest part of the aortic root and primary anchoring plane for sutureless transcatheter heart valve deployment. That's what you need to aim for. And when you also look at the key other measurements, you look at the subannular LVOT, at least 2 millimeter below the hinge point plane, lower anchoring boundary, that is where the lower part of the device anchors. Virtual annular plane, that is 3 hinge points, what I showed. Then sinus of Valsalva, width as well as the height determine coronary anatomy and the risk of coronary obstruction. Sinotubular junction I just mentioned, and in ascending aorta is also important. If it's more than 4.5, 5, then you may have little difficulty. You need stiffer wires. The valve may can't. So why these are important? What are the most important thing? Annulus, area, perimeter, primarily sizing input. Undersizing or oversizing depends on this. Coronary height and sinus width are very important, may influence which platform you may use. Calcium distribution, this is one of the single most important predict. Sealing of the THV, expansion and conduction issues, LVOT anatomy. Coming to the primary sizing references, when we look at it, what modifies them? If you have a calcification, if there is no calcification, use a size equal or more than 1 millimeter above the annular diameter. If there is a mild to moderate, target 0.5 millimeter above the annular size. If there is a severe diffuse calcification, almost make it near equal or annular size. When you have a borderline anatomy, there's a MyValve has an advantage because they give you an increment of 1.5 millimeter compared to other balloon expandable or self-expanding which are 3 millimeters. So we know these IFUs are already there with you all. What is balloon expandable valve strengths and how do you select them? I think rapid pacing is absolutely essential when you use a balloon expanding platforms. Mandatory 160 to 200 beats per minute to have a systolic blood pressure of probably less than 60-50. Then balloon overfill for larger, again it becomes little out of context. Then the delivery system allows you to flex and get commissural alignments as well. Then you have balloon sizing adjunct if CTTs are discordant. Then for a self-expanding, when you look at it, primary sizing is by the perimeter. Here, again, what you do for a self-expanding, I'll go here. CT parameter is primarily a perimeter, controlled oversizing. Here, you can go up to 10 to 20%, but if you're doing balloon expandable, it is 5 to 10%. Don't get too aggressive with balloon expanding. Implantation depth critical, the determinant of pacemakers, go between 2 to 3, ideal. If you go anything beyond 5, there's a higher probability of left bundle or a complete heart blocks. Supraannular advantage you have, 10 to 15% larger effective orifice area for the same nominal size versus balloon expandable. And the great advantage is reposition. You have multiple attempts to really position where you want. The drawback is higher permanent pacemakers. I think I will leave it at that and take some questions and show you some simultaneously, I think. Thank you.
I think you can show this slide because this slide seems to be more important than anything. That is why you stopped over there.
I know there are certain things that you must see to understand. When you have calcification, I think this is one of the most important things because you never want to have a rupture. If there is none, use at least 1 millimeter and above, mild to moderate, upsize by 0.5. If it's a severe dense, you may have to just go by nominal or slightly lesser. Also, when you have an intermediate sizing, try and avoid taking a larger device because there is faster degeneration if you use a larger device versus choosing a smaller one and oversizing, overinflating it. You have a better durability, lesser pacemaker, lesser PVL. So don't try to oversize in the anxiety. Again, another important thing is annular ellipticity, especially this happens with severe bicuspid aortic lesions. So that's why area dependence is important. And also, use a platform which is less aggressive because if a raphe is very calcified, the device will move in the opposite direction. So if you have any very dense calcification, it may even cause perforations on that side. Self-expanding with post dilation may be good option, but if you're going with a balloon platform, don't get very aggressive. You may do it 2 post dilations, but don't do the very aggressive in the first. There's a newer notion that the anchoring, the interaction between the device and the person does not happen at the annulus, but all through between the STJ and the LVOT. So you need to take multiple levels at the annulus, every 2 millimeter above and 2 millimeter below, and then very often the probability of downsizing the valve has been about 90% of the case. The sizes have been reduced to have lesser pacemakers, better performance of the valve, good gradients and durability. So, and when you go to the, slightly challenging situation, sigmoid septum or septal hypertrophy, you can consider alcohol ablation prior to doing. Otherwise, there's always a melon seeding, slightly it may move up. So in this case, you can use a self-expanding and go a little deeper. But if you're going with a balloon expandable pace for a longer duration, inflate, anchor very, very well, slightly deeper than usual. And when you have a shorter membranous septum, I think use the one which has lower, radial force. Balloon expandable are better. Also, self-expandable with lesser radial force. Coming to valve in valve, I think you all discussed. One single thing I would like to tell you, please identify the surgical valve. It's very, very important. And the true ID of that previous surgical valve is your starting point, not the valve size written on the discharge summary. Go to the website, look at the internal diameter of that particular surgical valve and start from there. And if second one is true ID, you've already got it. And TAVR nominal size should be 90 to 100% of the surgical valve true ID. If you try to get too bigger valve, just because there's a ppm, the valve may migrate or it may be associated with, halt and other things. The coronary obstruction risk also goes up if you use a bigger valve in these people, because the leaflets of the first surgical valve create a covered stent within which the second set of leaflets would open. That's why you need at least VTC of 4 millimeter or more. Don't be very, very close. Otherwise, always protect the coronaries. And higher implant is important when you have the very small valve, previous valve. Slightly get it higher, maybe 2-3 millimeter. Don't get too deep. And key takeaways and right valve size, if I have to mention, today MDCT is non-negotiable. Although we look at, contrast-induced nephropathy, as my colleague Dr. Shin was telling, if you give minimum contrast just to assess the annulus and the adjacent areas and forget about periphery and all that, we can still do with 30 to 50 ml contrast. Annulus is the starting point, not the end point. You need to look at every other parameters. Balloon expandable valve, these are intraannular, reproducible, horizontal aorta and coronary access friendly. Self-expandable, they are supraannular, advantage for small annuli. Valve in valve, low ejection fraction, you don't have to pace them, that's the advantage, but downside is higher pacemaker rates. Bicuspid aortic valve demands multiplanar supraannular sizing, downsized by default. Challenges would be calcification, conduction risk, coronary heights and life expectancy modify final choices. If you have younger people, you want different valve positioning, and if you have very old, only one valve would suffice, probably you'll go aggressively with one valve. Thank you.
Thank you so much, Dr. Girish, for this excellent talk. So let me open up the discussion. So you get a CT. This discussion is not only for you, anyone in the audience can participate. I think that will be great. You get a CT. You don't have a systolic frame. You only have a diastolic frame. You do an analysis in 75% diastole. You get a annulus measurement. What is the consequence that comes to your mind if the CT analysis is only done in diastolic frame, that is 75% diastolic frame?
Yeah, I think that's a good question. Very often you need to look at multiple things. You don't only look at the annulus, you look at all other parameters. You look at go 2 millimeter down, go 2 millimeter up, that's one. Second, you may have to add by about 10 to 15% extra if you have gone in a diastolic frame. You look at the mitral valve, what's happening, how much of diastole is it? And thirdly, if you're ambiguous at that point in time, you can also do very good balloon assessment. If you're in a dilemma, I think choose probably depending on the calcification. If the calcification is not too high, oversizing by about 1 millimeter is much safer, whether you use balloon or non-balloon. But if it's highly calcified, I think I would just go by maybe, whatever I've got on that diastole plus 0.5 or so.
So that's an excellent view. So just let me add to that. The difference between a systolic and a diastolic measurement, that is 25% systolic and the 75% diastolic, is almost about 10%. So diastole will give you 10% lesser measurement, whereas systole will be the accurate one. So whenever we are taking a diastolic measurement, when you see a diastolic measurement, then think that the measurement is lesser. So you may have to take a larger valve. Regarding the balloon sizing, let me put another question, a scenario again. You have a patient, very sick patient, you can shift for CT. Balloon sizing is one way to go. What are the other ways that we can look into these patients?
Okay.
Because we are not able to shift the patient for CT at all. We need to do TAVI immediately because the patient is crashing or doing something like that.
I think this is one where I feel you need to probably better intubate, do a transesophageal echo. That's one. You have a good control on patient hemodynamics and saturation. You have time to make certain measurements. Look at the transesophageal, whatever you see. Again, you be mindful that it will be about 15 to 20% undersizing compared to CT sizing. And as I mentioned to you, take a good injection with probably hinge point to hinge point, whatever you're finding. You inflate the balloon 1:1. If there is no too much, acute AR, you be prepared for it. 1:1, and balloon should not move. No paravalvular leak. If you're going to get that, that's probably the ideal size that you would like to go, and then add 10% or so.
So perfectly, this is how we used to do in the old days. The second way we used to do is take a measurement in the lateral view, take a measurement in the AP view, and then just take an average out. But the best measurement that correlates almost equal to MSCT is the 3D measurement, 3D echo measurement. So if you don't have anything to do, just put in the TE machine, get a good 3D measurement, take the sizing, and just go ahead with the case. But despite that, I have had one patient in which the valve just flew away. And in these cases, I feel self-expandable has a slightly edge because you need a range. You don't need to be accurate in these cases.
Can you play my slides?
Dr. Hajra here.
Hi. Can you play my slides? Yeah.
In last 10 minutes, you talked about the aortic stenosis. How about the aortic regurgitations? Because nowadays we'll be seeing more and more newer gen valve for aortic regurgitation. So do you think the same systole 40% or you measure in diastole? So how do you measure the valve size in pure aortic regurgitation?
I think that's another ball game altogether. It's still an evolution at this point in time. The current, whatever we are doing with the, if you have a Jenner valve, I can understand. But if you're going to use our existing valves to treat pure AR, with a balloon expandable, you are going to size minimum 20% upsizing. If you're using a self-expanding valve, be very mindful that it's going to be more unpredictable. You may have embolization, both either aortic or ventricular, and higher chance of valve-in-valve when you use a self-expanding. And you may have to again use snares to readjust them. I think minimum 20 to 25% upsizing in a pure AR is probably an off-label way of treating aortic regurgitation at this point.
The other question is, we have different sizing modality, annular, supraannular,
yes.
We do it intercommissural distance and all. For this audience, if you'll have to give one single way to measure it, and that does everything, what should it be?
Again, you need to look at all three levels. See, never go by one measurement. That's the biggest fallacy. If you really see, if you do just one measurement, you have highest chance of all the complications. What? Annular rupture, PVL, halt, as well as embolizations. So perimeter and area are the most two crucial measurements. And if you can use both of them with their specific, what do you call, softwares, that's the right thing to do. Sorry, the part of the question you asked me, what single most? Probably annulus is still the starting point, but definitely it's not the ending point. It depends on calcification, whether raphe, if it's a bicuspid, or even if it's tricuspid, highly critically stenosed. I think valve is going to be anchored at much higher than the annulus. You should factor in all this when you take the measurements.
Okay. The other again scenario I'm giving. There is a huge calcium on the annulus. This was already discussed, but I again want to remind. What happens if you include the calcium in your measurement in perimeter derived diameter and in aorta, area derived diameter? Because these are questions that always comes in mind to everybody. So
yes, I think that is probably the principle why balloon expandable valves are area derived. So you keep this calcium out of the measurements. If you're looking at a self-expandable, you're still looking at perimeter derived, because these are self-confirmatory, and the chance of injury to the aortic annulus or the aortic, the root is much lesser when you use a self-expanding with so much calcium. So how do you factor in that calcium? If it's a nodule protruding inside, not circumferential, be prepared for a significant PVL. What are you going to do with it? Probably gentle post-dilation after a self-expanding valve may appear a better option to me than using a balloon expandable valve and risking trying to make the whole annulus circular in an elliptical area and causing more PVL and more risk of rupture.
I think that is what it is to be considered, but let me put it in another way. If you exclude the calcium while doing a perimeter derived diameter for a self-expandable valve, the perimeter will come larger if you exclude the calcium. If you exclude the calcium for the area derived diameter, then the diameter will come smaller.
Yes.
So these are the factors that you'll have to keep in mind. Septal hypertrophy, again, it's one area where we started with TE because we wanted to have our valve to end just above the septum.
Yes.
So if you have a great big septal hypertrophy, self-expandable, balloon expandable, both are going to be dangerous. Because with a self-expandable, if you go too deep in, you increase the chance of AI, you increase the chance of
pacemaker
conduction defect. Again, with the balloon expandable, if you go too deep in, you increase the chance of rupture, AI, conduction defect. So in these cases, you need to be perfect. We did away with TE, but now I think, again, if you have a severe septal hypertrophy, a TE is a good thing to have. Any other question from the audience? From the panels? Anything you want to ask? Any question, something?
Hello.
Yeah. Hi.
Very nice presentation, sir. Just one question from my part. Sir, how to mitigate the Russian doll effect in surgical valve degeneration, and then you are using TAVI in those cases?
Sorry?
The Russian doll effect.
Means the valve in a valve effect.
The valve in
that
valve.
Decreases
How
the
to mitigate
size of
that?
the valve.
Okay. Russian dolls. I think there are two things. You're looking at primarily a PPM. What is the previous annulus was there in the surgical valve? Is it modifiable? Means is it fracturable or non-fracturable? If you can, either you can do it before and then implant, it's better. You will have better preservation of the new valve. Otherwise, when you post dilate at high pressures to fracture the surgical valve, you may damage the THV valve leaflets. So that's one way of looking at it. If you can modify and make it bigger, then definitely that effect will be reduced. Second, try to position, always use a probably self-expandable slightly high. But if you have a large surgical valve, you can put in a balloon expandable valve equally and position it not more than 2 millimeter or maximum 3 millimeter below the annulus, the ring, not the annulus becomes defunct. You don't bother about the annulus. Look at the annular ring as your starting point and ending point and try and stay maybe 2 millimeter below and then post expand.
Thank you, sir.
Thank you,
It
sir.
was a great discussion, I think, and thank you everyone for the participation. Excellent talk. Thank you so much.
Thank you so much. Big round of applause for our chairpersons, moderator, panelist, and also speaker for an amazing, enriching session. We move on to the next session, which is the Dr. K.B. Bakshi Oration Award session. I would like to invite on the dais Dr. Munutosh Paja sir, Dr. Amal Kumar Khan sir, Dr. Anil Dhar, Dr. Girish Nawasundi and Dr. Dilip Kumar sir to please join the dais for the Dr. K.B. Bakshi Oration Award.
Dilip, would you please introduce KB Bakshi Hall, why you are select the oration?
So I was not that fortunate enough to see Dr. K.B. Bakshi in my lifetime, and but Dr. Panja, Dr. Khan, I think they have worked together and they are the pioneers of interventional cardiology in especially this part of country. And this is just to pay respect to the leaders and the pioneers. So Dr. K.B. Bakshi's vision, leadership and dedication laid the foundation of modern cardiac care in Eastern India. His contributions continue to inspire generations of cardiologists and remain deeply embedded in the region's cardiovascular healthcare landscape. I wanted to have his picture, but I looked into internet. I asked so many guys, I couldn't get one. That was one thing which I'm really sorry about. And this is what we got. His residence, one picture clicked by some of my senior colleague, and then he gave it to me. So Professor K.B. Bakshi was the former president of the Cardiological Society of India, 1975. He was recognized nationally for his leadership and contribution to cardiovascular medicine. One of the founding architects of organized cardiac care in Eastern India, helping establish modern cardiology services when the specialty was still in its formative years. Along with eminent cardiologists such as Dr. Manutosh Panja, Dr. Debal Sen, he played a pivotal role in building the foundations of advanced cardiac care and cardiology training in Kolkata and Eastern India. He was actively associated with national and international professional organizations, including membership of the British Cardiac Society, fostering academic exchange and adoption of global best practices. He contributed significantly to the growth of the CSI West Bengal chapter and several charitable initiatives dedicated to patient welfare and community cardiac health. He is remembered for his commitment to ethical medicine, patient-centered care, academic excellence, and professional integrity. I am so happy and privileged to have Dr. Pratap Kumar giving the first Professor K.B. Bakshi Oration Award. Dr. Pratap Kumar, see, there are a lot of gunpowders here sitting in the back bench. I still am a gunpowder, we need a spark. So we the spark has to be lighted, and that's where these leaders, those who are sitting here and likes of Dr. Pratap Kumar, they give a spark to these gunpowders and they can create something really, really big. So Professor Pratap Kumar is Chairman and Managing Director of Medtrina Group of Hospitals. He has fellowship in interventional cardiology from University of Turin, Italy. Over 25 years experience in interventional cardiology, course director of Indo-Japanese CTO Club, past scientific chairman, National Interventional Council of India.
What is the problem?
Can we have
Think
the
that only in
audio,
rich
please?
places like Mumbai, Delhi, Calcutta will get the heart attack. No. People are actually in the tier 2, tier 3 cities, even in the villages, will get the heart attack. It is not only the economic status. We are genetically in a bad situation, all Indian population. So we get a high chance of getting heart attack compared to any other population.
So I think we can fall short in reading out his awards and accolades, but these are few which I could gather. Best Interventional Cardiologist Award by Amrita Institute of Medical Sciences, Excellence Award by Vivekananda Samskarika Samiti, recognized nationally for advancing affordable and accessible cardiac care, India's leading experts in complex coronary interventions and CTO angioplasty. He is a regular invited faculty and live case operators at major national and international cardiology conferences. He is pioneer in retrograde CTO techniques in India, trained more than 100 cardiologists. He is training daily. I saw a LinkedIn post 3 days back. He was in Hebel, so in Manipal Hospital Group. So I was a little surprised. Sir is here and he was in Japan, where I couldn't fathom out where was he exactly 3 days back. And he developed one of India's most respected complex coronary intervention training programs, conducted live demonstrations at international meetings, including TCT, EuroPCR, TCTAP, CCT, Singapore Live. These are only few names. He established cardiac interventional facilities in several underserved regions across India and Maldives. So he is a relentless achiever, and he is the course director of Fellows India. And how hard he works, us we all can know. Dr. Dal, Dr. Girish, Dr. Srinivasa is there. Those who are associated with ICRTF. Yeah. So with this, I invite Professor Pratap Kumar to deliver the KV Bakshi oration, lecture. And before that, I would like to honor him, and I request Professor Panja to honor him and present a token of appreciation. Can we have a big round of applause for Professor Pratap Kumar?
It is my proud privilege and honor. Please take that.
Can I have my slides?
So I think it is my proud privilege already to be welcome in the city of joy. And Pratap is very dynamic interventional cardiology in India. So therefore he'll talk on the coronary situation, intervention in presence of severe aortic stenosis. This is an important subject. He's working for a long time. Dr. Pratap, please.
You should understand the revascularization in severe AS. Actually, he was telling me, I don't know anything about structural heart disease. I'm actually telling Anil Dal that they should start only basics, not talking about Mensio and all. You should teach students like they are at the age of 10. Then only people will understand. Never go into the advanced aeronautic level of discussions, and we want the basic program. That is why 1 year back we started Fellows India program only to train the youngsters, and I am actually the youngest of the trainee. I did my DM from a medical college where there was no cath lab. So from that day, I was thinking that I wanted to become an interventional cardiologist. I never became a structural heart disease. I'm not interested, but even then, I'll just tell you why this call came. My disclosure is, I have done the maximum CTO in India, both antegrade and retrograde, done the maximum zero contrast PCI globally, proctored in complex PCI in 18 states, but next Saturday, I'll be proctoring one more state and will become 19, and 16 countries internationally. I started the first Cath lab in any ESA hospital in India and underprivileged places in the country, and also in the country of Maldives. But I've done more than 50,000 angioplasty at the lowest possible rate in the country, which is a great achievement by myself. I feel proud of that. But I have not done a single TAVI individually so far, only assisted few and standing near to the great operators, but never, I have no interest also. Today also morning I was thinking that these people are talking something which is beyond my eyes, but I'm a close friend of Dr. Dilip. Probably that is the reason that I'm standing here. The prevalence of AS and CAD increases with age, and both entities often coexist in the early age group. You should look at all the prevalences of CAD in all the data telling that. It ranges from 30 to 80%. That means it is actually having a coexistence. So what is the long-term risk? The lifetime risk of unplanned PCI after the TAVR is low in patients with no coronary artery disease at the time of TAVR, but accumulates over time in patients with non-coronary artery disease, particularly with multiple or multivessel disease. You can look at that 0.6% if there is no CAD over the next 10 years. And if you look at that one with a multivessel disease, 7.4%. So that is actually the overall need of future PCI is very low in TAVR patients. Is CAD an important parameter of prognosis in severe AS? There is no significant difference at 30 days, and there is a significant increase in all-cause mortality at 1 year in the CAD group, not in the non-CAD group. So the CAD increases mortality in long term only. The syntax score more than 22 had an increased 1 year mortality rate. So the presence of CAD did not affect the prognosis, only the severity of the CAD. And it is risk of the death after TAVR is closely related to the complexity of the CAD. That means more complexity, more mortality. CAD severity rather than CAD itself is associated with increased TAVR, post-TAVR mortality. That is actually the point. So the complexity of the CAD matters. PCI before the TAVR, what do studies teach us? Basically the notion 3, you look into the data, FFR of 0.8 or less, or a coronary artery diameter stenosis of more than 90%. If that is actually indicates the PCI is beneficial, only those group. So if you look at this one, the trial is actually telling PCI is better, only it's those group. Patients with a minimal angina, significant CAD with a class 2 angina, class 2 or less than that, the death and hospitalization at 1 year is similar. That means PCI resulted in a high incidence of bleeding, so PCI may not be required in that group. So PCI is not beneficial in those patients. Study was interrupted prematurely due to the slow recruitment, and did not meet the pre-established non-inferiority margin, thus preventing the authors to draw a definite conclusion on this topic. Revascularization before TAVR confers no clinical advantage, and PCI does not lead to any improvement in any kinds in this patient group. PCI during TAVR, next question. The concomitant PCI in TAVR has a major vascular complication and slightly higher composite all-cause mortality and stroke. So more vascular complication can happen. Does completeness of the revascularization matter before TAVR? Basically, a strategy of complete revascularization did not confer a clinical benefit compared with an incomplete revascularization. So this is actually all the studies are completely confusing. Completeness does not matter. In this core laboratory validated study, neither the severity of the CAD nor completeness of the revascularization after PCI or CABG were associated with the clinical outcome of after TAVR at both 30 days at 1 day. Completeness does not matter. Why these inconsistent results in studies? Differences in the definition of CAD, variation in the diagnostic criteria and threshold of CAD, the definition of complete revascularization, different interpretation of completeness across study, and extend to the CAD, heterogeneity in the disease burden and lesion complexity. What if PCI is not performed before TAVR? Coronary event occurred in 11.6%, and previous CAD and non-coronary artery disease more than 50% before TAVR has the highest hazard ratio for rehospitalization of coronary event. After TAVR, ACS is infrequent, that is less than 5%. Occurrence of STEMI after TAVR is associated with a higher mortality. So 48%, it occurs in less than 5%, and 48% of the ACS admission occurs within 6 months of TAVR. STEMI was associated with a higher mortality, and invasive approaches significantly lower the long-term mortality. When the patient-related access, actually the coronary reaccess, the major problem, it discussed in detail, but I am not a very good guide to tell these points. So you should understand that you should choose a valve which is actually having the highest coronary accessibility, and definitely Sapien 3 and our own Indian valve, my valve, are the two favorable things. Unsuccessful other things are there. Overall, actually 7.7% is the unsuccessful coronary access in traditionally. Factors impacting the coronary reaccess after TAVR, these are the patient-related and TAVR-related. Challenges of PCI after TAVR, coronary access difficulty, increased procedural time and complexity, risk of the incomplete or failed PCI, higher need of adjunctive imaging technique, then potential for the coronary obstruction and hemodynamic instability, imaging limitation, and increased contrast or renal risk. Urgent PCI is performed in 2/3 of the PCI has ACS, and those patients urgent PCI was required, and selective engagement was achieved in 86% of the patients. That means technical success was 96%. Overall PCI success rate was very good. So the PCI registry telling procedural success of PCI was similar in post-TAVR patient, greater fluoroscopic time and a higher rate of stroke. And post-TAVR patients have increased risk of repeat PCI. So more radiation, bleeding and stroke. Stage PCI performed after TAVR is associated with the lowest rate of all-cause mortality of stages. PCI before TAVR, after TAVR combined. If you look at less reliable FFR and IFR assessment of borderline lesions. So recommended revascular strategy in any revascular strategy is indicated among patients with acute coronary syndrome, irrespective of the concomitant AS or AS. And conversely, the therapeutic benefit of the coronary revascularization among patients undergoing TAVR with a chronic disease is a matter of debate. So if you have ACS, no doubt. If you have CTO, no. If you have a frail patient, no. If your FFR is less than 80%, no. Basically, the PCI should be considered if FFR is less than 80.8, then diameter stenosis of more than 90% or LM stenosis. These are the situations it should be considered. So that is actually the patient. Diabetes is actually a vulnerable for SAVR. Basically, distribution of complexity of CAD again is SAVR plus CABG. Coronary access after TAVR will be a problem or a hostile, then SAVR. So these are the indications. When you go with a single, not a proximal LAD disease or a tight left main disease, isolated AVR, these things TAVR can be preferred. Complexity of the disease, definitely go for SAVR. These are the recommendations. Class 2-year recommendation is given for 90%, and these are the things. The PCI before TAVR should be performed in patients with CAD, severe CAD. The timing of the PCI is definitely with respect to the procedure should be based on the clinical presentation, patient's anatomical characteristics and lesion complexity. If PCI planned after TAVR, preserving easy coronary access. Decision making is because of the severity, symptoms, valve, coronary anatomy, heart team discussion. I'll show one case. Basically, again, this angiogram is on 3010 we have done. We can see there is a significant disease in the diagonal, as well as naturally I will be provoked by a CTO of the RCA. The patient came to me. We did a AL catheter taken. This is all before the TAVR. Already a valve is there. Actually, the patient came for a valve in valve. Balloon dilatation. Guy next crossed, CTO program, exchange to cyan black. Not a very complex case for a CTO. We put a stent, opened the vessel, but I was thinking the diagonal is a very simple lesion, cyan black, nothing happened. No stent was going. Remove the circumflex wire, nothing happens. Complexity started there. I used balloon, no effect. I used Wolverine cutting balloon, no effect. I did it. Rota there in the diagonal. You may ask that these things are required or not. May not be, we don't know. I put a stent, and then the same patient, we did a TAVR after 2 weeks. Ultrasound guidance, 2 proglides on either side, valve crossed. This is actually not done by me. I'm just telling, I'll be telling the who have done this case. Then mammoth balloon, dilated. Then naturally it's a Merrill valve. Make in India is done. Thank you. Special thanks to Ashish Kumar for doing this case. Thank you very much.
Okay. Pratap, excellent demonstration of the last cases. Particularly, we are very thankful to you. I want to any comment from them.
I think you're a champion of coronary revascularization. Your services would be more required for TAVI operators. All of them may not be able to do revascularization, but there's a great understanding that all coronary artery disease in severe aortic stenosis need not be treated before. That is the fundamental thing. If the presenting symptom is angina, even in presence of severe aortic stenosis, and if you have a blockage 90% or more, is a good one to treat, or a very proximal LAD 70% or more, or a left main disease, better to treat. And even if you can space them better. But there are also instances, sir, when you try and do, if they have a hypotension, they never come back. So you should be prepared to do an ad hoc, at least balloon valvuloplasty, if there is some hemodynamic instability in severe aortic stenosis, if they're present with acute coronary syndrome. This has been my experience. Any questions from the audience, please?
This is the oration we can discuss at the lunch time.
Yeah.
So no customer, no question and.
Thank you.
Okay, thank you very much.
That makes me happier, you know. There are no questions.
Thank you. Thank you.
One photo.
Big round of applause for our chairpersons, our honorable speaker, moderator, panelists. We move on to the next session, which will be an online presentation. As moderator of the next session will be the valve-in-valve TAVR. As moderator, I would like to invite on the dais Dr. Rajiv Menon, sir. The chairpersons, Dr. Shourav Kumar, Dr. Orijit Ghosh, and panelists, Dr. Dayanand Paswan, Dr. Shamshed Alam, Dr. Shubhodip Datta.
So before we go ahead, we take a moment to thank Dr. Ramesh Dagubati. It's 3 a.m. In US and sir is there, and we volunteered to change the timing, but he said the program flow should not be disturbed. We are very thankful to you, sir. And it's a packed house, and we are waiting to hear from you. Dr. Rajiv Menon will give the pretext.
I should tell one comment. Ramesh, actually seeing you in the night 3 a.m. from there, this fellow is not even sleeping. Please, man. After the talk, go and sleep, Ramesh.
I'll do that. Thank you very much, Dr. Pratap Kumar. Very nice to hear from you. And thank you, Dr. Dilip Kumar as well.
Yeah, Dr. Ramesh, good morning. Whatever time that is, 3 o'clock, it's like unhumanly time to give a talk. And again, thank you very much. I think without wasting much time, you can go ahead with your presentation. A very, very important topic of valve-in-valve TAVR.
Thank you very much, everyone. Good day. This is Ramesh Dagubati here, and I really appreciate Dr. Dilip Kumar and the team to give me this opportunity for presenting at a conference at SHAPE Summit. And I'll be talking about the valve-in-valve. Sorry about my title, slightly a typo in the title as well. Okay. I have no disclosures for this talk other than I'm actually a proctor for almost all the valve companies. So the valve-in-valve TAVR is an effective alternative to redo surgery in high or intermediate risk patients with failing tissue valves. However, this can be problematic with small surgical bioprosthetic valves because of further reduction in the effective orifice area, leading to high residual gradients. Okay. And so this is obviously how you put the frame in so that it overlaps one on each other. And actually then you can easily go and deploy any, this is an old Sapien valve, XT valve that is being deployed in the valve-in-valve. Okay. Somehow this slide is not playing, but you can understand that under rapid pacing, keep it at 180 or 200, whatever it requires. The mean arterial pressure has to be about 40 millimeters of mercury. And then you can easily deploy that valve under rapid pacing and then perform, in case if you need to, an iodogram based on the patient's creatinine, we use that, okay? So this case was just finished in 16 minutes, no general anesthesia, no TEE, no contrast, and the patient was discharged from the next day. So we don't use contrast all the time, just like in regular TAVR. You need to put in a pigtail. Here you don't need to put in a pigtail. You see the valve frame very nicely in RAO. Usually it will be an RAO caudal view that you can do a cusp overlap view and do that. And so it's very easy. So let's look at in the VIVID registry, which is the Valve-in-Valve International Data Registry, and what is the reason for mechanism of valve failure. In aortic stenosis, there will be pannus, thrombus, or calcification. But if the patient presents with AR, there will be usually a wear and tear of the leaflet. And as you can see here, or sometimes it could be endocarditis of the surgical valve. There will be two talks today. I know Dr. Anmol Sonovan is going to give about TAV in TAV, but I'll be talking mostly about the valve in surgical degenerated valve prosthesis, okay, which as you can see in the bottom. So when you look at these valve degenerations, and you need to look at the leaflet thickness, calcification, and whether there's any fibrosis or pannus. These three are the most important because as Dr. Pratap Kumar gave a talk on about coronary revascularization after TAVR, if you do need to revascularize, you need to understand, or do coronary protection, you need to understand about what is the thickness and what is the calcification load on the valve, whether you can do basilica, unicorn, or cleave type of procedures. And so this is a histological specimen that actually looking at the maximal thickness starts actually appearing after 2 years after a surgical valve. But obviously in trifecta, we have seen valve failures within 1 year. So for those people who think that surgical valves are really excellent, yes, there are types of valves, maybe Magna E's and which are really doing a Carpentier-Edwards type of valves, which are doing really excellent job. And they sometimes I've seen even up to 20 years after a valve that got degenerated. So I think as you can see here with the forceps that they are holding, the thickness of the original leaflet and then how thick it has become after some time. So these also will limit on whether there's calcification, and will also limit on the sizing of the valve inside that surgical valve, the durability, and how we can modify them, as I said, in leaflet modification. So this picture shows you that what is the actual true internal dimension of the valve in a newly placed surgical heart valve versus actually after some fibrosis, pannus, and calcification reduces that true ID as well. So you need to look at both the functional true ID takes valve degeneration into account and is therefore often smaller than the true ID. And so the modifications can happen because of this degeneration or a tear in a leaflet, and that actually becomes really horrible. And approaching them and trying to push these leaflets towards the coronaries can be really drastic for coronary obstruction. So, and this can actually lead to 1 year mortality after valve-in-valve TAVR. As you can see that if the started off with a smaller valve, the mortality is much higher, about 25%.
And if it is a large valve, the mortality can come down to 7%. And so the easy way is actually, first of all, you need to obtain an operative report and looking at it. But obviously, you can also do a valve-in-valve app, and based on whether it is aortic or mitral, you can actually identify on fluoroscopy majority of these valves, and you can download this app for yourself and look at the benefit. Okay. So let's look at the issues with the valve-in-valve. The success, number one, I think, and you are going to obviously come with a smaller EOA, that is effective orifice area, and the risk of coronary obstruction. These three are the issues with the valve-in-valve. The next one is actually valve in homograft. It is a valve, but it has been replaced. The whole root is taken out and replaced either from the pulmonic valve is then replaced in the aortic position and vice versa. And so those are actually really very difficult. I'll tell you why. But there's no need for anticoagulation. There are lower infection rates and higher rates of structural valve degeneration, because these valves are not meant to be in that position, so they can actually degenerate faster, and the valves are not meant to be exposed for high flow, high cardiac output, so they can degenerate. So there will be severe calcification of the entire root and the valve, and redo surgery leads to root replacement, and it's now used in patients with complex valve or root infections. And if you're looking at the bioprosthetic size, most of the time that actually is about 23 to 25 millimeter size bioprocessors that is there, and the majority of the time it's more than 10 years, and that's the structural heart valve degenerates. And let's look at the failure. The failure mode is stenosis in 55% of the patients, mixed in 21%, and regurgitation in 23%. And the types of bioprosthetic valve failures that happen is stented is in 92%, and stentless or homograft has 6%. So I think which is actually good, because both these homografts and stentless bioprosthetic valves make valve-in-valve implantation challenging, given that there's no frame or structural support to anchor the new transcatheter aortic valve. And we are truly based on depending upon the calcification. And the differences in mode of index valve failure, as well as the lack of radiographic markers to help with proper positioning, makes valve-in-valve challenging in both stentless valves or homografts. And so people at times place two pigtail catheters to know exactly where the position of the valve is and how coaxial we should be with that valve. So if it is stented, it is easier implantation, but you will end up with a lower effective orifice area due to crowding, and inner diameter is always smaller. Whereas if it is stentless valves, those are larger effective orifice area, and you get lower gradients, but there'll be significant calcification in the valve and the root, and a redo surgery can be very challenging in these patients. And due to the, I'll let you know that majority of the patients are in another from David Zhao from Atrium Health in Wake Forest. He looked at another stented versus stentless valves. These are small numbers, obviously. In stented valves, the failure is aortic stenosis. In stentless valves, the failure is aortic regurgitation. I just wanted to let you know that that's one of the reasons that you can look at in these people differently. And the malposition of the, it occurs mostly in stentless valves, okay? And whereas you are properly positioning in stented valves because of the frame. And second prosthesis is also required mostly in stentless valve because of the malpositioning, and coronary obstruction can happen more in stentless valves. And but the final gradients are obviously 17% in stented valves versus 11 millimeters in stentless valves. Okay. And so there are trifecta type of valves with stented valves with externally mounted leaflets, and the history risk of coronary obstruction is much higher in those trifecta type of patients with a 6%, versus other magna E's will come down to 0.7%. Okay. And how can we improve effective orifice area? So the idea is actually just think about it for those who are in the audience, coronary operators. You're placing sometimes a BRS, in the past, which is 300 microns, 150 on each side inside the vessel, and now you're trying to achieve a good effective orifice area. So we have to actually aggressively balloon fracture these valves, and some of these valves can be limited by its frame that it cannot be fractured. Okay, so which valves can be fractured, and what type of balloons will work, and what balloon pressures are required to each valve to be fractured, and does surgical valve fracture is possible without causing too much damage. So here is a true balloon. So that's the Magna valve, and it fractured with a 20 millimeters. Okay, so go 1 millimeters larger than the size of the valve to fracture the valve. So if it is 21, go with 22, and 22, 23 and such. Okay. And so in Magna Ease and Magna, both of them have the diaphragm sewing ring remains intact after fracture. So you can actually get a good orifice area with those. That the valves that cannot be fractured are Biocor Epic, Mitroflow, Edwards Magna, Magna Ease, and Medtronic Mosaic, and these are the valves that can be fractured. Okay, so that's one of the most important ones. And that the ones that cannot be fractured are unfortunately the trifecta and Hancock 2, which have been used actually quite in huge amounts until recently. The data came out that trifecta is failing very quickly, and so it was removed off the shelves about 3 years ago. Okay. And the technique is, what you need is Atlas Gold or true dilatation type of balloons. And these are really high pressure balloons. And you use a 60 cc Leo lock syringe, and you need to prepare them this way that the syringe is locked, and you inflate actually with the insufflator first, and then close it to the stopcock is closed, and then the rest you can inject through the syringe. Okay. And so either way, whichever you want to do, so that's one. Okay. Otherwise, people use syringe first and then insufflator. So with the balloon valve fractures, what we have seen is there will be decrease in gradient from 42. Initially, with the valve replacement itself comes down to 20, and from 20 it can be brought down to single digits with the balloon valve fracture. So you have to understand that you can do it either immediately before the TAVR valve is placed, or for safety, majority of the people do it after the TAVR valve is placed. I like to do it before, but that is a risk that you should be willing to take it. And the effective orifice area grows from 0.6 to 1.8 almost with the 3 times with the balloon valve fracture. So which type of patients you need to understand? If there is narrow sinuses and you don't have much of space and narrow STJ, coronary obstruction is a risk, is high. And in those patients, you might have to do a basilica type of procedure. So whether it is a supraannular stented valve, and as I showed earlier, one similar patient with an XT inside that stented valve caused coronary obstruction into the left main that has been saved with using an impella and opening up that coronary artery. And similarly here in nowadays we do coronary protection. We put a guide liner inside or sometimes a stent inside the coronary artery while slowly inflating the valve, and then actually you can take care of the left main in case if there is any obstruction, like in this patient, severe ST depression after TAVR, echo showed a low global hypokinesia, and patient became hypotensive. And so then you check for AI as well, because the wire might be obstructing and causing severe AI, making sure on echo there's no AI. And then immediately, deploying the stent is the easiest thing to do. And we call it a chimney stent, or so the stent is deployed and it has come above the stent valve frame. Okay, so you need to. So, and immediately EKG changes, hypotension and LV dysfunction have resolved. The mortality in coronary obstruction, if you are successful, comes down to 22%. And if they're unsuccessful PCI after coronary obstruction, the mortality is almost 100%. And I mean, obviously, small sample size of these patients because it doesn't occur that frequently. But in people who are women, balloon expandable valves have used small aortic roots. The coronary heights are less than 12 millimeters, and the VTC is less than 3 millimeters, actually, are the predictors of coronary obstruction. How do we prevent that? Is coronary a wire and guideliner inside the coronary artery, and also stent at times. And maybe you can use actually self-expandable valves and looking at 80% deployment and seeing what happens. If the coronaries are obstructed, then remove the valve and maybe actually aborting the procedure might help as well. And so the other point is that we talked about leaving high gradients. If the patients have high gradients, they end up with higher mortality. So if the gradient is more than 20 millimeters of mercury at the end of your TAVR, 16% mortality versus if it is less than 27.7% mortality. So valve in valve is good, but it actually sometimes you can end up with residual gradients high. If you're expecting higher residual gradients, like such as a patient processes mismatch already, and you're going to put in a smaller valve inside that smaller surgical valve, it is probably better to take a heart team approach and go with the replacement surgical redo of the TAVR valve. Okay. And so as you can see, this is after placement of a evolute and then inside a surgical valve, and balloon valve fracture is being done, and which has been first described by Adnan. And so that actually finally fractured that magnase. Again, one more time, that as we shown in this patient, after valve in valve, balloon valve fracture reduced the gradient by 50%. And this is a cartoon of about a basilica, how to do it. And as you can see, if the valve is not functioning well, and the risk of coronary obstruction is high, and so you can bring in a AL2 or 3 or 4. And the larger the AL size, the better it is. And traversing with an electrifying wire, and then I think electrosurgery is another talk that is going to be given at this wonderful conference, which you will see, hear about soon. Okay, and so with that, there's a risk of coronary obstruction becomes less. So in real life, actually, this is a patient that has actually a higher chance of coronary obstruction due to low coronary heights, and you put in a snare inside the ventricle along with the protection wire, like a V18 wire, for immediate placement of a valve after the basilica procedure is done. And so here is an AL3. And once you make sure that you're in the right leaflet here, we want it to be on the left coronary leaflet, and traversing with an astato, and it goes through easily, and then snaring that with the flying V has been created, and you can cause that tear in the leaflet, and after that a valve can be placed. Okay. So in summary, AI is more common than aortic stenosis, especially in stentless valves, and valve sizing is important, and getting the surgical valve data, if at all possible, I think it's most important. And you have to set the valve a bit lower than the usual skirting, sewing skirt, and oversize only if needed. Watch the coronaries, because oversizing will increase the risk of coronary obstruction as well. And careful placement and anatomical alignment are very important in all the valves, but in stentless valves, as I mentioned, it could be quite difficult at times. And in final conclusion is that the valve-in-valve TAVR is an acceptable alternative to surgery in selected patients. Long-term durability remains to be seen. The caution should be taken in high-risk groups, such as those with small valve size, stentless valves, homografts, etc. And a balloon valve fracture can be performed in patients with residual gradients, and a long-term follow-up is needed for valve-in-valve patients. And I do actually recommend anticoagulation for at least 3 months for these patients after valve-in-valve, just like surgical valves. With that, I'll stop here and I'll be happy to take any questions.
Thank you so much, Dr. Ramesh Dagupati. It was a wonderful talk. Just one comment and a question. The comment is most of the times we have issue about 19 mm trifecta here. Many of the SAVR patients in India, they have small annuli and they invariably come with 19 mm. One of the things we have noticed is when we use a supraannular design, we may not be able to fracture a trifecta, but we can always modify it. So when we post dilate with the Atlas Gold, the stent posts tend to open up, and that's the place where the third, fourth node are there. So we still get good gradients in spite of it being 19 mm. So I think probably doing non-compliant balloon dilatation as a routine after we put a valve in valve should be a standard practice, especially in the small annuli valves. And yeah, please go ahead.
No, absolutely. I think getting the largest effective orifice area is main focus here, especially in people with smaller surgical valves. We also should encourage the surgeons now to invite to such meetings and encourage them to do some root enlargement. At our center, the root enlargement when I joined was about maybe 3 to 5%. Now it is at 30%. So inviting them for a heart team approach before each valve that you're doing, making sure that they understand what are the problems you will be facing, in, especially in surgical valves, at least degenerated surgical valves before you do a tower, have a small heart team approach so that we can change their mind, by putting the data in front of them. I agree. And supraannular valve is what I usually like to do in these patients for better gradients.
And while we were discussing, actually, Dr. Anmol showed a case today where the surgical valve is totally canted, about 2 times AVR. Any specific preference from your side for balloon versus self-expandable valve in a canted surgical valve?
Yeah, I mean, number one, both these patients should be, whether it's small valves or canted valves, we should try to push the surgeons to operate, but in a surgically inoperable, as I think his patient was, and if it is a surgically inoperable patient, I still like to use actually a supraannular valve for better gradients, and but that particular patient, I think you're talking about, he is so canted and the risk of coronary obstruction is so high. And proceeding with protecting both the coronaries and the chimney stent might be easier in that patient, even though you are going to end up with higher gradients.
So, thanks again, Dr. Ramesh. This is Dr. Dilip. Just a small, comment. When there is a stentless valves which are there, and then the fluoro visibility is really a challenge, like Hancock and Mosaic. So, any tips and tricks from your side, especially if they are little canted, these stentless valves, then how exactly, challenge is and how you do see this patient,
Yeah, no, absolutely. Thank you very much for Dr. Dilip for that question. But so usually put some 2 pigtails, and in case if you are also worried about coronary obstruction, do a balloon inflation and aortogram at the same time to assess the risk of coronary obstruction. If the coronary obstruction is there, then you need to really make up your mind. Are you going to put a valve in or just abort the procedure? So if there is a risk of coronary obstruction in those patients, I actually protect the coronaries with the 2 stents and ready to deploy them at the same time, immediately after the valve deployment.
I was asking about the placement of the valve in these, where the fluoroscopy visibility is not very good, of these stentless valves like Hancock and Mosaic. And if it is tilted, then yeah.
So you say, for example, the valve is like this, put a pigtail here and a pigtail here. On both sides, there will be 2 pigtails, and make those coaxial, meaning they're in the same plane. So when you put in a pigtail, those 2 pigtails should be meeting at the same, bottom should be meeting at the same level. And then actually you can place, but if it is canted, even in those patients, I think the risk is much higher, surgical valves. And the stentless valves, the canting is not as much as stented valves are, and protecting them with coronaries is important. Yeah.
Sir, What is your take on one stent which has to be kept for coronary protection? Because at times people have used stents and second stent were required due to that osteal compromise of the lumen. So which stent you commonly use?
Because normally we try to be so flush, right? We are coronary interventionalists who became structural, and then we're trying to protect. In people who have coronary obstruction, you have to come above the frame. And so you need to use a longer, at least I say in your mind, if you're thinking about, the 13 millimeter stent, go 5 millimeters more, because you want that frame to extend above the stent frame. In balloon expandable valves, maybe it is okay to come a little bit back and it should be fine. But it's better to use one long stent, in my opinion, even if you're crossing the left main into LAD, crossover the circumflex, it is okay. So longer stent is better. So normally for these, I choose a 4/28 or 22. Minimum is 22 millimeters for the left main, and for RCA it's also same. Yeah.
So what is your preference, sir? A Megatron or Onyx kind of stent? Because the platform, we need a good radial strength. So what you commonly use?
I use Onyx mostly, but it's a choice of yours. But I choose Onyx most of the time. We have both of them on the shelf.
Thank you, sir.
Megatron and Onyx, but Onyx though.
Yeah, thank you again so much, Dr. Ramesh Ragupati, for staying up and then sharing your vast knowledge. Thank you so much.
Thank you. My pleasure. Thank you.
Big
We'll
round of
close the session
applause.
here. Thank you.
For our honorable speaker, chairpersons, and moderator. We move on to the next session. As moderator, this will be the coronary protection in TAVR session. As moderator, I would like to invite on the dais Dr. Anil Dhal, sir. Chairpersons, Dr. Abhishek Roy, Dr. P.S. Banerjee, and panelists, Dr. Dharmendra Kumar, Dr. Deepankar Mukherjee, Dr. Alok Majumdar. I request our moderator to please come on the dais.
Yeah. So we are going to start a very important session, that is the coronary protection in TAVR, and I will ask Dr. Anil Dhal to introduce the talk and then start the session.
So we all know that everybody, before they started our program, is mortally scared that they're going to occlude coronaries. The pressures will fall, the patient becomes ischemic, and all hell will break loose. But over the years, everybody has developed understanding of why this should not happen, how we can prevent it, how we can take preemptive steps before, so that we don't get into these troubles. And I think Amit is going to talk and tell us more about all of this.
Good morning, everybody. Thank you so much for having me over here, Dr. Dilip. And this is one of the most important talk I feel. And we should all understand why coronary protection is important. So coronary protection in, can't see my slides. Okay. So coronary obstruction is the most horrifying thing that you can ever have in TAVR. And I can tell you, once you have it, you will know why I'm saying this, because bailing out is extremely difficult, particularly in certain types of valve. So how do we actually manage it? First, to manage anything, you should know your enemy well. And what is the enemy? The enemy is the anatomy of the patient itself. That is the aortic root anatomy of the patient itself. So this is the coronary.
This is the virtual aortic annulus that we look at. The junction between the cusp and the root is called as STJ, sinotubular junction. These are the leaflets. Now, if we look at this structure, then where can the coronary obstruction occur? First, you will have to think about that. The first thing is, if the height is low, then there is a chance of coronary obstruction. And that initial height was supposed to be 12 millimeter when we started tower, but slowly we came down to 10 millimeter. But that 10 millimeter is looking at many things. And then what are the things that we look at? The first thing that you need to understand is if the leaflet length is more than the height of the coronary, you are going to have a coronary obstruction. Second, if the sinus of vessel diameter is not very large and the leaflet falls back, again it can go and close the coronary. So sinus of vessel diameter should be adequate. What should be the adequate sinus of vessel diameter? It depends. Usually what we say is the valve +2, it was discussed as 4, but it is +2. The reason is that 2 millimeter, you want the flow to occur, number one. The second thing, you need the catheter manipulation, and that tip of the catheter is usually 2 millimeter. So that is why we need that 2 millimeter. So the second thing is sinus of vessel bar. The third thing, suppose this STJ height is low and your coronary is between this. Your valve frame comes above that. Then again you are going to have a coronary obstruction. So STJ is the third thing. Now you can see that it's not a single factor that matters in the anatomy. It's all the factors you'll have to look at. Suppose you have a smaller sinus of vessel, you have a very narrow STJ, but your coronaries are starting above the STJ or just above so that the leaflet never reaches over there. Then still you can think, okay, I may get away with it. But in other sense, if the sinus of vessel is small, STJ is low, coronary heights are low, you're going to have a sure shot coronary obstruction. So this is the anatomy that we are looking at. The second thing is the valve that we are looking at, the type of valve. Now, a lot of people may think, okay, short frame valve and long frame valve, how does it matter? To me, it doesn't matter. But to a beginner, maybe it may matter. So if you take the height of the valve in a short frame, even if you are taking a 20 millimeter valve, it is roughly 17 millimeter. The leaflet comes to 17 millimeter. So in that case, again, if you have a smaller sinus of vessel, lower STJ, lower coronaries, no way you can get away with even a short frame valve. In that case, you cannot get away even with a long frame valve. Now, if you are thinking that accessing the coronaries can be easier with a short frame valve, suppose you put in a short frame valve and this strut directly comes in front of the coronaries. Believe me, it is extremely difficult to access the coronary because you will have to then use the wire to enter the coronary, take a microcatheter, then use a guideliner, putting it in a zigzag way and finish off your intervention. So these are the things that you need to keep in mind whenever you are accessing the coronaries, whenever you are looking at the coronary occlusion or not. Now look at this case. You have a very, very narrow effaced sinuses, less than 25 millimeter. Coronary height is less than 10, 7.4 and 7.5. Calcified valve. Now in this case, if you're going to look at these kind of coronaries, this is a sure shot coronary occlusion case. So what are you going to think? You need some kind of coronary protection. What are the ways you can protect the coronaries? Now again, you should start thinking how you are going to protect it. The first thing is you want to put away the leaflet. How are you going to put away the leaflet? By the use of stent. So you want to put away the leaflet. If you are going to put this stent exactly at the ostium, the leaflet will still not be put away. So you need to pull the stent above the stent frame so that the leaflet is down and the coronary flows still occurs. That is chimney stenting, number one. Number two, what you can do is you can split the leaflet. Now, splitting the leaflet, what will happen? This leaflet will get split, and the flow to the coronary will still occur. So, how can you split the leaflet? There are procedures like Basilica, in which you split the leaflet by electrosurgery. Shortcut, which is a dedicated device to split the leaflet. And the third is the unicorn procedure. Just like the Batman that we do in the mitral, we can do unicorn in the case of aortic position, in which again we actually lacerate the leaflet with a small balloon, put in the valve and deploy the valve. Now, how are you going to decide whether it is going to be a chimney or a leaflet? You can do anything that you are comfortable with. Believe me, do what you are comfortable with. Because none of the studies have shown any difference between chimney stenting or a basilica or a leaflet splitting type of procedure. So, if you have a very, very effaced sinuses, then if you are thinking that you are going to split the leaflet and get away, you cannot get away by doing that. You will have to do a chimney stenting. But if the coronary height is low, you have a good sinus vessel, then in that case you can split the leaflet. Also, you will have to look at the STJ. If there is, after putting the valve, if you have a distance of 2 millimeter between the STJ and the valve, then the flow will still occur. And that way you can have a coronary flow going. So that is two things that you will have to keep in mind. Very effaced sinus, do a chimney. Good sinus of Veselva with a good STJ distance of 2 millimeter, go for any leaflet splitting technique. Now coming back to the old case. Now here you have a very effaced sinus. If you are going to do any kind of splitting technique, this is not going to work. So what we did is we put a stent on either side, deployed the valve, pull back the left stent, pull back the right stent, and then you can see the coronaries are flowing. Now look at this case. It's a valve in a valve case. In a valve case, there is another angle that you will have to look at. You can see the valve is there. The valve is almost occupying the complete sinus. So you see the coronary height. It is 4.3 on the left side, 8.7 on the right side. It's your sort coronary occlusion. The VTC distance I have not shown in this. It was 1.8 on one side and 2.3 on the other side. So we decided to protect the coronaries, of course, and go ahead. So that's the coronaries on either side. When we saw the coronary, we felt that we may get away, but still we put a stent on either side. Deployed the valve. After deploying the valve, took injections, saw good flow in the coronaries, both coronaries. Then slowly retrieved both the stent. Because we knew here that the coronaries were flowing, the sinuses were good. This case, we got away without putting any stent. 5 years follow-up, the patient is doing good. This is how a Basilica is done. You put a AL catheter in the sinus that you want to go, and then what you do is you put another snare in the LV, electrify it, let the snare come down, and then you snare the A-stato wire outside. After you snare the A-stato wire, just scrap the portion distal end, make a flying V over there. This is how you make a flying V. And after you make a flying V, you go ahead, and then when the flying V reaches over there, electrify it, electrocautery, do a electrocautery, and then split, and then you can finish up the procedure. Now, the second one is the unicorn procedure. It is a much simpler procedure. What we do is, again, electrocautery, get into the LV. After you get into the LV, you use a balloon over there, lacerate the leaflet completely, and after you lacerate the leaflet, you deploy the valve. Now, what is the difference between a Basilica and a unicorn laceration? A unicorn laceration gives a larger area for the coronaries to fill than a Basilica. In a Basilica, you don't know exactly where you are splitting the leaflet. So if you are doing a basilica, still there is 5% chance of coronary obstruction. But with a unicorn, that is done away because you are completely avulsing the leaflet. There is also a technique by which you can put a snare and then actually scrape away the whole leaflet and then deploy a valve. It's just like the unicorn, but here you are using a multi-snare and then you are taking away the leaflet through the guiding catheter. This can a unicorn be done not in valve in a native valve? Yes, it can be done even in a native valve. People have used as a coronary protection. People have used in a bicuspid aortic valve where you can do a unicorn, convert it to a tricuspid or completely avulse it so that you get a good effective orifice area in these patients. And this is a unicorn in what is called as native valve. This is shortcut video. It's not still available in India. The cost of the valve and the cost of the shortcut is the same. What you do is you take in the device, you open the device, and then you direct the device into the leaflet that you want to cut. And once you reach to the desired place, you open up the knife that is there. You engage the knife and then you just pull the knife. That will cut the leaflet. It is similar to basilica but more controlled. You know where you are cutting. So you can exactly cut in the middle because this is an echo plus a fluoro-guided procedure. To conclude, coronary obstruction is horrifying. MSCT is your best friend. Reanalyze, and do it again if required. And then think about what way you are going to protect the coronary. Aortography valvuloplasty may be helpful, but believe me, even with this, if your CT says that you are going to have a coronary obstruction, please protect the coronary. Because sometimes what happens is when the balloon alignment is low, the right coronary will look like it is going to get closed. You may protect that right. You should protect that right. But then at the end, you will find that the coronary is still flowing and you may pull out the stent. There are various techniques for coronary protection. Master one and use that again and again. All techniques have pros and cons. So you need to master only one. Choose the best that is suited for you. These are all from experience. Thank you so much.
Again,
Any question?
great talk. So, if there any question, yeah, because yes, Devdatto, then Menon, yeah. First, because no,
I had my first coronary obstruction in
Order.
2014.
Order. First because then Devuda, then Menon. Yeah. Mic on karo bhai. Yeah.
Hello.
Yeah.
Thank you, Amit, for your excellent presentation. So it gives an overview of how we are going to protect the coronaries. Just one question. So every case when you're doing chimney, would you use guideliner as well on the top of the guide? Or you
No,
don't?
I actually see. I don't use a guideliner in every cases. It depends.
Not in every case.
Not in
Right.
every cases.
Now, and again, when you are measuring the leaflet, what's your comfort length of leaflet where you think that coronary protection
I
is not
see
not
the
necessary?
height of the coronary and the length of the leaflet. If the length of the leaflet is more than the height of the coronaries, then I know that I'm in trouble. Number one. But if the sinus of Veselva is large and the leaflet height is just 1 millimeter, I take the liberty thinking that it may not get closed.
Thank you.
Devuda, yeah. Mike.
Is part of your assessment. So you are looking at the leaflet, at the length of the leaflet, and say the leaflet is not very calcified as opposed to it is really calcified with a chunky calcium. Will it make any difference in your approach?
So there are two things that you should keep in mind. The leaflet can be either fibrotic or it could be calcific. Fibrotic leaflet don't fall back. They stay over there. So I take the liberty that it may not get occluded. Leaflet tip calcium is dangerous because when the coronary filling occurs, due to that pressure, it pulls back the leaflet. And my first coronary occlusion occurred because of that in 2014. It was a right coronary occlusion. I didn't show that case. I thought it could be because of, the calcium, huge chunk of calcium would have gone and occluded. But when we ballooned it, the calcium did not move. Then we knew it was something else and we stented it. 2014, we all were learning.
Right.
And in that era, actually, a Japanese operator showed with IVUS that it's the leaflet that goes and falls.
Ajit, sorry, Rajib.
Yeah, suppose we have a self-expandable valve, we are suspecting coronary occlusion, we have deployed the self-expanding valve. There is suspicion that once we remove the wire and all, there could be occlusion. Do you recross within the stent frame and then deploy the chimney stent versus put the chimney stent behind the frame? Because there's some thought process that if we go through the stent, the TAVR frame, and then deploy, probably the long-term outcomes might be better rather than keeping it beyond the frame.
So there is two ways of thinking it. If a valve is deep in and you have a wire through it, first wire, you can actually try to do what you are saying, go through the valve and then recross with a wire and then stent from the coronary into the valve. That is one way. But suppose you have deployed the valve higher. Then what happens is the valve leaflet is going to interact with the stent. In those cases, I think it is better to do the snorkel or the chimney technique inside rather than doing the technique you are explaining.
Girish.
Thank you.
I think great, Rajiv. In my opinion, keeping a guideliner always helps because moving the stent smoothly beyond the frame. Once if you come in, you want to go out or you want to pull back, the frame may restrict withdrawing of the stent or it may deform the stent. So I normally keep guideliner all the time. Second, if you want to know, as Rajiv says, what may happen now that I have withdrawn the stent, it's still filling. But if I take out my coronary wire or a guideliner, would it close? What options would I have? In which case, I think you can just withdraw the guideliner just into the outside the frame, but outside of the left main as well. But leave the guideliner in between so that you can again negotiate back into the left main. It gives you that option. And also during pre-dilation, if you use a slightly bigger balloon and see where that leaflet goes, if it is covering more than 20-30% of the ostium, I think we should be a little more cautious.
Those are great points, and I would like to say that guideliner is a great help. The guideliner is there because of its atraumatic tip, and that does not harm the what is called as left main. Even with guideliner, there has been case reports wherein you pull back the guideliner, try to position the stent, and then you realize that you are not able to pull back the stent.
But inside of the guideliner, stent will always move smoothly.
Yeah, that's there.
Without the guideliner, it's difficult to.
It's the situation wherein you want to see whether the coronaries get occluded or not.
Right. Last question.
Okay.
Because Anilda.
What is the risk of the self-expandable stent moving a little bit when you are withdrawing the guideliner?
No, it doesn't. No. Usually it doesn't. There has been case report where the stent has moved. I don't know how, because it requires a great force to pull. In the past days, we have tried putting a snare, trying to hold both the eyes and pull. I can tell you, it requires the first bench testing when Renu Birmani did. When they deployed the valve, it required 2 kg of force to pull out that valve. So that's the difference.
Amit, last question I meant to answer. The statement is the sequestration, sequestration of the valsalva or deficit of the valsalva is only feasible for the Basilica procedure. Why it is? Only there are two situations. One the deficient of sinus valsalva, another situation sequestration of the sinus valsalva, and these two situations Basilica procedure only feasible. Please explain.
So Basilica, if you see, if the sinus vessel is large and STJ is good, in those cases Basilica is excellent, because the leaflet is going to get turned and it is going to go this way. But suppose you have a very sequestered sinus, then the leaflet is going to go jam the coronary. In those cases, I don't know if this may be a great solution.
Thank you. I think we have a next presentation on
Conclude.
electrosurgery.
Yeah,
So
we'll conclude.
Thank you very
I
much.
was just going to say that with so many towers being done, the nightmare of every young cardiologist is going to be that they're called for a primary in the middle of the night. And they would probably have a post-tower patient who has the frame of a tower. So any tips for some of our younger colleagues as to how to access those coronaries in a post-tower STEMI, which may come in the middle of the night?
The best way to re-access the coronary is just take a normal 035 wire, put it in the sinus, take a guide. When it reaches the sinus, just pull back the wire. Let the guide fall in any of the struts. If you are taking, I'm talking about the long frame in this case. Let the guide fall into any of the struts, and after it falls, take a wire. You can take a guide liner and a wire and a microcatheter. With the help, you enter into the coronaries, push your microcatheter. You can also use a balloon. Push the balloon, engage the balloon, then push the what is called as guide liner inside it, and then you can, it is easy, you can finish up the procedure. The second thing is, like the present today, commissural alignment has made life easy. You can actually cannulate anything. The problem is, in the old days, when we used to think higher the valve, the lower the, higher the effective orifice area, so we are placing the valve higher. In doing so, what we are doing is actually placing the valve, the neosinus, what we are making with above the coronaries. And in those coronaries, it's a real nightmare to enter the coronary.
So thank you very much, Dr. Chaurashia, for excellent presentation on the topic. So we'll conclude the session and give a big hand to the speaker.
But I had to make a comment that Basilica is not the end, because even if we have done Basilica, there can still be obstruction. So we have to be ready with the coronary protection. I think 70-80% of cases are like that. So we can't just rely on single Basilica. And the commissioner posts are towards the coronary, Basilica is not going to work.
Thank you so much. We end the session over here. Big round of applause for our chairpersons, panelists and speaker. We move on to the next session, that is electrosurgery in TAVR. As moderator, I would like to invite on the dais Dr. Srinivasa Prasad sir, chairperson Dr. Vishwakesh Majumdar, Dr. Ranjan Sharma, and panelist Dr. Debargho Dua, Dr. Ritvik Ghoshal, Dr. Shiv Shankar Sharkar.
So, may I invite Dr. Prashant for his talk on electrosurgery in TAVR. In the last session, what we saw was the coronary, the aortic leaflets can pose a risk for a coronary occlusion, or the STJ sequestration, or sinus sequestration, can pose a coronary obstruction risk. So here comes a way to split this coronaries or alter the leaflet coming in the way of coronary flow mechanically, and thereby we can protect their flow. So over to you, Dr. Prashant.
Thank you. Thank you. So my task has already been simplified by the Dr. Amit Chaurasia and Dr. Ramesh Daggubati. So I will be more focused on the real concept of electrosurgery rather than the procedure aspect. So what is the concept of electrosurgery is? So electrosurgery refers to the delivery of high frequency alternating current through the guide wire or a catheter to traverse or cut the tissue. We can use the monoplane or the bipolar mode, but the monopolar being used mostly. And it is not an electrocautery. There is two difference between the electrocautery and the electrosurgery, where the electrocautery is basically, it leads to the heat and coagulates the tissue. But electrosurgery, we usually have a true cut mechanism. So there are two different mechanisms. One is tissue traversal and one is tissue laceration and excision. So with coaxial microcatheter, when we along with the coaxial microcatheter, the guide wire tip charge the concentration, that is a tissue traversal. So basically we have to go from, we have to pierce the tissue and we have to go from one side to other side, that is a tissue traversal. Then what is tissue laceration? We have already crossed from one side to other side by the tissue traversal, and then now we are lacerating that tissue from in the side by side. That is a tissue laceration or the excision. So these are the two different concepts which is usually applied in the electrosurgery. So there are two different mode we usually have, a cut mode and the coagulation mode. So we usually need to have a yellow one, that is a cut mode, that is a true cut mode. So what is the concept? So what happens when the temperature is somewhere around 49 degrees centigrade, the tissue coagulates. If it's somewhere around 70, the cell desiccates, and if it's 100 degrees centigrade, the cell ruptures from the vaporization of the intracellular water. And this is what we need. We want the vaporization of the intracellular water so that the tissue, the cell ruptures. The goal is vaporization and not the thermal coagulation. And so basically what we have to do is we have to give a concentrated energy at a single point of focus so that the tissue can be traversed by the wire. So when the concentrated energy is given by the guide wire tip, it is a tissue traversal, while in the tissue laceration or excision, we need to use a flying V wire which can lacerate the tissue. So there are different aspect of electrosurgery we can use in the transseptal puncture, transcaval puncture for the tissue traversal, and in the basilica, while the tissue laceration is used in the basilica or even in the lampoon and CSME and other procedures. So the tissue traversal, the energy is being charged over the guide wire tip. What is the concept? What we need is we need insulation. So that's why we need to put one large guide. Inside of that large guide, we need to put one diagnostic catheter, that is a mother and child technique, so that we can position the guide catheter where exactly we want to traverse the tissue. So then for the positioning perspective, we need to put the guide catheter and the diagnostic catheter. And inside of that diagnostic catheter, we need to put the microcatheter for the insulation perspective. So once we put this microcatheter, then we put a stiff wire, and this stiff wire has to be at the direct contact of the tissue. And so this microcatheter is basically giving a more insulation. So what exactly is happening, that if we keep the insulation from up to the wire tip, so all the energy is going to traverse at the single point of focus, so that we can get a maximum energy at a single point, so that we can traverse the tissue. So if there is a bad insulation, current leaks into the blood and there will be no traversal. But if there is a good insulation, the current concentrated at the wire tip and there will be easy traversal. Then how to increase that concentrated energy at single point? So what happens when the energy comes in the contact of blood or the saline, the energy dissipates in different direction. So what is the concept is, when we are doing it, do a dextrose 5% saline infusion. So what will happen, all the energy will be transmitted directly over the place where we want to. So you can see in this diagram, then when the tissue is not, the wire is not in the direct contact with the tissue, and if it in between there is a blood, the energy is being dissipated. While when it's coming directly with the contact of the tissue, as well as there is a dextrose infusion, then the energy will be directly transmitted to the point of focus. So this is what the usual assembly for the tissue traversal. What we need to do is, the distal end of the wire, we need to denude it, we need to remove that coating, and then we have to connect it with the alligator forceps, and then with the electrocautery with a true cut mechanism. Then this is a guide catheter, usually a larger guide catheter. Usually for the left side, we use a 8 French or a 7 French, AL1, AL2, AL3, depending on the sinus size. Then inside of this, we usually keep a diagnostic catheter, usually a 5 French multi-purpose or a JR diagnostic catheter. And inside this, we usually keep a one piggyback or any of microcatheter like a fine cross, which uses as an insulation mechanism. And inside of this, we usually keep a estato extra support wire, usually a 300 centimeter wire. So this is all the concept for the tissue traversal. So this is what we have to do is, so this is the AL guide. Inside of this there is a diagnostic catheter, and inside of this there is a micro catheter, and then a point of focus is being identified, and then energy is transmitted, and then the tissue is being traversed. Then what about the tissue laceration and excision? It is a flying V, which the inner curve of the flying V basically is being charged, and that leads to the tissue traversal. So how to make a flying V? What we need to do is, we need to at the middle of the wire, we need to focally denude the guide wire with the scalpel, and then kink the mid shaft using the back of the scalpel, and that will make a flying V. So what is the concept is, now how to charge the density at the flying V with the highest concentration energy. So what we need to do is, we need to do three things. First is inner surface denudation, which is I have already explained that we need to denude the inner surface. Second thing, insulating catheter, like a guide catheter, diagnostic catheter, and the micro catheter, and then a dextrose flush. All these three will lead to the highest charge density and tissue laceration. So this is the concept. This is the usually these all catheters and wires and everything is required for the tissue laceration. So you can see there is a 8 French traversal sheath, and inside of this there is a micro catheter, and inside of this there is a extrato wire. On the other side there is a guide catheter along with a snare and the 5% dextrosaline on both the guide catheter. So this is a usual concept. That's how we have to do it. So why electrosurgery is required? It is required to prevent coronary obstruction in the tower, to prevent. Sorry, sir. So first so there are two different steps. One is tissue traversal. So at the time of tissue traversal, you just do the tissue traversal, and you do a denudation outside of the at the outer end of the wire to transmit the charge. But at the time of tissue laceration, once you crossed it, you snared it, and then hold it, and now at the outside of the wire, you need to denude it and make a V. Outside of the body, you need to make a V, and then and on one side you have to pull the snare, and from the other side you have to push that V, so that you want that V, that flying V has to be reached at the site of the tissue laceration. So where exactly we want that, at that place we have to
somewhere approximately middle of the wire, because it's a double length.
Exactly, at the middle of the wire. So to prevent coronary obstruction in the tower, to prevent the LV obstruction in TMBR, to gain the access in the transcable tower, in the transseptal puncture. So the electrosurgery in transcatheter electrosurgery is expanding indications. And so basically in tower perspective, it is usually applied when there is a high predicted risk of coronary obstruction on the CT planning. There are two different mechanisms. One is basilica, one is unicorn. It's been already shown that it's an electrified guide wire is used to traverse and then lacerate the aortic wall leaflet. So what exactly is being done is, we need to keep one snare inside the LVOT, and usually the snare size is decided by the LVOT size. If LVOT is somewhere around 18, keep the snare of 20. If LVOT is somewhere around 20, 23, keep the snare of somewhere around 25. So this is how we have to decide the size of the snare. Then we have to traverse the tissue. Suppose it's the left-sided basilica, traverse the tissue, then we snare it, and then we need to make a flying V. So at this point of time, outside of the body, at the middle of the wire, we need to denude the wire, make a kink, make a V, and then on one side we need to pull this whole system with the snare, and the opposite side we need to push, so that the flying V which was made outside will come at this level. And then we have to make it a cut. So this is all the equipment which is required. So large sheath, wire, microcatheter, traversal system, snare system, and the electrosurgery generator. Usually the 50 to 70 watt cut mode is required. For the traversal, it's usually 30 to 50 is required. For the laceration, we need around 50 to 70. So these are the steps. So the axis then the snare system positioning, then the traversal system positioning, then leaflet traversal, then snaring. Then what we need to do is we have to make a V-shape formation and then delivery of the energy and then a leaflet laceration, and then we need to proceed with the tower, and then the post-tower assessment is required. So overall the steps are: first, apply a dispersive ground pad, then prepare the traversal system including guide catheter, microcatheter and the stiff wire, then connect the wire with the alligator and the generator, then keep it in the setting of cut mode. The procedure relies on the cutting rather than the coagulation strategy. Then go for a leaflet traversal, then create the flying V, then leaflet laceration and the cut mode 50 to 70 watt with flush with dextrose 5% solution, and then proceed with the tower. So one more important point is we need to, when we are doing it, we need to identify the two pre-planned orthogonal CT view, because we need to cut it in the middle of the leaflet. So we have to identify that. So it's the frontal view which will gives us an idea that our catheter is in the middle, and it is a side view which gives us an idea that we are on the left side of the cusp leaflet. So then the trajectory is also important. So suppose your catheter is directing like this, there is a possibility that wire may traverse and it may go into the left atrium. So you have to make sure that your trajectory should be directed on this side towards the LVOT rather than not going towards the septum. So the common reason basilica fails: wire not touching the leaflet, catheter too far from the leaflet base, heavily calcification, saline instead of dextrose 5%, and poor grounding pad contact. So there are different, these are the different example. This is a left basilica. This is in a patient with a prior tower valve, and this is an example of the valve in wall, and this is another example is of native valve. So what we are doing is we are tissue traversal, then making a flying V, and then traversing, and then laceration, and then followed by valve deployment. So complications: perforation, embolization of tissue fragments, stroke risk is very high, coronary injury, conduction disturbances, and cardiac tamponades. Ideally, these patients has to be, these procedure has to be performed with a prevention, with a carotid protection. Unfortunately, Sentinel device is no more in India. So we have to do it with a normal filter which we use for the carotid intervention. Then another is the unicorn or the modified unicorn. So basically the difference in unicorn and the basilica is, in unicorn, what we do is after the tissue traversal, what we do is we lacerate the leaflet by the balloon. So we do a sequential balloon dilatation. So we took the axis, traverse the system, we go from the ascending aorta to from the LV, then we leaflet traverse, coronary balloon dilatation, and then we switch to O35 wire and leads to larger balloon dilatation, and then we deploy the valve inside of that leaflet traverse. So this is the example of the unicorn tower, which is what we are doing it. So we have tissue traversal, then the sequential balloon dilatation on one leaflet, and then the valve is being deployed on the same valve. So then the concept is also applicable for the transcable tower. The electrosurgical is sometimes required when there is other peripheral vessels are not amenable. So the take-home message: electrosurgery has transformed the management of challenging tower anatomies. Applications of electrosurgery in structural heart intervention is expanding. Success depends on careful pre-procedure planning. The contemporary leaflet modification strategy like basilica, unicorn, lambcorn provide effective options to prevent coronary obstruction, but it's not absolute, because even if we do a good basilica, we might need to do a coronary protection with a stent as a bailout strategy, because sometimes we never know how the basilica has cut. There might be possibility that even after the basilica there might be a coronary obstruction. So the electrosurgery should be viewed as a precision adjunct but not as a substitute. Thank you.
Yeah. So thank you, Dr. Prashant. That was quite elaborative and quite an extensive one. So in view of shortage of time, we'll take some couple of questions. If not, I'll make one comment and then I'll make. So whenever we plan for any of this electrosurgical or coronary protection strategies, it is always the CT which is going to play a major role. We need to know which leaflet we are going to modify and whether splitting that leaflet in between is going to protect our coronary. That means to say that there should be a coronary centricity. The coronary is eccentric. Even if you split the leaflet in between, it may not be helpful. Similarly, if the valve posts are against the coronary, then obviously basilica may not help us. So then usually you should pursue the other ones. And then planning your angles, depth, and other things are very, very important. Planning trajectory is very, very important. If not, wire can enter other chambers. For a left, it can enter left atrium, and that is still okay. When you are doing a right, most commonly either it is going to hit an interventricular septum and trigger a VT, or it will go into RVOT, which if you don't realize and pass a balloon or other device, microcatheter, so it can cause a small RSOV also. So these should be kept in mind. I think with this we'll stop in view of time and probably we'll discuss it further again. Thank you all.
Thank you.
Big round of applause for our speaker, our chairperson moderator. We move on to the next session, TAV in TAV. As moderator, I would like to invite Dr. Anil Dhal sir once again on the dais, and chairperson, Dr. Shomik Chaudhuri, Dr. BP Chatterjee, panelists, Dr. Anand Kumar Pandey, Dr. Oriam Kaur, Dr. Sumit Shankar.
There's too much of packed learning in, and but I think it's a very exciting concept, and I must compliment Dilip for having put it all together and got some really focused force happening here. Nobody else is here, so may I request Anmol to start off with his tower in tower. We've already had a presentation, but I think you can clarify many of the doubts.
Yeah, I think good afternoon and thank you so much, Dr. Dilip Kumar, for a wonderful concept of sharing knowledge and teaching and spreading it. So I think the stage has already been set. Dr. Ramesh Dagubati, we started with a normal tower, then tower in SAVR, and now the coronary protection, multiple things. We realized that the coronary obstruction is one of the most dreaded thing what anyone can see or experience during this kind of procedure. And mortality, if you see, it is almost 60% if even with rescue, and 100% if not been rescued. So now we are moving to the more difficult subject, tower in tower. So if you see, the numbers started growing in last 2 years, and the numbers almost doubled. But what we started seeing, the 5.5% of the tower devices are degenerating in 6 years, and almost 10% are degenerating in 7 years, and they required a re-intervention. If you see, the more common phenomena of degeneration is regurgitant. Almost 6% of the people come with regurgitant failure. If you see, even the partner low risk cohort, the aortic valve tower in tower reintervention at the end of 5 years is almost 2.2 to 2.6%. So this is what I was saying. If you see the numbers from 2020 to 2025, the number almost double. We crossed from 500 to 10,000 towers in a year, and we are going to see this subset of tower in tower quite often in our routine practice. Tower in SAVR has been well studied, but this is still the new subject what we have to do a lot of learning. Current experience, if you see, it is very small. The number of patients what we are tackling as of today is less than 1% per TAV in TAV. So we are talking more about it. Numbers are very small currently. The implant experience is very limited, even with the operators at the larger centers. And early phase of optimizing and sharing our experiences and pool gathering learning will be helpful. So why it is important and how it is different? Dagubati Ramesh has already shared. TAV in SAV is pretty well standardized because it is quite easy because the valve is well implanted at the annulus. Surgeons have implanted valve at the annulus. Valve have a similar, almost all the type of surgical valve, if you see the height of this valve is similar. And the valve dimensions, like what is the exact inner dimension, we have done an extensive bench testing and everything, and we come out to the true ID, and we decide our transcatheter valve, which we are going to put in TAV in SAV from the true ID. But contrary to this, why it is not similar like TAV in SAV and TAV in TAV? The TAV in TAV is very different because the depth of implant varies completely. Somebody is deploying at 0, somebody at 3, somebody is into sinus, somebody is 5. So it varies depending on the device and the platform. The valve have a different structure. It is not a unanimous height. We have a short frame valve, we have a long frame valve. Some are 45, some are 55. And leaflet positioning in that tower prosthesis is also very different. And if what we learned in vitro sizing as well as in vivo sizing, the shape and size is very different. We are going to know and learn these terminologies which can be helpful for TAV in TAV. The commissure, the leaflet outflow attachment is called a commissure, which will be vary for a short frame valve and a long frame valve. VTC, it is a valve to coronary distance, but it is a valve which is a virtual valve what we are going to put it. That valve to the coronary distance is called as VTC. Then the risk plane. See, the risk plane is the plane at the level where the stent frame of the first transcatheter valve, which become a tube graft or a cover stent after putting a second tower prosthesis there. And a VTA is a valve to aorta distance. We'll come to know in subsequent conversation what are the implications and what are the importance of this all new terminology and measurements. See, what is important in redo tower or TAV in TAV and what we have to consider. First problem is which is the second transcatheter heart valve we are going to use in given tower situation. Second is what size. Third is prevention of coronary complication, because this is the most dreaded subset where the coronary complication, if it happens, we don't have any rescue. And the fourth important thing is putting a valve and rescuing coronary and everything is okay, but that valve should function. So optimum positioning and even the functioning is very important, because too lower deployment will give rise to leaflet overhang and the purpose will not suffice, and too much high deployment will cause an coronary obstruction which will never going to salvage. So you have to understand before thinking about TAV in TAV, we are going to create a tube graft in front of the coronary, because there is a covered portion of the stent and then your leaflet are going to stand still and going to cover the complete stent frame. It varies, the distance will vary depending on the platform which has been used at the first time, whether it is a balloon expandable or a self-expandable. It is more challenging and more cumbersome with a self-expandable platform for subsequent TAV in TAV. So what are the landmarks which are important for tower device, which can help us? See, the landmark which is going to give us a leaflet height, where to measure for the sizing, and what is the coronary risk plane. For a balloon expandable valve, you can see the leaflet is going to go for whether my valve or Sapien, it is the commissural tab. The top end of the commissural tab is going to be your complete neoskirt plane or a tube graft plane. For self-expandable, when I'm talking about balloon expandable, it is a commissural post. And for self-expandable platform, it is node. So start getting acclimatized to these terminologies as well as the node. So self-expandable platform, we start about, this is 0 node, then every junction is 1 node. This is node 1, 2, 3, 4, 5, 6. So you are going to create a cover stent till the node 6. So this is what, if you put and do a TAV in TAV, this is about the tube graft what we are going to create in front of the coronary osteums. And for accurate neo, which has been withdrawn, but what are the implant has been done in the past, if they come and degenerate in future and come back to us, you have to understand. Here, the bottom of the commissural tab, till that level, you are going to create a cover tube graft. So, you are landing into, depending on which of the valve has been used, there are only 4 combination or situations what you can see in your practice when you are addressing a case of TAV in TAV. Either you are going to put a short frame into a short frame, you are going to put a tall frame valve into the tall frame valve, Third is you are going to put a tall frame valve into the short frame valve, or you are going to put a short frame valve into the tall frame valve. These are the only 4 situations what you are going to get. But why this is important? See, these are the just and what once you put a time and time, how they are going to look it. But see, what is important in 3 situations when you are going to put a short frame in short frame, or tall frame in short frame, or a tall frame in tall frame, your neo-skirt plane is constant. You will not be able to modify it at all. Whatever the cover stand or tube graph you are going to create, it will be constant. Tall in tall situation you will not face because it is the most dreaded thing, and you will always land up into the 4th situation, short in tall. You are going to use a short frame valve into the tall frame valve which has been used in the first case. So the 4th situation, if you are going to use a short frame valve into the tall frame valve, then the neo-skirt, the tube graft, you have if you position the valve at a different node level, then you can modify and you can reduce the covered portion and a tube graft, and you can have an escape for the coronary perfusion. So this is the concept. If you use and deploy your valve at the 6, there will be a complete tube graft till the node 6. If you deploy your valve at node 5, then you can have little lesser cover portion, and node 4 it is less covered portion. Why it is important, I will tell you in subsequent slides. So why it is important? See, if you put a valve 2 up, there will be, it is a trade-off. It is a less leaflet overhang, but high risk coronary risk plane. So what is a coronary risk plane? This we have to understand. The neo-skirt plane, that is a tube graft plane, if it is above the coronary, then you are going to have a big trouble. Your coronaries are not going to fill. So this is a coronary risk plane. I think I'll take some time for a few minutes extra because it is a very complex thing to explain in a very limited slides. So the coronary risk plane is the lower portion of the coronary artery which arises from the annular plane. And then that plane is a virtual plane, what you will get it. You have to study it. It is arising at which node? Because you know your coronary neo-skirt plane is at this level, and if your coronary plane is lower than that, you are going to have a complete coronary obstruction. So just take an example. If your coronary risk plane, that the coronary ostium are coming at the node 4, then this is your node 4 is your coronary risk plane. If your valve neo-skirt plane is, if you deploy the valve at node 6, you are going to create a complete cover stand in front of the coronary ostium. Then the risk of both the coronaries will get occluded will be very high. If you deploy your valve at node 5, then you can see the right is have an escape, it will fill, but your left coronary is still at the risk. And if you deploy the valve at the node 4 or below the node 4, then there is no risk for the coronary occlusion, but there will be a huge amount of leaflet overhang above this new valve what you are going to put. If the valve failure is stenotic, then putting a tab in tab is not going to suffice the purpose. If it is a regurgitant, still the significant amount of overhang will be a problem. This is just another thing to understand it. If you deploy the valve too deep or node 4, the previous valve will completely overhang the new valve. If you deploy it at node 5, there will be some leaflet overhang. You can see it here also to understand it better. Here it is a complete overhang. It is almost 60% overhang. And if you deploy it at node 6, there is no leaflet overhang. So you have to understand the trade-off between complete overhang versus coronary protection. So whenever you are going to get a long frame valve which is degenerated and you have to put a short frame, you have to have an additional measurement when your coronary risk plane is below the neo-skirt plane. So what are those measurements? VTA, valve to aorta distance, VTC, as I mentioned, valve to coronary distance, VTAOS, that is valve to ascending aorta to sinus distance, and VTSTJ. Why it is important? Because if you don't measure this and if there is no good room around the valve frame to fill the coronary, we are going to completely sequester sinus and occlude the coronaries. And it is extremely impossible to get into that situation or enter that coronary ever. Whatever may be the expertise of coronary, so you must be having it in your life. So depending on that, this has been classified. VTA distance more than 4 has been considered safe. 2 to 4 is a probable and a possible risk. You should always have a safety mechanism in this zone. And if the VTA is less than 2, I think it is better. We should not touch and we should not intervene. As I said, the sizing in vitro and in vivo sizing is more accurate. So sizing and deciding the valve for TAV in TAV is very different. You have to make a multiple measurements at multiple sites, because if you see in vivo size, in evaluate 26, we are going to use a 23. But in vivo, in 29, ideally you should use 26. But by making a multiple measurements and area and perimeter, we are going to use a 23. So there is a under expansion if you use the bigger size, asymmetric expansion and more chance of halt. For a balloon expandable valve, we make 3 measurements at the outflow, inflow, and waste size. But for the self-expandable, you take at least 4 measurements and take an average of it. You just have to take these measurements on a CT and use this TAV in TAV app. If you feed all this data in this TAV in TAV app, which has been a genius work which has been done by Dr. Vinayak Bapat and team, if you feed into this app, you will get all the answers, where the risk plane is, where the neoskirt plane is, whether your coronaries are safe, whether what size of valve you are going to use, and whether your coronaries will get perfused or no. This is the workflow what you will see in this app. So the CT planning, see if your coronary risk plane is above the neoskirt plane, you don't have to worry about it. Just go and deploy the valve and come out. If no, then see what is the STJ, whether STJ is above neoskirt plane. Yes, then just see the VTA and VTC. If they are more than 4, just do the tower. If no, then see the VT STJ. If VT STJ has a good space, then just do a tower, otherwise abandon it. So I think if time permits, I'll show the case, otherwise I'll conclude. In conclusion, TAV in TAV requires a more CT planning. Choice of second value and the depth of implantation should be individualized for each patient. Leaflet modification may be enabled to redo tower in anatomies that are high risk for coronary obstruction. And outcomes of surgical explant of failed transcatheter valve are improving now, so we should keep it in mind. And in my closing remarks, initial tower choice is the crucial in terms of aortic sinus size, age, and projected life expectancy. Initial tower implant and the selection of the valve and the platform and the depth is going to decide your future TAV in TAV procedure. Lifetime management is important, so decide your first procedure very wisely. Thank you so much.
That was very revealing, because we are very liberal with the expression lifetime management of aortic stenosis, and doing an index procedure, not realizing what we may have contributed to the subsequent lives as lives are getting longer. So we may have contributed to our own problems. Yeah. So, but thank you very much for a very exhaustive coverage. Maybe there'll be more iterations in and development of better devices, so that we would have less of a challenge in times to come. Thank you. We are already running behind time, and
thank you so much. We move on to the next session. As moderator, I would like to invite Dr. Prakash Hajra sir, Dr. Dilip Kumar sir, Dr. Pratap Kumar sir, and chairperson Dr. K. Ghosh Ajra, Dr. Vinayak De, panelists Dr. Manish Kumar, Dr. Varun Kumar, Dr. Vinit Kumar.
Sir has not brought the slides. So Smith has to take slides. So request Dr. Smith to present, and Dr. Dhal, sir, I think your slides have downloaded, you can place it. He's presenting, sir.
7 o'clock.
Can we have these lights off? Yeah.
7 o'clock.
It's okay now? Yeah.
So, Anmol, what is a vector procedure? Vector. If you can't do tab in tab because the second valve risk causing, second valve causing huge risk to coronary obstruction and patient is not amenable to redo surgery. So what do you do?
Vector is percutaneous bypass surgery. So yeah, you puncture the aorta, you then puncture the coronary artery, then put a cover stent, something like that sort. Is a vector procedure. Yeah.
See, actually, all these unknown names and unknown confusions will come from Dr. Hasra. So you will be learning every day. That is why I don't look at any of the statements of Hasra.
Yes, there is one comment on Dr. Anmol's presentation. If we are looking at lifetime management of aortic stenosis, looking two valves, the first valve has to be shorter frame. That is very important. And then the second one, because first, if the first valve is tall, the second node 4, 5, 6 is absolutely not, go with your idea. It will be misplaced. So you are going and inflating, it can go node 4, it can go to node 7 also. So the first valve has to be shorter and then the next one. Yes, Smith, please.
Thank you, Dr. Dilip, for inviting me here to be among friends and lots of learning. The case I'm going to present, actually, it seemed that would be a straightforward case, but we saw, difficulties and hurdles at every step. So this is an old lady who is 70 years plus, had an anterior wall MI in 2016, undergone a prior CABG in 2016 with a surgical mitral valve replacement with 27 millimeter bicore prosthetic valve and a rib fixation surgery then because she was severely osteoporotic. A rest of other comorbidities were already there: hypertension, severe asthma, and a 6-minute walk test which was less than 100 meters, and 4 admissions in last 30 days. She had ITP, undergone a splenectomy, and present platelet counts were 40,000. So that was another concern that we had. The objective was she was a surgical decline for a redo, so TMVR was aimed. We calculated the size and went ahead obviously with a balloon expandable wall based on the internal diameter. And CT was not done because we already had a surgical wall, so the measurements, internal diameters were already available with us. But we have to understand the problem that she had a bypass. She had a rib fixation surgery for almost the ribs were not present now. And there was severe prostate stenosis, and I feel that was because probably it was contributed because of some calcium metabolism problem with this patient, which resulted in a stenotic wall in the prostatic wall with moderate MR. And then she had readmissions. Probably I rate them because of the wall failure itself, but she had underlying pulmonary hypertension and COPD. She had thrombocytopenia, a flail elderly status, edentulous. So without teeth, why that became important, we'll come to that. And she had a tracheomalacia. So the problem here was we could do a T before during the planning, but on table, once we had intubated her, the trachea did not have, if you can see, the trachea does not have any tracheal rings. So she did not have any calcium spot throughout her trachea, and this tube, it pressed on the esophagus. And now we could not pass her TE. We tried, she started bleeding, and fearful of, and you can even see those nails which are hanging down from the rib fixation plates. So those there also, there is no bone, and everything has come down into the thorax and abdomen. So unable to pass T, we decided the septal puncture will take based on transthoracic, and that was slightly posterior and to the center in the bicable view. And we also took fluoroscopic guidance for puncturing it, and then the things were easier. With a SL1, we could cross and we could pass the catheter. And the other help, I think videos are not running. After crossing, we dilated the septum. So the guidance that we were relying on was, one was that where the balloon would dilate and would tell us where the valve is, and the other that there is a slight ring which is visible from the prosthetic valve, which is priorly put. So based on that two rings, or the ring and we marked the place where the balloon had the maximum constriction, where the original valve is. We deployed a my valve based on these two. So just to tell that if even T guidance is not available, we can, in a prosthetic valve, get away with doing a successful TMVR based on where the balloon constriction develops and the prior frame that is available with the patient. So precise positioning is important in wall-in-wall TMVR, that we have to be 30%, 20 to 30% atrial and 70% ventricle. Otherwise, it can embolize on both the sides, or it can compromise the left LVOT. So here we took help of orthogonal fluoroscopic views to get the landing zones. We had the balloon used as a marker and the surgical frameworks as marker. LVOT assessment again requires a T, but here we monitored the hemodynamics and the TTE to understand whether the patient has paravalvular leaks and how the hemodynamics are post deployment. T other would have been the most sensitive tool, but then we have to take it with a lot of salt, and T would have shown the frame expansion. Again, we did a left ventricular ventriculography to understand whether the patient has any hemodynamic compromise or a PVL, and a TTE which revealed that the gradients have come down to acceptable limits and the patient remained hemodynamically stable with these continuous monitoring, which could tell us that probably we have done the job well. So whenever we don't have a real-time guidance, a radio opaque surgical valve frame and fluoroscopic markers like the balloon constriction, if the coaxial alignment is not possible, we do a multiple fluoroscopic projections and try to understand where we are deploying the valve. And if there is restriction to detect the paravalvular leak immediately, one is continuous hemodynamic assessment and a transthoracic echocardiography. And then we have delivered the valve well is through the hemodynamic assessment and intraoperative transthoracic. So every problem has a solution. Only thing that we have to think of the solutions then and there. I'm ready to discuss any and comments.
Very good. Very nice. Any question from the audience? Or yeah, Srinivas.
Yes, sir.
So very nice case, nice demonstration actually. Even when we have a TE guidance, we follow certain fluoroscopic rules. I thought I'll share with you because since you had struggled with the case. So what we do is we try to profile this bioprosthetic valve in an RAO where we can see it as a straight line. So this valve is epic biocar. I think that's why you will only see a small ring-like structure. So on that, when you want to do a septal puncture, so generally we try to aim at a point which is midway or slightly below the midway of the valve ring, and also posterior enough to accommodate one valve length of a tower valve. That should be the precise position which will give you a proper trajectory. In this, you did it with a TTE, which is slightly on an eye-up road. That's why you could see that the valve was driving and dipping down. Otherwise, if you follow this guidelines, most of the time, your device tracking, flossing of the balloon, everything is going to be very, very smooth.
Right. So suppose the biggest advantage of having T on board, suppose you have a paravalvular leak, and if you go through the paravalvular leak and do the flossing and etc., thinking that it has gone intravalvular segment, that can cause disaster. So how do you assure that you have actually gone through the valve on fluoroscopy? You got my point. There is an area outside the valve, suppose there is a paravalvular leak, and that might have caused the LV dysfunction because the MR. Eventually, the aortic mitral stenosis should not cause so much of LV dysfunction, or he was or she was living with LV dysfunction. So that is the only advantage, and a septal puncture, as we rightly mentioned. So how you assure that you have gone inside the
two orthogonal projections,
Yeah,
if we see,
would be
two
required.
orthogonal projections, I think,
Both
yeah,
the times it should be
we can
same.
make out, yeah.
Sir, also I guess in that way, when we follow the S curve, I think in when we are coming in a more caudal view, we can see it en fast, whether it is coming because we have a rim, so whether it's coming inside or not. I think that orthogonal position, that projection will also.
Emphasis is arocranial, no?
So
Emphasis of mitral is arocranial.
It's sorry,
Arocranial.
ariocaudal.
But
Ariocaudal.
Yes, multiple
Ariocaudal.
projections.
Ariocaudal.
Multiple projections is the answer, if you see. So,
So you
sir,
have to go to the in-fast view so that you can see the centrality, the perimeter of the valve. Then you can.
so what we're doing is we are clubbing two sessions together. So may I request Professor Panja, sir, to come on the stage, sir. And Dr. Radha Vinod Pal, Dr. Amit Chaturvedi, Dr. Abhi Karak, Dr. Munna Das to please come on the stage. So we have Dr. Robin Chakravarti waiting from US to give a talk online. And we have Dr. Dhal, sir. Is he ready? Is he presenting, sir? No, sir. Then we can invite and Dr. Professor Robin Chakravarti. Sir is online. Sunil? Audiovisual time? Audiovisual team? If sir is online, please. Sir, 4 o'clock there. No, he wanted. Sir, are you there? So what we'll do is, by the time sir is fixing his presentation, may I request Anupam to show his case, and then we'll take sirs.
Thank you, sir. Thanks to Dilip Kumar sir for inviting me. I mean, this is one of the first biggest structural conclave in this part of the country. And my task is to talk about a tower and some case where we have some learning points to see. So this is my case, actually two cases I will cover quickly. So this is, the title is One Tower, Double Trouble. 76-year-old female presented with syncope dyspnea, severe calcific aortic stenosis with gradient more than 100, mean gradient 70, and severe COPD. She was frail, so we took up for surgery. And this CT showed a tricuspid valve, annular area of 350. However, the coronary height was less, the RCA height was less than 10, left main height was 10, and the sinuses were also effaced, less than 25, some 23 or something. Then to add to the problem, the femoral arteries were also small. Right iliac artery was 5.2, 5.6, left was 4.7, 5.4. I mean, if we go by the standard recommendations, then 5.5 is what we should take ideally. So we thought that left appears to be small. We decided to go ahead with the right side. However, there was mild tortuosity of the right femoral as compared to the left, which was more straight. And at that time, this DASI simulation was, we are doing some work with the DASI simulation also. Presently, it is commercially available. It is already FDA approved, where we can virtually deploy the valve. We can run virtual videos to see what is happening. So this was a pilot run at that time, and it clearly showed that the RCA, there is a definitely high risk of occlusion of the right coronary artery. And with self-deploying 23 valve, definitely the risk was very high. Based on that, we decided to go ahead with a balloon expandable valve, 20 millimeter valve with, if needed, we will go with 2 ml extra. This is just to confirm the same. The valve was heavily calcified, resting gradient was more than 100. And the point is, on the right side, there was, even though the CT showed that the diameter is fine, but there was one tortuosity here, and still we decided that on the left side it was small, so we'll use the right side. So we went ahead from the right side, and during balloon predilatation, RCA was completely occluded. Leaflet length was, the leaflet was entirely covering the RCA. We took protection for both coronary arteries, and for the right coronary artery, we deployed we took the guideliner and the stent. For left, since left we thought that we can get away on the left side, we just kept a wire and a guiding catheter for the left side. We deployed the valve, and as expected, RCA was not flowing, so we deployed a chimney, and post chimney stenting, coronaries were fine. So we tackled one problem, coronary occlusion. Then there was another problem. After putting the proglides there, so here exactly there was this little bend, and in that bend area, what has happened is the proglides actually stitched the anterior and the posterior wall together. So that is a problem that can sometimes. This is my second proglide problem, and during my initial days in 2017-18, when we are not doing ultrasound guided puncture, and we used to put a pigtail.
It was double or single?
Double.
Double program.
Yeah. So another
crisscrossing was it crisscrossing or because of the small size?
Yeah.
Deployment was 11-1 or maybe 3 or 9.
No, not 3 or 9. It was 10 and 2. Because these cases are done 5-6 years back. Yeah.
I think
So
rather than
here,
a double proglide issue, it was basically a posterior wall getting stitched. So
yeah.
it was posterior wall getting stitched. Probably had you imaged it with an ultrasound here, and if you had determined how deep is your posterior
if today I do this case, my approach will be little different. Probably I'll go with single proglide and manual compression, or maybe single proglide with a angiosil. But with single proglide, we effectively reduce the lumen and reduce the opening to a 6 French. So single proglide with manual compression will be safer in this case, what I feel. And then finally, surgeons came into the picture, and the total artery was avulsed. They could not salvage the artery. We put an interpositioning graft. We have all discussed how surgeons come to our rescue. So here is an example. They came to the rescue, and and this case ended well, finally. Case 2 is less complicated. However, again, we have whatever we have discussed, just to show that there is a bicuspid aortic valve type 0, and there is eccentric calcification that usually happens in the bicuspid aortic valves. There is dilated ascending aorta, 45 millimeter, and the angle is also very difficult angle, 62 degrees it is showing, but when we try to pass the valve, we see the real difficulty here in this case because of the dilated horizontal aorta, bicuspid aortic valve with eccentric calcium, so much of eccentricity, and there was a septal bulge. This was done in 2018. At that time, only Medtronic was available in my center. So we did a pre-dilatation, and when we tried to pass the valve over a confida wire, we are unable to pass the valve. Every time the valve was getting, the wire was getting sucked out. So finally, we had to change the confida wire for the Lunderquist wire. And with some maneuvering of pushing and pulling of the Lunderquist wire, we could finally pass the valve. And it is absolutely horizontal. This valve now sits absolutely horizontal. And of course, difficult to deploy this, difficult to make it coaxial, make it properly aligned. It tends to be misaligned usually. However, we deployed, and this was done in 2018. The concept of zero deployment and all was not there. Even if it is there, I don't think we can really aim for that high or that type of ideal deployment in such cases. We deployed the valve, but again, after releasing, the valve migrated. Valve migrated maybe 2 millimeter, but echocardiographically, the PVL appeared to be mild, or we can say moderate. And the proctor at the time, Dr. Giza Fonto, he thought that, okay, considering everything, probably it is best not to take another valve, and because he thought that passing another valve through this valve will be very difficult because of the positioning and the orientation of the valve. So that's how we left the case
Give
at this
Manjaro.
point.
Manjaro. Tijabitai.
Giza Fontes, I think.
So there is a paper from India last 3 months back in, I think, CRT. If you give Manjaro, the chance of valvular leak, paravalvular leak decreased by 60%. 60%.
Oh, wow. Amazing. Paravalvular leak coming down with Munjaro.
Yeah, 58% reduction of valve halt and durability, I do not know, but the paravalvular leak decreased by almost 60%.
Okay. So, I mean, this case highlights all the problems with a bicuspid aortic valve tower, like dilated aorta, poor coaxiality, difficult crossing, asymmetric deployment, high risk of PVL, and valve migration. All the textbook descriptions of challenges of TAVI in a bicuspid aortic valve can be seen in this case. Thank you.
Very nice case. I just want to ask one question to everybody. Since morning, Dilip and Dr. Panja, everybody was asking the coronary access, coronary risk. When you're implanting a valve, balloon or self-expanding, 3-cuspal or 2-cuspal view take, no? But we don't take any view for the left main ostia. The ostia is at risk, not the LAD, not at the circumflex. So we must see the ostia.
Yeah.
In routine angiography, we see the ostia, left main ostia in iliocranial view. So would you care for iliocranial view at least once to see the level of left main ostial risk?
You are fortunate. You are fortunate in spite of the migration, the left cloud protractum towards the left ventricle, but they're not causing any obstruction to that electrical pathway. That means conductor is not involved. No pacemaker. That is
Thank you, Anupam. I think sir's question was very genuine. LCC side view we take when we are borderline for coronary risk. In Tremencio also we are not clear. Then we take a LCC side view during the procedure, and this gives us a good idea whether it's getting obstructed or not.
With balloon expandable valves, you can just take a diagnostic JL and take a iliocranial view.
So thank you, Anupam.
sir.
And we have Dr. Devdatta Bhattacharya waiting for his case presentation, and Dr. Robin is waiting from US. So may I request Dr. Robin sir if he has joined? Yeah, sir, we can see you, sir, digitally. We can't hear you, sir.
Subclavian access, but I have lost that case now. So I was desperately searching for it, but I couldn't find it, and the saved presentation there was saying that this can't be played. So I'm sorry about this. This case we presented 2 years ago in London Valves. So this is an interesting case. So this is quite an old lady. She said she was 75, but she looked like she was 80, hypertensive and diabetic, and she had severe AS. And you can see the gradient 102/62 and grade 1 diastolic dysfunction. Ejection fraction was normal. And this was so she had to have it. She was very symptomatic. And this was the initial Tremencio report. And you can see that the RCA height and the LCA height, what they reported was like quite okay. But it was a bicuspid aortic valve type 1A with moderate aortic calcification. And these are the sinus of Valsalva diameter. So there was a calcified raphe. But when we looked at the valve ourselves, we thought that the coronary heights were actually much lower than what they had reported, and both the coronaries were at risk of occlusion. So this is the aortogram, and you can look at that picture. So you can look at this picture here, and what we thought was this left coronary was low, and then we looked at the other view on the right coronary, and it also appeared to be slightly at risk. So we thought that we will take due care. And again, you can see at the aortic root and the coronary heights they don't look very promising. So we set out with the aim of protecting the coronaries, but we got into a lot of trouble. So I will show you. Sorry. So we have crossed the aortic valve, and we are trying to cannulate the coronaries, and we spent an hour trying to cannulate the coronaries because both the left and the right coronary artery, they were arising in a funny way. And we have done, I mean, I'm not a structuralist, learning to become a structuralist from experts. But I've done a lot of coronaries, and it is very rare that I can't cannulate a coronary. And this was like 1 hour. We managed to do the right, but we couldn't do the left. So we said, okay, why don't we do a why don't we do balloon dilatation and see what happens to the left coronary. And here you can see, I don't know whether you can appreciate it very well, this valve leaflet is really standing up. And we were now convinced that we had to protect it. So then I had a proctor with me, but the only contribution I had in this case was I cannulated the left coronary because it was so difficult. And in the end, we had what we wanted to do. So this is how it was. So we implanted the valve, and then we deployed the left coronary stent and the right coronary stent, and this is how it looked. So we got away with it, and you can see that here this valve leaflet is standing up quite a bit. So it was absolutely the right thing to do to stent the left. And sorry, what happened after that? Sorry, these slides are not here. So what happened after that was the pressure started dropping, and we were like very, very anxious that why this was happening. And this is like 3 hours into the procedure, and we were like, it was 9 o'clock at night, and we were getting a little exhausted. And then what we found, I'm sorry, these slides are not loaded here. So then what we found was that the patient was bleeding from a twig of the inferior epigastric artery. And how it was, how we injured it, someone was saying your wire went in there, but the wire never went in there. And we called our interventional radiologist, and they said that this happens in elderly patients. If you give them a lot of heparin, they can bleed. And that internal epigastric artery branch had to be intervened upon. So glue was injected, it stopped, and then the patient went to the ward, to the CCU. The patient is still alive. It's been 3 years. The patient is still alive. The gradient is around, the mean gradient is around 12. So we got away with this case from a lot of trouble, and this is, I presented this case, Dilip, because this is one of my most challenging cases as you wanted me to present, and I have acknowledgements for both the interventional radiologist team who bailed us out of the bleeding complication, and my proctor for this case was Manik Chopra. Thank you very much. Okay.
So it was really a little surprising. We do femoral punctures. We have been doing for decades, and heparin 18,000, 20,000 also for CTOs, but we never see this inferior epigastric bleeding.
It happens. So I told the same thing to the interventional radiologist. We don't see this. So he said it happens, and this patient had both of them. It happens in elderly people, and it happens in ladies. So they see this complication in this type of patients. So they have you can have suddenly a patient who comes to the emergency with a rectus sheath hematoma, who is on anticoagulants, and they are called, and they see that there is a twig bleeding. and then they have to intervene on that. So, I mean, Manik was very, very anxious about anticoagulation. So we were really loading him that there are 2 stents, we must give it. So we were giving it. And then we ended up with this. Yeah.
Girish sir, yeah.
I think when we do a CT scan, it's very, very important to find out that inferior epigastric artery. That's an Achilles heel. When we are trying to do ultrasound guided punctures, it's so small, very difficult to visualize. The CT is your best time to know. Sometimes it is so tortuous that it may come on the common femoral artery and go on this side, especially, very elderly and frail ladies. So sometimes it's important while you have done the CT, from where you want to access that common femoral artery, that also helps us.
Yeah. I mean, the puncture was, yes, I thought it was my fault because I have punctured it. It was on both, the puncture was on both groins, as you can appreciate. And I thought I must have done it. But it was not bleeding from the proximal part of the inferior epigastric artery. It was like in a twig, which was much, much distal. And no way my wire could have gone there. So that was the thing. So I asked him that, why is this twig bleeding? I mean, it's 9:30 in the evening, and why is this bleeding? So he said it can happen.
Thank you, sir. Thank you so much for presenting this nightmare case. We are announcing the anyone who is due for lunch, they can have, and it will be a kind of running sort of thing. And Amit will be presenting his talk, endovascular, because with large bore access, a lot of endovascular things are coming in our fold, so we can easily take care of them. And the only thing which is lacking is fenestration. If someone knows fenestration, he can do everything. So Amit will be showing us, and we also have kept a workshop on fenestration at our stalls. So Amit, please go ahead.
Can I have my slide?
And we can move on with the chairperson and panel for that session.
Morning.
Amit, you start.
Good afternoon, and at the outset, I would like to thank Dr. Dilip. Basically, we'll be.
May I request Dr. Ajay Gautam, Arindam Pandey, Dr. IBHRE Datta, Srishti Kulshrestha, Souvik Paul to be here. Dr. Srishti Kulshrestha. Varun, please be there. Please come.
So basically, we'll be trying to understand what are the indications of fenestrated TEVR techniques, and review some of the techniques in a little bit more detail, and compare the devices, the tools and advantages and limitations of these techniques, as well as I show you one case recently which I did. Although I'm a newcomer in this field, I have entered this aortic field very recently, so forgive me if I have did some mistakes. So why do we need fenestrations? Basically, it's to preserve either the supraaortic or the visceral branches, because you are using a covered graft, and preservation of these branches is very important during these procedures. And sometimes we don't have a proper landing zone in the proximal end, and to extend this landing zone, we have to cover some of the supraaortic branches, and to that extent that it covers the artery which is not involved, and that's why we have to use a fenestration technique to keep the patency of the branch. Sometimes we just want to avoid a surgical debranching because of various reasons, and sometimes in complex arch cases where surgery is denied to the patient. So fenestration techniques are basically divided into 2 parts. One is what we call as physician modified endograft, whereby you do the fenestration or the scalloping outside the table. Means you deploy the graft outside the table, and according to the CT report, you make scallops either using a surgical blade or a thermal catheter to exact size of according to the CT ostial diameter, and then resheath the graft and use it again. That is called a physician modified endograft,
And there are other techniques where you do the fenestration inside the body. Now this fenestration can be done either using a laser or needles like broken barrow, or specialized needles are available from Cook and other companies which can be used for the needle ablation. Chimney is an alternative technique which is actually technically not a fenestration. So I will not be discussing chimney or periscope method. So basically needle fenestration is commonly used for supraortic branches, commonly for the left subclavian preservation. Here usually you deploy the graft, the main graft up till the subclavian, and then you use a brachial access to do the fenestration, and once the fenestration is done, it is balloon dilated, stented as a bridging stent, and then the complete deployment of the graft is done. Whereas laser assisted fenestration is similar, but we use laser instead of a needle to make the graft puncture. Laser is considered to be better because it at the same time it coagulates the graft material. So later the chance of endo leaks is lesser if you use laser assisted fenestration. Now there is a third technique which I already told you, physician modified grafting, whereas the scallops are made outside the body and then they are precisely oriented towards the ostia of the artery which is to be preserved during the deployment by correct rotational techniques. This technique is less preferred because it can lead to endo leak post procedure until unless you deploy a covered stent as a bridging stent there. But it is very useful in cases where you are in an emergency and you need to do it in a fast manner. For all fenestration cases, pre-procedure planning is 95% of the job. If you have done procedural planning with written steps, pre-procedure, how you are going to do it, most likely you will be successful in your procedure. And all the steps should be discussed with your team before you proceed for the final this thing. Laser fenestration, as I already said, it's the most commonly used worldwide, and it creates a graft opening which is precise, and after balloon dilatation you can place the stents easily. It's a rapid and reproducible in experienced hand. Whereas needle fenestration, it is useful, but it can lead to the tear in grafts. So whenever you should prefer needle fenestration only if the laser is not available, and you can use a broken barrow or transseptal needle, and there are the specialized needles with the occluding balloons are available to the graft fenestration. Physician modified endografts we have already discussed, and there's something called custom fenestrated devices. The main problem with these devices is that it takes a lot of time for these grafts to come, 6 to 8 weeks. So normally you might not have the time to wait for that long in these cases. But otherwise, they are the best strategy for preserving the supraortic and abdominal branches. Technically, while fenestration, you should always take orthogonal views to have a correct positioning for the fenestration. Then fenestration reinforcement is very important. Either if you are using scallops outside this thing, on table fenestration, you should do suture with proline or radio opaque markers so that you know how to where to exactly place the scallops. And if you are using in situ fenestration, then bridging stents are very important. And fusion imaging, if available, is very useful. And post dilatation should always be gentle in fenestration cases because it can lead to fabric injury. And to stay out of trouble, the only way is to plan. Consider all the anatomic and physiologic factors, the takeoff angle of the vessel, calcification, whether it will be easy to cannulate or difficult to cannulate, if you should be ready with the backup plans, backup catheters, and sometimes you should have the courage to say no if the anatomy is difficult. And to get out of the trouble, the most common cause of failure of fenestration is because of cannulation failure. So if you are not able to cannulate it properly, you should use proper views and use multiple views to define the ostia of the artery which you have to fenestrate. You can use different types of wire because sometimes the wires may not be so flexible to enter the tortuous ostium. So you can use wires which you are used to. Steerable sheaths are available, but it is difficult to get. But if you have a steerable sheath, it highly assists you in engaging the osteo of the artery to be fenestrated. And one concept of offset, that there should be some space between the deployed main stent graft and the ostia so that you have a place to maneuver. Sometimes even operators inflate a balloon in between the arterial wall and the main stent graft to create this offset so that you have a place to maneuver the wire and engage your guide. So this is technically a very successful procedure. The most common cause of failure of fenestration is cannulation failure. The risk that you may produce a retrograde aortic dissection, thromboembolism and stroke are a major concern, especially in supraortic branches. But if the procedure is successful, the branch patency is reported to be more than 96% on an average and usually close to 100%. And endo leaks is a problem, especially type 1 and type 3, type 3 being more common in fenestration cases. So normally, if it's emergency, you do the scalloping outside, or if it's a subclavian artery, you can do an in situ fenestration. Elective cases, always custom devices, but you will have to wait 6 to 8 weeks, and cost is also an issue. But it all depends on resources and operators' expertise. And I'll just show you one case. It's a young male with a dissection from subclavian up to the iliacs. So we decided to go with the TVAR procedure with in situ fenestration, and because we had to protect the common carotid also, so what we did, we decided to do 2 types of fenestration in this case. We made a scallop for the common carotid outside the table and marked the sutures so that we can have the correct orientation. And after entering the true lumen, doing the check angiogram, we took a left brachial axis and cannulated the left subclavian artery. Then we deployed the main stent halfway, making sure that the scallop we created for the carotid is correctly oriented towards the artery and the flow is there. Once we had done that, you can see that scallop is marked with a C, that's the suture. Then we took a puncture needle with the balloon, stabilized the balloon over the ostia of the left subclavian, and then it was fenestrated. Once the fenestration is done, then the job is easy. After fenestration, you exchange the wires, take the balloons to dilate the fenestration up to the required size. Once the fenestration is done, ballooning is done, you have reached the square size, you use a stent as a bridging so that there's no endo leak. And once this stent is deployed, then the further full deployment of the main stent graft can be done. And then we did the completion of the procedure. And post-op 6 months, after 1 month, the CT looks good. There's no endo leak. So thank you very much.
Any questions? So I think yes. So fenestration, if a CT is done properly and if it's analyzed properly, the only thing is to orient your catheters and do the job. And basically the fenestration.
With fenestration was the most important thing is planning, as you
Yes.
said. Because if it's a supraortic branch, in situ fenestration with a needle is very easy and technically less demanding. And if suppose you are trying to preserve the branches in abdominal aorta, then scalloping outside the body, and then you orient those holes which are already there for the ostia, then cannulate it inside, rather than doing the fenestration directly inside the body, because it can be dangerous.
No. When you are doing for abdominal, it has to be fenestration outside the body, and it has to be sutured properly also. And many times we take help of surgeons to suture that. It's very delicate to suture that.
Yeah.
But the idea is the orientation in which you are going to make fenestration. It all comes from CT analysis.
CT,
everything comes CT analysis. 3 o'clock, 4 o'clock, 5 o'clock. How big is the center and how big, And when we open the fenestrations to recannulation, it has to be a partial opening of the endovascular stent. It should not be open full, otherwise you can't do that.
So as I said, the greatest tip of staying out of trouble is plan, plan, and plan. If your pre-procedure planning is good, 95 procedure is success.
Yes. Sir, you were saying something?
I think, what is your preferred strategy for supraaortic branches?
Sir, that's what I said. For supraaortic branches, we normally prefer this
Custom made,
in situ fenestration because it's technically easy to do.
So you put the graft first and then come
Sir,
retrograde?
we partially deploy the graft until we reach the subclavian. Once we reach the subclavian, we take a brachial, which is brachial access. From brachial you go, and then the wire directly reaches the graft.
Right.
And then you puncture it, then you balloon it, and then after stenting that, it acts as a bridging, because once you have put a stent across subclavian into the aorta, the stent won't move.
Correct.
So you're not worried about the stent migration.
Have you deployed the stent by end of it?
No, at the end only you deploy the other part of the stent.
After fenestration, you deploy the rest of the stent. Okay.
Yeah, so deployment has to be last, and that is where we need to have a lower blood pressure in these patients. If you are working and you have done fenestration outside, you have taken it, and while you have partially opened it, you have to recannulate. And if the blood pressure is high, the chance it will be, moving upside and,
What do you do?
quite a movements will be there.
Sometimes we do fenestration and pacing also, sir.
Yeah.
After fenestration,
Pacing.
we do rapid pacing and then deploy the final deployment.
Thank you, Amit. I think it was a wonderful presentation, and endovascular is a new area which we are going to capture. Endovascular cardiologist.
I started recently only, sir.
Yeah.
I've been doing coronary for long, so I thought I'll do it.
Thank you so much, and we will take 2-3 minutes break and let everyone come, and then we will go to the next session of TMVR.
Hello, Dilip.
I think LA is there. No?
I'll just quickly sort of highlight some last 3 or 4 important trials, right?
Yes, sir.
So you all are aware about the partner trial. I will and the core valve trial was by Dr. J. Popma, and which said that the supported self-expanding TAVR, TAVR, and therefore with that we actually broadened the device choice. Initially it used to be only balloon expandable valve. This is the core valve high risk group, and this is the one which was published in JACC sometimes in 2018, and they found in high risk group of patient, core valve high risk group is TAVR is superior to surgery for mortality at 1 year. Then partner 2A and partner 2A, then SURVATI trial, SUTAVI trial, and finally from partner 3, we came to know that this is about last 5 years, this first time when he showed that low risk randomized trial using SAPIEN 3 in severe symptomatic aortic stenosis with low STS risk and favorable anatomy. They excluded bicuspid valve, unfavorable vascular access, and complex anatomy. Accelerated TAVR adoption is carefully selected low risk patient was useful because they found in partner 3, the all-cause mortality was reduced by 24%, stroke at first year was reduced by 58%, and hospitalization was reduced by 35%. This is a trial by Martin Leon and his team published in New England Journal 2 years ago. Then the EVOLUTE low-risk trial, which is a background low-risk comparison of self-expanding TAVR versus surgical valve replacement in severe symptomatic aortic stenosis trial with low surgical risk. And for those conditions where anatomy is unsuitable for TAVR, it has been shown that in EVOLUTE low-risk trial has shown that in 30 days time and in 1 year time, the TAVR has superior hemodynamics with self-expanding valve. This is a trial which was published only last year in April in American College of Cardiology, JACC journal. This is the summary of the message, which again has been presented in the same journal. It's been published in another paper, shows that how superior is this trial. Then this NOTION trial, which is again published sometimes in April 2024, 2 years ago, has shown the rate of severe your structural valve deterioration or was higher after SAVR, but was not significantly different from your bioprosthetic valve dysfunction. Rates of reintervention are very low and not different between the two groups. Notion trial again has shown the key message is that TAVR has shown an excellent durability at least for 8 years, if not for 10 years. In fact, later on the Notion trial 10 years data was presented and shown that TAVR is superior as compared to SAVR from the durability of the valve and structural valve deterioration point of view. This is an Indian valve, which is Merrill valve trial, which is landmark trial. It was randomized parallel open label trial. The goal of this trial was to evaluate TAVR with MyValve prosthesis compared with the contemporary prosthesis among patients with symptomatic severe aortic stenosis. MyValve is, we all know, this balloon expandable platform with prosthetic size that increases in diameter by 1.5 millimeter increment. It has been shown that all-cause mortality, stroke, major bleeding, acute kidney injury, major vascular complication, moderate to severe prosthetic or regurgitation, or permanent pacemaker implantation was 25% with MyValve as compared to 27% with contemporary valve, be it a Sapien or your balloon expandable valve. In secondary outcome, this moderate to severe prosthetic valve regurgitation was 3% with MyValve versus 5% with a contemporary valve. So the conclusion of this trial was among patients with severe aortic stenosis, TAVR with MyValve was a non-inferior to a contemporary prosthetic valve like Sapien or Evolute. All-cause mortality, stroke, major bleeding, acute kidney injury, major vascular complication, moderate or severe prosthetic valve regurgitation, or permanent pacemaker implantation was similar between treatment groups. Then later in 2024, another trial came out called early TAVR trial. And in early TAVR trial, it has been shown that the early TAVR has shown that early TAVR reduces hard outcomes to surveillance. And this is this particular paper has recently been presented. In fact, by this original paper by Philips Generics, who actually came to Calcutta in one of my meeting, I think about 5 years ago, 4 or 5 years ago, and he presented the same paper just 24th June at New York Valve just few days ago, and he showed that this is the data early TAVR trial perception of how patients with asymptomatic disease should be treated when it was first published in 2024, and the data ultimately led to US FDA to approve TAVI in 2025 because it has been shown the composite endpoint of death, stroke, or heart failure hospitalization was significantly low in those randomized to early TAVI compared to clinical surveillance at 5 years interval. This finding was driven by a decrease in death or stroke after 2 years. Therefore, it is an important landmark analysis. The SMART trial is again another trial which is enriched with, particularly in women, more than 88% enrollment in this group of patients. And it has been shown that among patients with a similarly sized aortic annular self-expanding valve have a lower Doppler-derived aortic valve gradient compared with balloon expandable valve. Then this is a SMART trial has shown that in Evolute and Sapien, in terms of hemodynamics, valve performance, and valve-related dysfunction at the function of the valve and clinical outcome, Evolute has some superiority as compared to Sapien. The key message is Evolute superior valve performance is small annulus. This is an important trial which was published 2 years ago. Sentinel is a trial which is basically to look for the cerebral protection in TAVR. And the data is that, yes, debris has been found, but clinical benefit of using cell protection device or cerebral protection device was not proven in Sentinel trial. We also need to know a little bit about antithrombotic trial in TAVR patients. The trials a popular TAVI showed aspirin alone reduced bleeding without increasing ischemic event. Galileo demonstrated routine rivaroxaban has increased mortality. Atlantis found no overall benefit of apixaban. Envisage and TAVI-AF showed eroxaban had similar efficacy warfarin but more GI bleeding. So single antiplatelet therapy when appropriate and reserve anticoagulation for established indication. This is a kind of popular TAVI which has shown that aspirin, probably a single antiplatelet drug, is enough in this group of patients. You do not need to go for dual antiplatelet therapy. Galileo has been stopped because it increases mortality, increases bleeding, and increases the thromboembolic events. So it is not a useful drug. Atlantis, again, apixaban did not improve the clinical outcome. And same is true with Envisage, and edoxaban has no benefit. Finally, before we conclude, certain ongoing trials are coming up, like Envision trial. This study evaluates Abbott's Navitor TAVI system across roughly 1,500 patients. It focuses on individuals with severe symptomatic aortic stenosis who are deemed low or intermediate risk group. Evolute Expand TAVR 2 trial is evaluating next generation Medtronic devices, Evolute PRO and Evolute FXPVA trial for aortic stenosis. Now we got TAVR in patients of aortic regurgitation, like Align AR trial, historically challenging to treat minimally invasively, but this trial, Align AR trial, recently validated a dedicated TAVR system with the JenaValve to treat native aortic regurgitation for patients at high surgical risk. Another trial of aortic regurgitation, Journey trial. This trial evaluates the investigation in J-valve of Edward Life Sciences. This device utilizes 3 specialized anchoring rings designed to grasp native leaflets and has shown promising procedural success rates in every trial. The ARTIST trial is an upcoming trial. It is designed to expand clinical data, randomly localizing low-risk aortic regurgitation directly and comparing it with surgical valve replacement in aortic regurgitation. And finally, there's an interesting trial coming up called Believers trial. This clinical trial is evaluating the safety and efficacy of TAVR specifically for patients with bicuspid aortic valve stenosis. Enrollment is only with bicuspid aortic valve group that was usually conventionally excluded largely from many trials in TAVR trials. Thank you very much.
Thank you, sir. Thank you for this wonderful presentation. So just a quick discussion on the trials, which have really stirred a lot of discussion nowadays, is that Evolute low risk trial 7 years data. It showed that you are getting more reintervention in self-expanding valve versus surgical platform. So that is a little point of concern, and we can have some discussion on that. Is it a moment which we should be pausing ourselves in low risk patients? We saw the primary endpoints were not different 7 years, but reintervention was significantly higher in TAVR arm, low risk patients. So what's your comment, Ravin sir, and what the panel feels about this study?
As I said, that the low risk trial now they have shown even asymptomatic individual. This is a new, I think that's just this week only it has been presented in New York valve meeting, that asymptomatic individual with severe aortic stenosis and even other with low STS score group, you can electively choose them for TAVR, and the results have been found to be quite comparable with other results, which is quite effective and safe.
So there was a point which they dissected was during the initial days of TAVR implantation, still expanding valve, a lot of post dilatation they were doing, not the pre dilatation. And from there the idea came up in those patients who had more post dilatation, the valve injury was considered as one of the reason, and those patients who they had gone aggressive pre dilatation, bought our Evolute platform, they had better valve durability. So that is the takeaway which we have taken from this trial. And now we see the trend of doing more pre-dilatation, aggressive with 20 mm balloon, 22 mm balloon, and a 23 mm expanding platform. It's now in practice, which earlier it was not there. It was kind of okay.
Yes.
It's a very high rate strength. Yeah, Dr. Anmol. Yeah.
Yeah, so I think the preparing the bed, what we started doing in coronary, I think the same way I think we started thinking the same lines in TAVR also. Prepare your bed properly. And about the low risk trial, which showed a lot of reintervention in TAVR arm. The problem with higher age, low risk people, it is still not a major problem. But the problem, the trial with respect to our population in India matters a lot, because our low risk are very low age also, very young. If you try to push them for a TAVR because of whatever the reasons, then it will be too much screwed up situation for them in their future thing. In our country, surgery and the surgeons are still the best skills. So we should, our patients are young, so you should think from the younger age point of view, how many interventions they will be required and how safe will be in future interventions.
So any last comment from Dr. Girish and then we'll close it.
No, I think what one practice that has changed in self-expanding platforms is regularly we are pre-dilating, as you said, and avoiding as much as possible post-dilation. The more calcium you see, I think better to do a good pre-dilation and then take the self-expanding valve.
Thank you, sir, for staying up there.
Thank you.
It's 5 o'clock
Thank you.
morning, and I really we appreciate your gesture and support to all of us. Thank you so much.
Thank you.
Yeah. So next we move on to the next session. This is TMVR. So we are clubbing the both presentations, TMVR valve in valve and TMVR native valve, and we will have a panel discussion on that as we go step by step, and we'll talk about the nitty-gritties also. So may I invite the chairpersons, moderator Dr. Anupam Jena is there. Anupam, please. And Dr. Gopal Ghosh, Dr. Nishant Tripathi, Dr. Vineet Kumar, and may I also request Dr. Kajal Ganguly, Dr. Rajesh Barbarao, Arnab Ghosh Chaudhary, and Dr. Amit Chaturvedi. Shamshad, you are there? Shamshad Alam? Dr. Shamshad Alam, Sabha, can you help? Yeah, tell Dr. Shamshad to be there.
Yeah, since one of the speaker is not there, what we are going to do is in this TMER session, I was supposed to talk on TMER in native valves. The other speaker was supposed to talk on TMER in valve in valve, that is surgical valve. Since he's not there, so probably I'll start with my presentation, and probably also we'll do a contemporary on talking about what are the exact steps of TMER so that we all know the nitty-gritty of the procedures. Can we have my slides? ये वाला नहीं, मेरा नाम पे है ना श्रीनिवास प्रसाद, वो ना कंट्रोल मुझे दीजिए, मैं खोलता हूँ.
We just had Dr. Smith presenting his case, TMVR, without transesophageal echocardiogram. So T is basically required during the puncture. That is the crucial step. And after that, I don't think T has much role to play. Finally, for PVL and the obstruction. And we'll go through step by step. So it's basically good puncture, and then the job is done.
Yeah. So correct. So the T was basically to ensure that we all have a precise puncture, but over the time we have learned where exactly to puncture, and probably we can take it forward. Otherwise, T is not absolutely essential nowadays, especially in those people who cannot tolerate a T or cannot tolerate a G and so on. So coming back to this talk, this is more like a data orientation. So we'll talk about this and then we'll go back to the steps. So MAC, why does it matter? This is an unmet clinical need in our country. MAC converts the mitral annulus into a rigid calcified scaffold. Traditional surgery risks annular rupture as well as LV disruption. Surgical MER in a severe MAC carries almost an operative mortality up to 50%. It's more than 25% in an extreme risk patients. TMER anchors a new valve within the calcium itself. No sutures, no decalcification, and purely transcatheter. As the population of our country is aging, MAC-related mitral valve disease is becoming one of the major problems. What makes MAC unique? There is a circumferential calcification, so dense calcium in the fibrous annulus extending into leaflets, alveoli, and supravalvular apparatus, and it's non-circular. If you remember, the mitral valve is kind of a D-shaped annulus, and this calcium can extend into LVOTO or into the subvalvular structures. And there's no suturable tissue. Whenever our surgeons try to do an annular debridement, the risk of AV disruption is almost 5%. LV perforation for an LVOT calcium extending the LV free wall is very high. LVOT obstruction can occur because of the anterior displacement of the tissue post decalcification. And obviously, this is not going to fit the valve in a uniform way, and there can be a paravalvular leak. And even with the best of the surgery, 30-day mortality risk is around 15 to 50%. So, whom should we take up for an TMER in MAC? The clinical indication should be symptomatic severe MS or MR, and there should be prohibitive or extremely high surgical risk, and there should be an art team consensus, and at least the patient survivability should be at least more than 1 year. What are the anatomical requirement? We need the calcium to be at least more than 270 degree, and annular area should be at least 4.5 centimeter square and more. We don't want to put a small valves there. And predicted neo-LVOT area, because whenever you put a mitral valve, this mitral valve can come in the way of an LV outflow tract or LV cardiac output. And if this predicted neo-LVOT area is less than 180 millimeter square or 170 millimeter square, then it is difficult and they can develop this LVOT obstruction, can develop in serious consequences. And also, there should be some adequate subannular space of at least 5 millimeter depth to anchor our valves, and there should be suitable access, apical or transeptal. Most of the TMERs in the MAC started as a transeptal. Nowadays, we also, transapical. Nowadays, we also do a transeptal trajectory. What are the contraindication? If at all, if your calcium is incomplete, you should not try it because it will not anchor the valve. If your predicted neo-LVOT is less than 150 millimeter square, even after considering lampoon, then you should not do. Active endocarditis is a relative contraindication. Severe LV dysfunction with a max severe MR mortality rate with or survival rate less than 1 year is very, very low, so you should not attempt. And if it is not feasible, you should not go behind it challenging the anatomies. So the key measurement, we see it on the CT. One, annular area. Unlike our aortic annulus, which is oval, this is a D shape. So that's why we have a diameter 1 and diameter 2, and you should check for the area. You can also do annular perimeter because this is the sizing parameter, and we generally oversize only by around 5 to 10% in case of a MAC. Whereas in a valve-in-valve, we generally oversize little more, whereas for a MAC, it is only 5 to 10% oversizing. And neo-LVOT area is the most critical measurement, and that should be at least 170 millimeter square. LVOT width should be adequate, subannular depth should be present, iotomitral angle should be less obtuse. Lesser the obtuse, more high risk. It should be more obtuse. So it should be less than 120 degrees. And as I said, calcium should be at least 270 degrees. So what are the three major things as we discussed? One is anchoring. If there is no enough calcium, it will not anchor. There can be a delayed migration or on-table embolization. If LVOT is small, it can cause an LVOT obstruction, causing an hemodynamic compromise, cardiogenic shock, or increased mortality. Paravalvular leak, residual paravalvular leaks are quite a norm in most of the MACs rather than exception. So this is a calcium score which came out in JACC imaging sometime back in 2020. So it is based on the calcium thickness, whether it is less than 5 millimeter, 5 to 10 or more than 10. Calcium distribution, it is less than 180, 180 to 270, more than 270. Whether the trigones, that is commissures, are involved or not, based on that. And the leaflet calcium, based on this, they came out with the scoring. Any MAC score less than 6 carries a high rate of device embolization and should not be attempted. So to attempt a TMER, your MAC scoring should be at least 7 and above. So neo-LVOT obstruction is one more Achilles heel. What is the mechanism? It displaces the anteromitral leaflet towards the interventricular septum. So MAC plus device frame creates a rigid, non-dynamic LVOT obstruction. So AML length, LV size, iotomitral angle determine the severity. So on CT, we all discussed what are the things of a neo-LVOT area. The other parameter is a long anteromitral leaflet. If your A2 segment is more than 20 millimeter, or there is a small cavity with iotomitral angle less than 120 degree, you should not attempt. One more variable factor is septal hypertrophy. If you see a big septal bulge, that can also cause a residual LVOT and should be avoided, or you should plan for a prevention strategies. The important prevention strategies are lampoon and alcohol septal ablation, and of course CSAM is also one of the important modality in these cases. So you can see that once I place this valve, the AML is going to go up and start obstructing the LVOT. If this space is very, very small, then obviously you're going to end up in LVOT obstruction. Septal bulge obviously poses more challenge. Long leaflet length of AML poses a long challenge, and the angle, if it is less than 120 degree, both the valves are going to face each other and can cause LVOT obstruction. So of course, we also have this Darcy simulation on which you can simulate the pre-CT renderings and see whether this is going to cause an LVOT obstruction or not. So is there any other, what are the dedicated devices? We do have a dedicated devices like Tendon, which has got FDA approval in 2024. Sapien M3 has come out as a more easier valve and probably more experimented valve now, and it got an approval last year. And there are Intrepid, which is investigation, cardio valve, alta valve, and so many other things. So Sapien M3 is an interesting one. It has got a dock which encircles around this mitral leaflets, and then you can deploy a valve inside this. This is one of the borrowed slide from PCR London valve. You can see once the dock extension is deployed around this mitral leaflets, then through the same sheath, they can go ahead and deploy this TMER valve just like a regular valve-in-valve TMERs. So Tendon, the SUMIT trial showed non-inferiority versus surgery in high-risk patients. Sapien 3, otherwise generally what we do in a regular practice is a routine Sapien 3, that is balloon expandable valve or a MI valve. This has got almost 86% success rate. 13-day mortality is still 13%. That's what we should remember. So procedural pulse, basically always check for a neo LVOT. If it is less, always consider Lampone. If post Lampone predicted area is less than 170, don't touch it at all. Transseptal, where exactly you puncture matters. That we'll talk in a next extended talk. This is one of the case which we did almost 2 years back. 69-year-old. So this is how a CT picture will come. You can see that this calcium is more than 270 degrees. There are two diameters, D1 and D2, and this is where we measure the area. And we can see that this is how the AML leaflet length is measured. You can see a big septal bulge here. So if I put a valve here, so there's hardly any space between this frame. Assuming that half of the valve is actually covered, there is only a small space here. So once I put a valve, the leaflet is going to be pushed like this. It is going to be outside of frame. Obviously, this is going to cause an obstruction. So there's a high chance of LVOT obstruction. So you need to do something. So what is that? So before even doing that, what you can do is you can predict what is the LVOT area with whatever small diameter remaining. And also if I do a Lampone, so usually this much is the covered portion. If I slit an AML, so this half of the covered portion will be open. So if at all, if I do a Lampone, what is the predicted neo LVOT post Lampone? So this is what is a neo LVOT measurement. Even with an just a Lampone, it might be just 153 millimeter square. It's still not adequate. So what is the other thing which we can do? We can do an septal ablation, alcoholic septal ablation, that is raise the roof in this case. That's what we did in this case. You can see that before alcohol septal ablation, this was a kind of a bulge. Post alcohol septal ablation, you can see that some amount of myocardium has regressed. So post which, when we reassessed with an CT, the neo LVOT area was 316. So we decided to go ahead. So coming to the steps, basically, this is what we were trying to say. So it's a transfemoral vein approach. So once you are there, just like you do an septal puncture for PTMC or a BME, it's the same way. Drop down your needle. So if at all, if there is a valve like this, profile that. So profile that. You can see a calcium here in this view. Similarly, in this view also you can see a calcium. If you are seeing a ring or a valve here, your puncture should be at approximately, if you draw a line from the mid of this valve or a mid of the ring or mid of the calcium, your puncture should be below that point. If at all, if you go above this point, then what will happen is the wire is going to go like this. So the valve may not enter the previous surgical valve well, or the calcium may not go well, and there will be a trajectory related issues. So this generally happens with the giant LAs. Then once because you're pushing from below, the wire starts prolapsing into the LA, and you'll have an issue. That's why we want it to be in the lower half. Then it should be slightly posterior, because if you come anterior, it may be difficult to maneuver the valves. So you need at least one valve length of a distance from your septum to the mitral valve. So that much distance, you can imagine a tower valve length, undeployed tower valve, you go that much posterior and puncture there. This is a precise area. If you do it, then what happens is when you pass a wire, it goes in a very smooth way. You can, next step is actually we take one peripheral balloon of 12 or 14 depending on the valve size, and then do a flossing. That is, we just open this balloon in a septum, dilate the septum, and then with a dilated balloon, we go across the wire and enter into the LV. So this does a flossing and also checks out the trajectory. Any change, if at all, if you feel that a wire is coming out when you're doing this flossing or wire is getting prolapsed, you can use a buddy wire as another technique, or you might have to do a repuncture at a slightly lower level. So this is where at the beginning itself, if you take a proper precaution, should be good. When we all started our TMERs or any transeptal procedure, we used to take a guidance of TE. Over the time, we have learned this trick. Nowadays, even without TE, we can do these things very, very safely. In this case also, you can see that we have done a septostomy with a 12 mm balloon, then we did a flossing, and then the 29 mm valve deployed. Because we were conscious about the LVOT obstruction, we did slightly somewhat atrial deployment. We can see that the valve is okay, LVOT gradient looks very mild. There is some periskirt leak because still I have not done a post-dilatation. After the dilatation, obviously my valve also moved towards the LVOT. Some mild gradient was noticed. The mean gradient was around 15. Patient remained hemodynamically stable. We accepted this result and valve is doing good. Patient is still surviving 2 years. So ESC guidelines 2025 has elevated TMER valve in MAC as to class 2B indication. So take home, MAC and TMER is feasible, but still high risk. CT planning is non-negotiable. Lampoon has transformed the field, so is alcohol septal ablation. You should know your device. For all practical purposes, in India, it is either Sapien 3 or a Merrill. We still don't have an access to Sapien M3. Patient selection is the key. Your outcome is determined even before you enter the cath lab. Thank you.
Thank you, sir, for the excellent talk. Still, valve in MAC is high risk, extremely high risk procedure, and is only offered to patients who are surgical rejects at the current status. And the complications are definitely, I mean, even there is a high risk of death on table also. So, any further questions from any?
LVOT gradient is acceptable when we...
Yeah, that's a good question actually. So I had one slide, I don't know if I have it here. If at all, I'll just show you that slide. So I was expecting if that question comes in, that will be a good discussion. So what generally we do is, this is the protocol we follow. This is an internationally accepted protocol. So if at all, if the patient develops an LVOT gradient, check for the clinical scenario. If there is an associated cardiogenic shock or a refractory hypertension, gradient more than 30 or 35 with a hemodynamic compromise or acute pulmonary edema, immediately you put a pigtail, then exchange it to Impella, and then try to do something or send it for a surgery. That's an emergency. If the gradient is between less than this, 15 to 35 or around 20 to 30, persistent obstruction present, start filling the LV with a volume. So do the serial echoes. If it is progressively worsening, then you send for a surgery, but you can observe for at least 48 hours. If at all, if the gradient is less than 10, then that is the best thing, and patient remains hemodynamically stable, you don't have to do anything. Between 10 to 15, what we generally do is, again, we start lowering the heart rate because we know that tachycardia worsens the gradient. Then we start filling the LV and we take off all inotropes. We try to reduce the inotropicity by giving more beta blockers.
Sir, I don't know whether it relates to our procedure. There were lots of noise recently on social media about a US surgeon who put the valve in a reverse direction.
Yeah.
Is it a possibility in this case? And how do we ensure that valve is positioned correctly?
There's a possibility in all valves, be it a surgeon or a cardiologist.
Who is responsible for monitoring this?
It's
Because
a primary operator. So there's no way that you can shun the responsibility. If some complication occurs, it's always good to own the responsibility and learn from it. So why this happens? When the industry person or your technician gives you a valve, you should check for the orientation. If we have not checked the orientation, it is our fault. Checking the orientation each and every time. is very, very important.
Sir, is there any role of LV angiogram? Because during the procedure, we can take a pictal angiogram of the LV to see the movement of the mitral AML leaflet towards the LVOT.
Yeah, so if at all, if you're doing it before an valve placement, obviously it is going to be dynamic, correct? So unless there is some fixed obstruction because of either subaortic membrane or really the valve has prolapsed and so on, in which case the scenario will be entirely different. Whereas post-procedure, we still do an LV angiogram just to see if there is any paravalvular leak. That is how we see. For an LVOT gradient, it is always the pressure pullback. In case if you add an access to this thing, pulmonary, LV with a pigtail, and if there is some gradient like semi-urgent, not an emergency, or probably if it is emergency, what you can do is you can pass on one more sapien wire, because generally we don't keep the aortic angiogram nowadays in a TMR. If you are doing it in a little older way, and you have an access, you have a pigtail, put a stiffer wire, take one larger balloon and try to open that area of an LVOT area, so that you can push the frame slightly outside, but that again risks there could be a valve embolization into the LA. But at least you will come out of the emergency, then you can plan for an ECMO and other things.
So I think when we are done with a proper puncture, and if our trajectory is right and a good flossing, then it's almost done.
Correct.
But the valve deployment has to be slower.
Yes.
And we need little subtle adjustments while the valve is getting deployed. And there is a concern, Dr. Srinivasa. If this is not Merrill, it's Edward valves, and your negotiation of the balloon was little difficult. And if you take the valve inside, if it is not going beyond the septum, so what will you do? I think it's very difficult situation. Edwards, you can't take it back, isn't it?
I'll tell you some of the troubleshoots. Can we have that other presentation also? So I'll show you one more case just for that, if we have a time, otherwise it's okay. So few things, sapien, always we think that it cannot be retrieved out of the body, especially on the arterial side. From the venous side, we don't have an issue, we can remove it. So if it is not crossing the valve, what we need to do is just go ahead, do one more septal puncture, just pull it back into the atria, just do one more septal puncture over there, dilate the track so that both the tracks actually open up, makes a bigger loop. Or you can pass one more wire parallelly, and now you use, instead of a 12 mm armada balloon, you use a 14 mm armada balloon. So you make the passage bigger, then you can go down. So this
I think
is what
our Merrill valve my valve is really good. We can take it back easily.
We can do this,
and we can do even Edwards also. We can do that.
On a venous side, it's
Venous,
not a problem.
Venous not a problem. Yeah, arterial, I think yes.
Yeah. So, and coming to the coaxiality, so doing an adjustment in a valve in valve is very easy because there is a valve frame already. It is going to get auto-centered. You don't have to do anything. You just have to be very, very slow in deploying. It will automatically align itself. If it is a ring or only a native valve, then you don't have an entire tubular structure to support you. This is where you need to position yourself. So this is where anchoring and movement adjustments are very, very important.
Just like 80-20 for aortic valve, it has to be
correct.
Reverse. 20-80, and the valve has also been crimped.
Yeah.
Opposite should not happen, as surgeons had in US. Which,
so this is kind of a valve and ring, but an unconventional ring. So this we had done some time back. So this is basically a case of a 69-year-old who had underwent a PTMC in 2007. 2014 underwent a mitral valve repair with a Teflon post-annuloplasty. How many of you have seen Teflon post-annuloplasty rings? I'm sure most of us should have seen, at least our generation of seniors, basically because that used to be a low-cost way of doing an annuloplasty repair. Because commercial rings used to cost at least 1.5 lakh and more. This used to be very cheap one, 5,000, 6,000 rupees. So there used to be a lot of rings. 2025, she comes back with recurrent heart failure. Now there is a severe eccentric MR with an MS also. You can see that the RHD things were there. And look at the LA. Almost 9.5-10 centimeters. So, and this ring being a non-commercial ring is invisible. So, and if you want to see, this is how it is looking like as a fibrous tissue. And this is not 270 degrees also, it is approximately 210 degrees. And this is an incomplete circle. By going by the standards, this is not a case for a TMER. This should be sent for a surgery. We sent for a surgery because last time she had a very stormy course. Surgeon refused, and patient is also quite sick. So on ventilator, off and on.
Coming, yeah.
And this is where patient was refused. So we were trying to see if at all if we can help. Initially, we thought if TEER is suitable, but given an RHD leaflets, it was not suitable. TMR commercially may be feasible. When we checked in the valve in valve app, there's nothing like a Teflon ring at all. So because obviously this is an homemade ring, this is not a commercially available ring. So there's no way that anybody would have done. So, but when we researched, we got to know that most of this kind of a surgery was done in Asian countries. So we reached out to our neighbors like Singapore, Malaysia, everybody. Even Dr. Mann, who used to do a lot of TMAR in ring, said like he has seen some 3-4 patients coming to him, but he did not dare to touch them because he didn't know how to tackle this. Because being a non-commercial ring, there's no data. Whether it will hold or not, we don't know. When we discussed with our surgeon said it acts like a semi-rigid ring. You can try, but obviously there's going to be a device embolization. And since it is invisible, how are you going to place is another challenge. So our challenges was, will Teflon annuloplasty ring hold the valve? So we thought we'll do a benchtop testing. We borrowed Teflon ring from the surgeons. We made them do a similar semicircular one. We put a balloon inside it and we started inflating. If it is a Teflon is very stiff, the balloon should burst below the RBP. RBP of this balloon is 16. If the balloon is strong and the Teflon is weak, till RBP balloon will, ring will burst off. This is what is this thing, and we went ahead. You can see that we have gone up to 12. 16 is RBP, 13 it bursted, and balloon bursted, but the Teflon ring was intact. So this gives us some confidence that yes, it is going to stay there. Second, how do you now we know that it can anchor. Second is, how do you mark out this? We thought we'll place one more puncture, keep one more pigtail along the mitral annulus, inject some contrast, and also use a art navigator application, that is CT overlap technique. Second thing is sizing. Nobody knows the sizing. We just measured it inner and outer diameter and then averaged it out. And third is giant left atrium. Whenever you have a giant left atrium, despite precise septal puncture, the valve wire is going to go prolapse into the atria and the valve can keep prolapsing there. Then radiolucent, obviously we thought multimodality imaging, incomplete, so there could be chances of embolization and non-coaxiality. So CT analysis, this is the neo LVOT area, this is the septal puncture which we are doing. So once we have done this Achilles sheath, you can see my wire has gone. Second wire I've kept in a LA. So the first wire prolapsed back. So we are doing a septostomy in a wire now in a LA, not in a LV, because the wire came out the moment we took the balloon. So then we are keeping another puncture. You can see my pigtail is now there. I'm using a buddy wire because giant left atrium, your puncture is not optimal. Railing or flossing is not working well. You need to do a buddy wire technique, or you have to do a railroad technique. You have to externalize this wire through the aorta. That can give you a hold. But here the patient also had a moderate AS, so we didn't want to do that railing. So that's why we went this. So then we can see that we are tracking the valve. If your puncture is good, support is good, the valve will slowly track. So even despite buddy wire, you can see that the valve is going upwards. It's not coming towards the valve. So with lot of maneuverability, deflection, slow tug and tug, you see that if you are not coaxial, this is what is going to happen. Somehow we could maneuver and it just dives into the LV. See, look at the way this is not coaxial at all. This is a non-coaxial. And once it is in place, we just kept there, we took an angios, we confirmed that this is an area of atrioventricular junction. TE also confirming the same, CT overlap is also confirming the same. And then we went ahead. Look at this deployment. This is going to be a very, very slow deployment. Here I'm trying to pull this valve toward the posterior side because I know that that is where the Teflon is there. Anteriorly, it is not there. So I'm not worried about the coaxiality. I'm worried about the anchoring. Once I saw the indentation, then I released the pressure on this, then aligned it well to the atrioventricular axis. And this is the post-LV angio, which shows very, very stable, no paravalvular leak. So this is a 3D MPR showing a perfect position of the valve. And this is how we did our first in world, our first in human TMR in Teflon annuloplasty. So that was one of the things. I mean, that was just to show the steps, like how exactly we do. And sometimes you have to go overboard and think of other steps also.
Wonderful case. So you injected LA just to see the border? you
yeah.
injected LA to see the landing zone.
Correct.
Perfect. So wonderful case, Dr. Srinathan. Thanks for showing. And I think we can conclude this session if anything. Thank you so much again.
Sure.
Next or next?
This one and this one.
Let's see how to do it right.
So calling all of them together. Thank you so much. We move on to the next session, 2 sessions back to back. As chairpersons, I would like to invite Dr. Prithvi Raj, Dr. Devashish Ghosh, Dr. Omlan Mondol, panelist Dr. Shilanjan Roy, Dr. Obhirup Sinha, Dr. Kripasindhu Mayura, and moderator Dr. Nishant Tripathi. Also, we are clubbing the next session together. So, I would also like to invite as chairperson Dr. Amol Kumar Khan, Dr. Shubho Banerjee, panelist Dr. Tutan Das, Dr. Saurabh Kumar Das, Dr. Ravi Vishnu, and also Dr. Girish Navasundi, sir. I would like to invite Dr. Tanmay Banerjee, sir, to please come on the dais. So there will be 2 presentations.
Dr. Girish is there or he has left? Has he left?
So I think we can wait.
Dr. Dhal has gone and he has given me the responsibility to talk both the topics together.
So I think.
Yeah, so thank you so much. This is about left atrial appendage device, and with the recent data which is available to us, we have a good light at the end of the tunnel that this therapy once used to be projected as a therapy which is going to overtake TAVI procedures is now coming up again, and we see that in coming future a lot of LA appendage closure devices will happen, and we have one person sitting there who started LA appendage closure devices in India, Dr. Prakash Hajra. I think he did initially the maximum number of LAC devices, proctored many places, he proctored us also, and then we took, we started doing that, we started proctoring that as well. This therapy has immense value, and that's what I'm going to discuss, the current evidence and how to do it correctly, step by step. So these are my disclosures. So we have very good therapy for non-valvular atrial fibrillation. Someone who is having atrial fibrillation and no rheumatic heart disease, and he has high chance of thromboembolic complications, and if the CHA2DS2 score is 3, 4, definitely it is a big problem. So we have drugs like NOACs, which are wonderful drugs, but NOACs are not the end. You see the compliance after 5 years, 6 years taking NOAC becomes really poor. And you can see the dropout rate, discontinuation of treatment happens in around 20-30% of patients if they proceed for 8 to 10 years. So someone who is having non-valvular atrial fibrillation at 60 years, 65 years of age, he has to live through at 75, 80. So how long he is going to take NOAC, and after some time, he tells, no, I can't take that and I'm okay with that. And so the problem with NOAC is poor compliance. And the patient, if he is poorly compliant, the discontinuation, the no difference in mortality between patients who discontinued NOAC and than those who received no therapy. So someone who took in past doesn't matter. It doesn't matter. If he is not taking, he is at risk, and the mortality is similar. At the same time, the therapy, the LA appendage occlusion device, which were there, become sleeker, more user-friendly. Operators have become more qualified. They are mature, and the implant success rate has really gone high, from 94% to 99%. In Champion F trial, you have something around 98.8% implant success rate. So that is a real, good development which is happening. And also the complication rate, it's gradually coming down to less than 2.5 to 3%. So once feared, once this procedure was feared a lot. We're going to septal puncture, a good device, LA device, what will happen, embolize, pericardial effusion, tamponade. Many things were concerned, device-related thrombosis, peri-device leak, but everything is coming down with the refinements in technology and operators' maturity. So this was one trial which came last year, and it really gave a very kind of discouraging vibes on all of us about the prospect of LAC device, closer AF trial, and they showed no, it's not even non-inferior to NOACs. So, and the reason was, it was done in a patients who had a mean age was 79 years. So you see, 79 years you are trying to see and weigh the LAC versus NOAC, it's going to fail. And the primary outcome rates in LA was 16.83 and medical care is 13.27. And both efficacy and bleeding were combined in primary outcome. So it was also little fallacious, and individual endpoints were not powered. So there are a lot of limitations where there in closer AF trial, and no one took it very seriously. We kept on doing LA appendage devices. No, we don't go with that idea of closer AF. And then came the Champion AF trial, recently presented in ACC meeting. Largest randomized trial till now on LA appendage, 3,000 patients, 1:1 randomized, with a CHATSWA score of 3.2 mean, and they were given 3 months dual antiplatelet followed by single antiplatelet, and they were followed up to 3 years, and the 3 years data is now available. And this was the procedure with implant success was 98.8%, and the serious adverse events, death was 0%, stroke 0.1%, systemic embolism 0%, pericardial effusion requiring intervention 0.6%, other major bleeding 0.4%, device embolization 0%. So very, very less complication, absolutely safe procedure within a good implanter's hand. The primary efficacy endpoints, NOACs are good, and that is where this is matching, it is not inferior to NOACs. So LA appendage closure was non-inferior, but when it comes to safety, the non-procedural bleeding was significantly lesser, it was superior. And secondary safety endpoints, again, it was matching, and secondary net clinical benefit was superior. So this was found to be superior over NOACs. So this is data which is really telling you that if you have to choose, it's not only when patients is bleeding on NOAC, it can be, the choice can be given to patients as per Champion AF, because Champion AF trial took patients, randomized the patients. They did not randomize after the patients were bleeding. They randomized patients who required either NOAC or L appendage device. So it is now an alternate with a superiority on net clinical benefit endpoints. Little bit concerned that more strokes after LAO closure, that too non-significant. That is because anticoagulation works systemically and LAA closure addresses one specific source. There was a bleeding trade-off. We found a lot of benefits in bleeding. So we are trading a one-time procedural risk for a lifetime bleeding risk. So it has to be taken into account. 60 years, 65 years patient, non-valvular atrial fibrillation, CHATSWA of 3.54. There is a case that LASC should be given them the first preference nowadays. It's no more probably with this trial, it's a matter of choice. It can be a preferred option because adherence is important. NOACs, they don't, patients, the compliance is not good. So finally, 3-4 case studies and how to do it. This patient has atrial fibrillation, ischemic stroke, and on anticoagulation, he was bleeding. And you can see here, there was a large LA. Patient also had a kind of hypertrophic heart, and you can see we punctured it. We puncture it postero-inferiorly. That too transesophageal guided. It has to be transesophageal guided, and the puncture, it has to be electrocautery, because once you are pushing it, there is always a chance of trauma. In these large bore procedures, it is better to go with an electrocautery. You can see in transesophageal echocardiogram, its bubbles are happening in LA. It means you have gone into LA. Once you go inside LA, you change your Moulin sheath with the sheath of the device. After taking a stronger, hard wire into the, stiff wire into the one of the pulmonary vein, then you introduce the, guide catheter. Then take the pigtail, maneuver the pigtail. If your puncture is right, the pigtail will go automatically in majority of the times in the LA appendage, in RO projection. You see in RO projection, it can be defined well, RO caudal or little RO cranial, and you can inject, you can see, and simultaneously you can see in transesophageal echocardiogram that you are in LA appendage. You can introduce your sheath inside the appendage over pigtail, and then once your sheath is inside, you can take your device in and deploy that. So I have two presentations I'm making in one, so 2 minutes extra I will take. And this is another case. This gentleman had a PTCA to LAD done by me in 2009, CRT in 2019. Patient has bleeding on 5 milligram apixaban. When you reduce the dose, he had a CVA. So there was no chance we can keep the patient like that. And you can see the patient has a CRT, stents, and this is the LA appendage closure device. We go similarly posterior inferior puncture, we go inside, and this is the T-guided maneuverability of the pigtail into the LA appendage. You confirm it, then on LA pigtail, you take the sheath over that, and then deploy the device. So this is a Lambre device. So that was amulet. That was a device from Merrill in the first case. This was the Lambre device, and then this final case had again a multiple procedure. The patient is a follow-up since 2010. 3 times angioplasty, 1 time AV node ablation, pacemaker, and then again bleeding hematuria on NOACs, atrial fibrillation. This was the amulet device. So it's all devices. They have given us good results till now. And this was a rheumatic heart disease, mild MS patient, a Lambre device. So just rounding up, we have options now, 3-4 devices. We have amulet, we have Watchman, we have a Lambre device, and we have our own walnut device from Merrill. Which has to be chosen? So Watchman Flex, if your landing is good, tubular landing is there, depth is higher, then you can choose that. And in Amplazer amulet, you don't require a much depth. Even if it is shallow, you can do that. Shallow LAO master, superior ostial coverage. These are plug and umbrella device. And the Watchman is a plug device, more or less one lobe device rather than plug, is a lobe device, single lobe. Lambre is a very sleek device. It needs very small landing zone, very small landing zone. And you require only 8-9 French venous access, not more than that. Like we use in Watchman and amulet, 12 French sheath. Here it is only 8 French sheath. For smaller devices and larger devices, 9 to 10 Frenches. So easier. And then I think, and finally we have a walnut device where the sheath is steerable. If you have any problem, you can steer your sheath just like Agilis sheath. You go inside, you make the curve more or less, point towards L appendage, take your pigtail in. So with this, I stop here. I think, I hope it was very clear to everyone how we do L appendage, what's the clinical evidence as of now. And we have a good YouTube video on that, how exactly do one, step by step. Thank you so much for the patient hearing.
Any questions on this?
Sir, we are pleased to have our Director of Medicine and Director of Neurology, Dr. Mandal and Dr. Tanmay. And as a center of LA appendage occlusion, we would like to have their insights and idea about how these patients, they also must have seen so many of these patients, especially Dr. Amlanda. So your insights and ideas.
Actually, I am here in Manipal, PM bypass. I am working with the cardiology team here. Dr. Dilip is just facilitating the concept of cardioembolic stroke when a person had non-valvular atrial fibrillation. It is very difficult to detect fast, but the advantage of TE is detected very early. And once the TE detected, most probably the thrombi, 90% of the thrombi in the LA appendages. So rationale for therapeutic this LA closure. If I say I am a little bit old now, if I see in my ages as 2 decades or 1 decade before, the concept of LA closure was not there. It is only the anticoagulation. But the risks of anticoagulation, the NOACT came before that warfarin. If you see the patient with a cardioembolic stroke, AF, and left atrial thrombosis is there, we are satisfied to start anticoagulation. But there are hints the patient may bleed. That is a risk. Even NOACT also. Before that, warfarin also. But thing is that nowadays, if somebody has atrial fibrillation and LA clot, definitely we choose some of the points in the MRI of the patients, usually guided by the number of microbleeds, or in old days, the cerebral angiopathy. So these are the two conditions. If you go by the by NOACT or any form of anticoagulation, the chance of bleeding is very high. So left appendix closure is the very good method. As the trial shows also, the previous PREVENT trial or other Paraguay trial, they are in favor of giving the option of LA closure. So at least mostly 2 cases of mine already Dilip has done extremely well. They have multiple comorbidities with a bleeding episode. Even the previous ICAs or cerebral angiopathy type of and microbleeds, long-term anticoagulation is very difficult. In that cases, I feel appendix closure is a very good option. We should promote this appendix closure nicely nowadays. This is my take.
Yeah, so most of the devices, newer devices, we can go with a dual antiplatelet for 3 months and then single antiplatelet. Watchman Flex now it is there. With previous Watchman devices, we used to give anticoagulation for 4 to 6 weeks. Now they have also removed. They say it's okay if we can't give anticoagulation, dual antiplatelet is good enough. So dual antiplatelet for 2 to 3 months and then single antiplatelet.
Sir, in the Champion-AF trial, the leading perioperative complication was pericardial effusion and tamponade. So what, according to you, will be the tips to avoid this complication?
It was very less, you saw. It was very, very less. Because now it is all, you are under vision. You can see exactly where you are puncturing. So there is very less chance of stitch phenomenon. There is very less chance of inadvertent pericardial, puncture. So it has come down very less. Many times pericardial effusion happens. LA appendage is very thin structure, very filmy structure, and then if you take your extra stiff wire inside and try to take your sheath on extra stiff wire, then you can have injury. So better to negotiate your sheath on pigtail. To advance your pigtail into the lateral appendage, advance your sheath into that, and then take the device. That is the tip from my side.
Sir, does device recapture and deployment leads to pericardial effusion?
Yeah, so multiple maneuvers there it can lead, and we have a good team with us, Dr. Anil Singhi. I think we operate jointly in these cases, and he is a great help. We see the image and also do the procedure with me. So it has to be a teamwork, just like TMVR and the TR procedures.
You mentioned about the patient who had a PR bleed and then a reduced dose of anticoagulation caused a stroke, and the patient was successfully treated with LASE. I was just wondering, I mean, in acute bleeding situations, can you use the device and reduce the anticoagulation dose so that the future stroke risk is lessened?
Yes, so
as you said about the stroke versus bleeding risk to balance the both.
So that is where this Champion-AF trial just it evaluated. It's not as a bailout device. It evaluated as an alternative. Half patients only on NOVAC, half patients only on L appendage, and they found that L appendage had a better safety parameters with maintained efficacy. So we can upfront go for L appendage device now. I think now we have a 2A indication for L appendage in those patients who are bleeding. It can be probably next with, based on Champion-AF, with the kind of result which we have got, it can be a 2A indication for upfront L appendage in all those patients with who required some kind of protection for non-valvular atrial fibrillation.
And what about patients who have had a stroke on full dose NOAC therapy? How do you approach them?
So if someone has a stroke on NOACs like Apixaban, we can go for a stronger NOAC, dabigatran 150 BD, or we can go for this device for extra protection. So we can go for a lap appendage device.
And still continue that NOAC.
We can continue for some time and then we can drop it.
Questions from audience.
Yeah,
so two questions. One is regarding medical management after LA appendage. Two situations we have. One where there is a bleeding on anticoagulation. So in that case, you said you will continue with some antiplatelet just after implantation because you can't give anticoagulation. One indication is where stroke even after full dose anticoagulation. In that case, what is your after deploying the device? You continue your anticoagulant along with an antiplatelet or simple a single anticoagulant after that?
Yes, it depends. It's choice because those patients who have recurrent thromboembolism even on NOACs, they need dual protection. Maybe a systemic with a NOAC and a local with a L appendage. Yeah, we can continue with NOACs.
So dual therapy after deployment, we have to give dual therapy.
Not dual therapy, NOACs with LAC both.
LAC we have given, but for a device, will you need an antiplatelet on an
No. If we are doing NOAC, no problem.
Of time?
No, if we are giving NOAC, we don't need antiplatelets. And for 3 to 6 months, we can continue NOACs and then we can drop it to dual antiplatelet.
Sir, because the indication is
No. So there are some. I couldn't get your question, Samsad.
One thing was that continuing an antiplatelet along with a NOAC in those cases who had stroke even after anticoagulation. So in that case, we deployed Watchman.
Antiplatelet has no stroke risk reduction in atrial fibrillation. You are okay with that? Yes. Either this is NOAC or no antiplatelet. Aspirin doesn't give. IBHRE trial it showed there was no benefit. Clopidogrel no benefit. So only NOAC. And if you are giving on NOAC, the patient has an embolic event, then you just plug it. LA appendage occluder device as well as you continue NOAC because these patients require two kind of protection. Protection doesn't come from antiplatelets. We give antiplatelets in these patients to avoid the device-related thrombosis, which is DRT that I think and PDL which he is talking about, Dr. Prithvi. So PDL doesn't change with antiplatelet therapy. Antiplatelet reduces the chance of device thrombosis, which was there in 15-20% cases which I've seen. Now with these devices has good coating, so chances of thrombosis is very less. Hemocoat is there in a Watchman device, and this walnut device has a good coating, so they don't require much of dual antiplatelet. 1 or 2 months is more than enough.
I just like to make a quick comment.
Procedural thing that there is a issue with the stiff wire because it can
lead
to puncture.
Yes.
So when you track your pigtail, you track your sheath directly on pigtail,
directly
or you
on
keep
pigtail.
a wire inside pigtail and then track it.
If you take your wire, hard wire, stiff wire in the pigtail, it will change the orientation, and it will difficult then to negotiate your sheath. Let the pigtail be there, and you advance your sheath on that.
So we do not need any extra support inside pigtail to track
it goes because it is trajectory is like this.
Another thing, Dilip, in very less number of cases, the stroke mechanism of cardioembolic stroke we are taken care of atrial fibrillation. But second stroke mechanism, it happens like small vessel vascular disease. In that cases, what he is telling, antiplatelets decision has to be considered because the stroke mechanism, if it is different from cardioembolic stroke.
Yeah. So if you are giving NOAC, it will take care. Yeah. No, we don't require. Yeah.
I think
Thank
one
you.
person.
Yes.
One last question we can take.
So, sir, I had one atypical case. Patient stayed in sinus rhythm. 7 days, Holter was normal. PFO was not there. And T, which I did, there was no atheroma. This MRI also, the carotids were clear for carotid angiography. But there was embolic stroke. Patient on antiplatelets had 4 times such event in the first, in 1 month. So, such a patient whose L appendage is clear in sinus rhythm, no other cause is identified. Should we go or advise this L appendage closure in such patients?
I don't think so. I think we should pursue more of PFO kind of thing. with a T-guided bubble, echo.
Both
So it's not a transthoracic, it's T.
T I did.
You have done. It
And
was
T,
negative.
saline contrast was negative.
Then there can be other reasons, I think Dr. Amlanda can tell. We don't have evidence to go for L appendage in these cases.
Okay.
Maybe you can see the L appendage velocity, and if it is lesser, but these are
okay.
conjectural. I think we don't have evidence, and we don't have any study on that line. Amlanda, he's saying patients with recurrent stroke, no PFO, young patient, 3 times, 4 times stroke, and no evidence, other evidence. So can we go for L appendage, or what could be other reasons?
Etiology of or mechanism has to be defined.
Yeah.
In atrial fibrillation, once the mechanism is cardioembolic, you got the.
He was sinus rhythm. In his case, it is sinus rhythm.
Sinus rhythm, I think,
yes.
I don't think there is no indication.
Okay.
Big round of applause for our chairpersons, panelists, moderator, and of course our speaker. We end the session over here and move on to the next session. As moderator, I would like to invite Dr. Ashish Haldar on the dais, please. And chairpersons, Dr. Raja Nag, Dr. Bashubendra Chaudhuri. Panelist, Dr. Anindo Agarwal, Dr. Shomokanti Datta, Dr. Rajesh Babarao Bhurkundi.
So good afternoon, everyone. Just sharing a 10-second story. So I was doing AF ablation in the Cath lab, and just outside the Cath lab, my sir was standing waiting for his turn to do the LA appendage closure just a few months back. So he is none other than Dr. IBHRE sir. So let's have him to hear his speech over LA appendage closure and complication and management. Over to you, sir.
I had another talk, so I tried to finish within 10 minutes. Vitaflow. So both these guys had TAVR, and Henry Kissinger and Mick Jagger, one of my favorite. So this is the first case of TAVR in China. There will be first case of Chinese valve in here tomorrow in Calcutta. I'm not revealing the name of the hospital. From China, different varieties of TAVR have come, CLEEP has come. One of them is Vitaflow. And this has got certain special feature, and these sheaths are bendable. There is only one valve which can be rotated during implantation, that is Jena valve and J valve. Bendable valve is Vitaflow, and these are the valves originated from China, starting from the Jena. The first TAVR done in India, I'm not revealing the name of the person who did it, was done on air, not in aortic stenosis. So more and more valves suitable for air will come in the future. And this is the smartest thing in new technology. So you have a valve and you have RBB, you implanted TAVR, patient goes into complete heart block. You put a temporary pacemaker, pace it, patient has RV perforations. So you have a TAVR valve which are embedded with a microchip and a micro pacemaker which can be triggered by your radio frequency wave, and this can space at 180 to 200 bits per minute, and that pacing is LVB pacing. So suppose you have LV dysfunction, if you pace from the right ventricle, it is RV pacing and patient can crash. This TAVR pacing can cause less LV dysfunction because you are actually stimulating like LVB. And you can keep it as a permanent if you really want to activate for permanent pacing with the TAVR valve. And also nowadays we are thinking a LA closer device with a sensor inside which will modulate or release some drugs over time, or monitor the blood pressure, or monitor the LA pressure. So this TAVR valve has come with a sensor nowadays. These are called SAFE valve technology. And you have not seen any human applications. Once you get the FDA approval in US first, we'll see the TAVR valve degenerations, the halt, the gradient, everything can be measured by the sensor as well as the need for pacing. Now we talk about different varieties of pericardium. There is a study nowadays available, the bovine pericardium, peritop, and the pig's pericardium is thinner, but pig's pericardium is very strong. So if you see any structure like LA appendage, where you see the parchment like LA appendage membrane, don't think it is very weak. It's very difficult to puncture this LA membrane until knowledge, as Dilip was mentioning, push the whole device with the sheath. So LA closure complications, the chance of through and through perforation of the LA appendage is very, very rare. Now we are learning also same thing in the RA appendage, where we put the leadless pacemaker. It's very difficult to puncture or perforate the appendage. It's much easier to perforate the free wall of the left atrium, free wall of the right atrium. And also we are coming to the next level of TAVR. We have come down to 65, 70, 75. So there will be no transatlantic alignment as far as any guideline is concerned, any therapy is concerned. Europe or America will differ. But the sweetest spot may be 70 years for Europe and 65 for Americans. So this is the first time we are doing a trial on 50 years. The 50 years bicuspid valve, which is too young for any TAVR procedure, will be tested in these believer trials. So there will be new generations of valve, like Siegel valve. This 8 French TAVR is reality now. 6 French TAVR will also be reality through the radial in the future. Biomimetic valve, polymer valve, encounter valve, fully automated delivery. You don't have to decide anything. Like the valve will tell you through the computer, this valve needs 1 millimeter extra. You just have to feed the valve with certain like annular diameter, the type of the valve. And this, not the type of the valve, certain diameters you have to put. The valve software or the AI will tell you, you have to inflate this much, this should be the post tapping volume, and it automatically will be delivered. So Jena valve, as I said, this is the only valve approved for the AR, and the Hanker valve is a balloon expandable valve for the AR. And the first time, as I mentioned, the vector procedure, like if you have a valve in valve and third valve cannot be done, the percutaneous CABG is possible. You puncture the aorta through the graft. You, if you have a high risk of coronary occlusion, you put this biotronic graft from the aorta to the LAD. The first time we have seen that TAVR valve can also be done on the mechanical valve. Initially, they have tried to remove the leaflets. It was too difficult, and the leaflets actually embolized in a smaller fragment. So what they have done, they have just inflated the balloon, damaged the valve, and the other valve is ready. The first mechanical valve TAVR has been done in 3 cases. We're also moving for the newer views. The left main I was talking about. We talked about 2 cuspal, 3 cuspal. Now in a compromised situations, there's a paper published in JACC. We should also look for left main view. Now we have talked about the complications, and out of 56,000 patients in US in the insurance literature or the data, device malfunction is the commonest one, 28%. Annular rupture is 1.8%, and 1.9% is the coronary obstruction. So coronary obstruction is very, very rare now. We have more robust technology, thinner valve. The coronary access is also much more doable. So don't think about this coronary access will be real challenge, the barrier of wider penetration TAVR valve. Rupture, so these are the areas where the valve can rupture. And now coming to the main presentation, complications. Now this is the LA appendage. It's really a tongue-shaped structure, and that's the inside. So in the autopsy, if you see, there is a parchment, and the light can pass through the parchment like membrane, but it's very top membrane. The Lambre type of device or amulet type of device occupies the ostia, and any diameter, any type of LA appendage can be closed. Now the complications are like, perivalvular leak. If you have more than 5 millimeter leak, either remove that device during the implant or implant a second device or plugging it. And the complications can be avoided if you really know where the LA appendage is. Usually there is a certain clock orientation everybody should know, that if any structure is beyond 12 o'clock, looking at 10, 11, so these are the structure, usually RA appendage, on RO. But very, very rarely the LA appendage looks towards 11. So the territory of LA appendage is 12 to 3 o'clock. So 2 o'clock or 1 o'clock is the ideal situation for your appendage, and 1 o'clock for pulmonary vein, 3 o'clock for your LVP pacing, and anything beyond the heart, you are in pulmonary vein. So if you embolize this device, the next best thing is to bring your, this jalebi wire inside the appendage. Perhaps you have to upsize the sheath. Sometimes, nowadays there is 8 French TAVR I mentioned. In London valve, they have also mentioned 8 French TMVR. So 8 French TMVR cannot be used, the sheath, TMVR sheath 8 French cannot be used for any extraction or removal of this large device. So few cases we have seen in India, but I have faced only once, and immediately I have removed it by the snare. So you should have different type of peripheral snares. The problem is which part to catch. Any part you catch, if it is stable enough, if you have produced a large ASD, like if you have just a puncture, it will be very difficult to remove the valve. So you have to enlarge sometimes the septal puncture site with a 12 millimeter balloon like TMVR. If the device is very small, you can remove. Now the most difficult part of any LA closure device migration is from your LV. Sometimes it can go into the LV, and these device, do not have, that kind of ASD device like a membrane. So ASD device stops the flow, but this device do not stop the flow. So even if you have this device migrated in the LV, the blood will still continue to flow rather than completely obstructing the inflow. So this is the beauty of this device. Now you catch this one end, snare. You have to see in 2 different planes. Sometimes those who have a biplane system, much easier. Once you catch this, it can migrate into the pulmonary artery again if you lose the device. Sometimes, those who are using Micra pacemaker or ABR pacemaker, they have the 27 French large sheath. And once you bring it to the RA, this Micra sheath can be placed in the IVC, and you can remove as a whole. And now the latest thing in US is your Ono device. So this is from B. Brown, and imagine a TAVR or TMVR as embolized in the LV. What do? You have only one solution. So you can go transapical with this Ono device, and it can remove up to 29 millimeter of balloon expandable stent. So you go there, and there is a snare. This LA closure device, the bullet, the tumor, the vegetation, the TAVR valve, the TMVR valve, what not has been removed from the Micra pacemaker, ABR pacemaker, anything and everything can be removed by this device. But this device is little costly. So once this basket is in, this basket is very soft, the basket can collapse the device to a smaller size, and then you can just drag it and become much more easier to remove this device from the circulations. So this is one of the device, like LA appendage or TMBR. TMBR has been removed by this ONO device. So ONO basket is quite handy in some of the complications like the weak device has embolized. But the TSP, you should give a nice puncture, posterior inferior puncture, then heparin, then where no air embolism, no clot formations, then your most of the complications are done. If you produce a small pericardial effusions, then you need to drain these because these are acute cases. Most of the time, the junior doctors, they puncture the pericardium on the table on the AP view. My sincere request will be to go dead lateral, take a 5 cc syringe with a contrast, and you will see on the right side, on the left side of the screen, there is a sternum. On the right side, you have the heart or the posterior structure like spine. Then you go anterior and gradually inject the dye in small quantity. You can see a track. Once it enters a thin zone of pericardium, the dye immediately disappears. Then you put the wire. You cannot see these things on AP view, and in AP view you can puncture anywhere. So these are the few points I wanted to highlight. Thank you, Dilip, for your kind attention. Thank you.
Thank you, sir, for your presentation. You have stressed upon the device migration and how to deal with it. But the entirely one thing I want to ask you, because many a times the notion of giving this LA appendage closure is to achieve the same kind of efficacy as the NOAC does, at the same time to minimize the complication in respect to bleeding. But sometimes the device choices may not be ideal to occlude the whole of the appendage. There might be some sort of leakage around the device. So how to mitigate that leakage, or if there is a leakage even after implantation, to how to deal with it?
So if you have seen on the table on the day 0, this device leak more than 5 millimeter by color flow, you have to use one plug, ABP plug, or another small device side by side. And DRT, device related thrombosis, later on is also another complication I have not mentioned. If you detect later on that there is a recurrence of stroke in spite of having LA closure device, the A patient can have recurrence of stroke from other sources, carotid, and also hemorrhage. But if you are not sure whether it has come from the device or something somewhere else, or a left out PFO, then you have to close the PFO. Then you see whether peri-device leak is more than 5 millimeter. Then you use again ABP. Some people have used coil also, has gone beyond the coil, and they have plugged whole left appendage. Now, if you have a new device like called invagination device, you put a suction machine inside the appendage, suck the appendage. It will get sucked in with a basket, and the basket will give a tie. So there will be no left out sac in those cases. Conformational LA appendage closure, like a cement, you give a biological cement occluding the os, the biological cement will immediately fill up the whole appendage. But conventional device, we have 3 and 4, you have to use a plug.
Right, sir. So excellent deliberation, Dr. Hajra. So I would like to ask one thing: how often do you recommend post LA device closure angiography? Because as we all know that L6 territory, the high OM territory is very close, and if we have to uptitrate the size, and is it there that we have a chance that we may occlude or even pinch any kind of vessels?
Circumflex.
Yes.
I think circumflex is a very important artery for Ashish. Doing PFA ablation can go into spasm, but circumflex artery compressions by LA closure device is not seen. Rather, it's a guide. If you have a stent, it's a guide. Circumflex artery is the most posterior structure, and this is the last stop of appendage. That means it defines the os. That's the beginning. That's the beginning of the appendage. If you do not see this circumflex artery at all, perhaps you have to re-evaluate your T, maybe entering into the large pulmonary vein. So circumflex tells you that you have entered in the appendage. Second, this is the actual holding area of your device. That's the area around the circumflex. There is so much of fibers in the muscle. Other part, the pulmonary ridge is actually mobile. But the circumflex is the anchor like tower. Aortic stenosis, you have the calcium, but the circumflex is the holding point of the appendage like your Watchman plagues or otherwise.
Excellent lecture, sir, as always. I would like to ask one question. What all precautions should be taken in giant LA while doing the procedure, large LA?
So giant LA can be done with only one device, Lambre device. They have a special size. Sometimes two devices, two sheaths, two devices, like your, coronary. If you have a large coronary artery, there are certain coronaries. Suppose you want to do a drug-coated balloon in a large 6 millimeter, you have to use two balloons. Similarly, to adopt large LA, you have to use two devices, one big, one small, or two equal size. That will do. CT scan is most important.
I think one last point, you are so much passionate about LA appendage occlusion. In today's time, when LA appendage closure is recommended in presence of contraindications to NOAC, we have several trials like in option, there is LA appendage closure versus NOAC. So simultaneously, even after PVI, you can directly go ahead with the LA appendage occlusion rather than put him on oral anticoagulation. On the other hand, we have several trials like Champion AF and Closure. Both are having contradictory result. So how you are reading these trials in contemporary periods?
Okay, so mentally speaking, everybody should go for LA closure. Philosophically speaking, everybody should go for LA closure because it's one treatment lifelong. Once you feel it, you can forget it. Now, as far as the guideline is concerned, surgical or not surgical measures 2A, because initial trials, they did not show, this was a small trial and cardiovascular death was reduced by a very small number. But after Champion trial, perhaps it can occupy class 1A positions in the future. About the option, there is option trial of option like ablation and LA closure. So as we did first case, ablation first, then followed by LA closure, because that area will create a lot of edema. It will be very difficult to measure the size of the appendage. So you finish your job with PFA or thermal ablation of the atria, then I'll put the LA closure device. If you put the LA closure device first, perhaps the area surrounding the device cannot be ablated with the PF. So standard practice is ablation followed by LA closure, nothing lifelong.
Thank you, sir. Any question from the audience? So we can conclude the session. Thank you.
I'll request our chairperson to please stay back, panelists to kindly stay back, because we have a presentation. I would like to invite Dr. Anmol Sonavane sir to please come and share your presentation.
Hello, hi, good afternoon and good evening, everyone. This is Dr. Dilip has requested me to share a most learning case and which has learned almost everything from this case and which has been done recently 3 weeks back.
Dr. Madhupati Pandya
But it is one of the most complex and I would really like to have any insights. If anybody is having any inputs, you can certainly give.
You can join there.
So this patient is 79-year-old lady, known case of Church-Strauss syndrome with vasculitis on maintenance steroid. She presented with dyspnea class 2, class 3, 2 episode of LVF, pulmonary edema on diuretic, treated with diuretic non-invasive ventilation. October 2024, she was diagnosed at bicuspid aortic valve, severe aortic regurgitation with ascending aorta aneurysm. Ascending aorta was 60 millimeter. So, on 9th November 2024, patient underwent an aortic aneurysm resection with mental surgery with valve. They have put 2.5 centimeter Inspirus Resilia composite connect conduit, and patient was extubated next day. It was hemodynamically stable without any supports and without any drain output. On day 3, post-operatively, on 12th November 2024, the patient crashed in the morning. CPR was given. All drains suddenly started flooded with frank blood. Almost 300, 500 ml of blood in every drain. HB dropped from 12 gram to 2 gram. Resuscitation was done, multiple transfusion, and decision was taken. There was a tap-like bleeding was happening into the drain. So the patient was immediately taken up to the surgery for re-exploration, and they found there was a aortic rupture at the aortic annulation site. So which was closed with Dacron pericardial patch by the surgeon. Patient again shifted back to ICU, had a really stormy course because patient was to begin with immunocompromised on maintenance steroid for chest troughs. So she developed AKI, liver failure, DIC because of massive blood transfusion, sepsis, septic shock. Blood cultures were positive with Pseudomonas. The sternal wound cultures were positive for fungus and was treated with prolonged antibiotic antifungal treatment for almost 8 weeks to 10 weeks roughly. And God was kind, patient was recovered completely from that whole stormy course, got discharged in January 2025 with normal LV function, normal functioning surgical valve bioprosthesis. Now patient again complaining of chest pain, left-sided, dyspnea class 2 for 4-5 months, dysphagia, loss of appetite, and there is some pulsation in the neck and the left precordium. Patient had one episode of acute pulmonary edema, hypoxia, admitted with acute LVF, anti-pro-BNP were nearly 28 to 30,000. So we did an echo, started stabilizing the patient. This was 3 weeks back, she admitted with this. And we found there was a moderate to severe aortic regurgitation. PST was 180 milliseconds and ejection fraction, which was normal in Jan 2025, has decreased to 40%. So we treated with BiPAP, diuretic, and we were really concerned why the Resilia graft and the valve has degenerated in 1.5 years. That was the thought process in our mind. So we sent again the blood culture. All blood cultures were negative. We did a TE. TE showed moderate to severe AR, no vegetation. But TE has low probability to pick any vegetations or any kind of thing. We thought last time she had a stormy course, blood cultures, fungal cultures positive, most probably some endocarditis and valve must have degenerated. We did a PET CT. So bioprosthetic valve, aortic root, there was no uptake. So there is no infection of the ventral conduit as well as the valve. There is some mild uptake which can be seen at the sternum, which suggestive of some osteomyelitis of sternum on the internal side. So in spite of optimal management, diuretic and BiPAP, we could not control her heart failure. She was continuously being in heart failure. Anti-pro-BNP was still 20,000 plus. She was on BiPAP requiring a lot of oxygen. So we thought the valve has been degenerated. We are not having any objective evidence. So let's fix that AR. So that is the only way we can salvage this patient. So we did a CT aortogram and planned for valve-in-valve tower in a Bental conduit. So this was the CT. You can just have a look. If you can pick up anything unusual, then let me know. I'll just run it. So this is a conduit. This is a valve, which was 25 millimeter. I am not expecting anyone will pick up, but I'll just tell you. You can see there is around the aorta, aortic root and aortic valve, there is a huge structure which is engulfing the whole aorta. You can see that as we are going from LVOT to aorta, it is a whole structure which is engulfing that whole ascending aorta, that graft, root, the coronaries and aortic annulus. And you can see there is a connection of this structure and aorta at this level. There is a direct connection. So we did multiple sections, multiple views, coronal, sagittal, to study what it is exactly, because even we have not seen something like this, at least I have not seen. So you can see, you can appreciate it very well here. It is, the whole mediastinum is filled with this structure which is engulfing that whole aorta. So finally, we rendered it and everything, and we can see here there's a huge aneurysm measuring about 160 millimeter by 130 millimeter of ascending aorta involving arch and whole root and even including aortic annulus. And you can see the neck vessel which are all distorted very badly because of this aneurysm. So now you can see the entry point here. There is a good connection between direct aorta and this, and we measured this connection. It is almost 9 millimeter. So it is, see, coronary artery is almost 5 millimeter or 4 millimeter and everything. It is a direct branch like thing which is coming from the aorta and direct connection. So it is pseudoaneurysm of aorta which has come from that junction, and the origin of this pseudoaneurysm was between the brachiocephalic and the left or right carotid, between that. So the whole arch is also at the stake. So now we are having a situation where this post-surgical lady had a stomach, somehow survived, 78-year-old, frail, she was only 40 kg. Immunocompromised on steroids, some osteomyelitis, bioprosthetic valve degeneration, moderate to severe AR with persistent heart failure, and huge pseudoaneurysm around the ascending aorta arch with impending rupture, because there is almost pulsatile chest, and the primary tear was something around 8 to 9 millimeter in the neck, entry point between innominate and left carotid artery. So what should be the plan for this patient? Any ideas come up in your mind? What can be done? Random. Okay, I'll just share what we thought that time. Yeah, I'll just mention the options, then let them think. So, can we send this patient like immunocompromised, 78, frail, third redo surgery? Valve-in-valve tower in a Bental conduit and to stabilize the heart failure and leave the aneurysm as it is? I'm just put forward in my thought process what we were dealing with. Complete EVAR with complex debranching plus valve-in-valve tower. Hybrid, open surgical debranching with endovascular graft plus valve-in-valve tower. And another is conservative management, not fit for anything, any major surgical procedure, let her be like that only.
So hybrid option would be the best.
Okay.
So hybrid procedure is obviously will be our choice,
So
otherwise we can put a valve in valve and go for a ASD device closer if the 9 millimeter that area and the other part of the pseudoaneurysm is sufficient enough to cope up that other part of the device, then we can go for an ASD device as well.
Okay, excellent. So good inputs. So we thought third redo, I don't think she will be able to tolerate, she will come up. Majority of the time, sternotomy only, that aneurysm will rupture and she might not make it before the surgery. When we valve-in-valve tower and fix the failure and leave the aneurysm which is impending rupture, if it ruptures, anyway she is not going to come back to hospital ever. Complete EVAR was very challenging, and I don't think it is possible to do it because of the complex debranching completely percutaneously. Hybrid was one option what we were thinking, but again, if you do a hybrid, you have to do a debranching from the neck, take it to the left and below the trachea and everything. Whether she will tolerate that and all is another. See, talking about hybrid is very easy, but if you talk to a surgeon to do and complete neck vessel debranching, they will step back. Conservative was one of the options in the list, but then we thought, can we do something least invasive possible? Can we close that entry point and that neck of the aneurysm? So with the transcatheter way, either coil, glue, device, endograft with innominate fenestration, lot of things. But what approach, what catheter, we were not knowing it because we have never done it. So the plan was to close with that ASD device, if it is possible, because it was a 9 millimeter, to fix it. Fix the ASD device with the petticoat graft stent, and then we can see how it is going to behave. Then we thought right femoral artery cut down will do, because while entering into the aneurysm, if it ruptures, it is like an rupture aorta and she will crash. So for the peripheral percutaneous bypass, we did a cut down on the right side for the right femoral artery and vein. Left femoral artery 7 and 9 French access with the device closure, pro style we have done. Right brachial, because we don't know from femoral we will be able to cross it or not. Then and we started with a blood pressure of 96/30. So there was a significant amount of AR. So this was the first shoot when we took. So we just could not see where to enter, where to put a catheter, and where to aim. So seeing on a CT is very easy, but when you be in the lab and then have a catheter in your hand, it is really tough. We try to see it in multiple views. Anyone, any idea which view or which
Any
anything
lateral
which can
views?
help us?
Any lateral views of the aorta?
Yeah, we have taken a lateral. They are also similar kind of thing, not useful at all. We again went back to the CT and we again tried to evaluate with our Tremenshaw software to see whether we can get any RAO angle or anything which can align that aneurysm and the aorta in one plane. So we derived the angle RAO 22 and caudal 35, and we went into that angle where we could see there is an entry and this aorta, and you can see the whole aneurysm nicely here. So with that angle, we tried to enter. We use that neurocatheter. See, being a cardiologist, never done a neurointervention. We use that headhunter something catheter name to enter that with a Terimo. Luckily, we could enter with a good amount of struggle. We were very careful. Then we exchanged that into a stiff wire. We advanced our sheath because it was 9 French compatible, because it was almost a 16 millimeter of Amplus device we thought to occlude. We confirmed we are into the cavity and that aneurysm. We injected into the aneurysm and we were happy. And we took this device 16 millimeter, but with multiple attempts, see, this device was made for ASD, not made for this kind of aneurysm. There is no, it is not a structure which is hold properly both the disc. So that aneurysm was not allowing that aneurysmal disc to align very properly. So we did multiple attempts. We took shoots. We tried our best. What are the skill we are having to adjust and seal that entry point. But you can see on the top end, because the discs are not aligned properly, the aneurysm was completely filling from the top end continuously. Pressures were still low. We tried multiple times, multiple resheath, multiple attempts, but we could not get a perfect alignment. Then we thought, we'll deploy this device like this, and what are the neck, we can fill it with some coil. So we crossed the aneurysm again with another catheter. You can see another catheter, another wire, another axis. Then we tried the device, but it failed. Then ultimately we switched to a multifunctional occluder, MFO device, which has a smaller disc and a bigger disc. So we thought we can put a smaller disc into the aneurysm and bigger into the aorta. So luckily, we were lucky that multifunctional occluder, I'll just go a little fast, sat quite good way. So we are very happy. You can see the aneurysm top end and the disc is sitting very properly. So we are very happy. Oh, at least we got something to hold on there and everything. So we put that, but the flow was still there. Then with another axis, we fill that neck with a coil. With 3-4 coils, we put it, but still, and we release the device, but still there was a persistent flow. Then we thought, as decided, we can put a petticoat graft. So you can see the entry point here because the coil you can see. We have taken a Lunderquist wire and we have put this petticoat graft across the site to seal and to double brace the device so that it should not embolize. But still there was a significant amount of flow. Pressures were still in that range only. Then we thought little heroic, which has not been done, but it was an out of the box thought. So we thought to directly puncture, because we can see the pulsation from here. We directly punctured from skin and enter into the aneurysm with a micropuncture needle. You can see this needle coming directly from the ribs, and we entered. We have to be sure about it ki we are into the aneurysm. Then we put the catheter, we injected with a micropuncture sheath, and we are sure like we are into the aneurysm. So we took another catheter, directed it to the disc which is inside the aneurysm, and we thought we'll fill all that space with the coil. So we did that, multiple coils. The pressure started picking up at this time. Then we thought, why not to glue it and thrombus this whole aneurysm. So we injected glue around that disc so that it can completely thrombus. So we injected almost 5-7 attempts of glue there in that sac. And then the moment it started getting a thrombus there, the diastolic blood pressure started picking up. So we did a literature research and we found there were 2 case reports has been reported in India. One from Narayan Hridayalaya, Bangalore, and one from GB Pant, Delhi. Both are having a similar kind of situation, but both the patients were young and they went for the surgical closure. But to our search, at least, there was no one who can tackle this kind of situation completely percutaneously. And so it is the first time in India we successfully closed this large ascending aorta pseudoaneurysm with multifunctional occluder device with a Cook petticoat dissection graft and intraaneurysmal glue and coil. The moment it got thrombus, the diastolic blood pressure, which was 30, started going to pick up, and 70, it became 70. We repeated an echo again. It showed trivial to mild AR. EF has improved. The gradient across the valve were hardly 11/5. Patient did not require valve-in-valve tower. And day 5, the heart failure is very well controlled. And yesterday, the patient got discharged home. So thank you so much for your patient hearing, I think.
Excellent case. First of all, I can see Dr. Singhvi raising his hand. So that is my question again, why not T in this case? And the second is that why not you have taken Agilis catheter when you have entered the aneurysm sac rather than going with a different type of catheters?
No, it was not different. We just take a headhunter to enter and then just an sheath to occlude that with ASD, nothing
right,
else.
sir. And the thing is that the MA4 device, multifunctional occluder, probably it was a 12/14,
Yeah,
14 by
14
by 16, whatever the MA4 is that. If I change the MA4 wire, that anchoring wire has to be changed with the vascular plug wire, that is much more less stiffer than the normal ASD device wire. So
But we
it
didn't
would
feel
have
the need that time. Everything was going smooth. Only for that neck, we
that
thought
so that we can, if we can pull the MA4 neck to a much more to the aortic part, then it would have occluded.
No, we did that. We tried to occlude everything, but see, even if you pull it from the aneurysm side, ultimately your disc is prolapsed and the flow
Yeah.
was continuously there. Unless you push it from here and stop the flow, it is not going to work from the aorta side.
From the aortic
So, in spite of releasing,
So
doing
MFO,
tag, everything,
MFO
it
is
was,
not kind of device that will handle the pressure of the aorta.
I
and
agree.
Obviously.
That is the reason the double breasting was thought.
Yeah,
It should
right.
not embolize. That was the thought process. ASD would have been a good, but it was not getting aligned at all.
Right.
Almost 10-15 times we attempted, but it was of no use.
Anyways, great case. Thank you, sir.
I think an excellent case, and this proves this notion that the fortune favors the brave people. One point, the MFO is meant double disc. The higher pressure zone should be the bigger disc. You put it in another way. So I guess on an hindsight it's easy, but still, if it was fit on an reverse way, then the aorta will have that bigger disc, then the pressure could have got, no, you have put on other way, that's what I saw.
No. The 14 was into the aorta and the 12 was into the aneurysmal sac. Obviously, we cannot put 12 here and 14 here. Huh.
It looked like it was
No,
otherly.
no, absolutely no. It is 14 on the aortic side.
Because the bigger disc should be
aorta. Because the flow is from aorta to aneurysm, not from aneurysm to aorta. Yeah.
So it was looking like the other way around.
Absolutely. That would have been a catastrophe.
Very nice case. The MFO device, how many people know that, how many people, which country has produced MFO device? Anybody? India. So it is Dr. Rao's, Nageshwar Rao's productions, manufacturing idea. No, MFO device can be loaded both sides, this side. Now, people have done with the ASD device. I have done with one ASD device, pseudoaneurysm. Another device is, electroser device, like Watchman flex can be put there. In hindsight, do you think the graft was needed?
So, if we would have put a graft, the debranching complexity in that frail, immunocompromised lady to undergo a surgery will be
No,
very tough.
whether, I'm saying whether these patients actually needed graft or not.
Grafting
No,
for
so the stent.
a stent graft, no?
Why?
See, the problem was, sir, our aim was having a bigger device so that it will anchor. See, MFO, we were not really aiming for using a MFO device in this patient. We wanted to be doubly sure कि it should just be on the wall by stent graft and it should not get embolized.
So
Because the flow blood pressure.
you have implanted large graft to anchor the device which you have put, MFO device. I don't think the graft was needed.
So
the
that time
MFO
the thought process was to,
okay, fine.
the
I mean,
device should
you are
stay
the
there.
operator, you know the best. Now, if you have punctured the pseudoaneurysm, how many times you have punctured? How many times you have punctured the pseudoaneurysm from the skin?
No, we have not punctured. We have just crossed 2 times. From that, whatever the communication was there, we just crossed it 2 times in the dedicated view what we derived from the CT.
Twice.
Yeah.
So 2 times you have injected glue. Ideally, no.
And 1 from skin directly, 3 times. Yeah.
Oh, that's what I'm asking.
Yeah.
If you have done like if you puncture, you put a sheath, then put 2 wires. Every time you inject glue, the neuro glue,
Yes.
your sheath get clogged.
Has to be.
So
out.
then you have to take it out the sheath. So you have this wire.
Yeah.
Now through that wire you put another sheath, another 2 wires. You inject the glue with the second sheath, take the sheath out, still 1 wire is left.
I
Through that
completely
wire,
agree, sir.
again sheath, again 2 wires. You can avoid 3
It
punctures.
was done for the first time. Next
No,
time
I'm
we
just
will certainly be
I'm just giving you ideas because in pericardium people have done. So once you inject to the pigtail, you have to take the pigtail out, go for a pedicle puncture, and then they take the pigtail out. Thank you.
Thank
Nice
you,
case.
sir. Yeah.
Thank you so much to all the chairpersons, moderator, panelists, and speaker. We move on to the next session. Ego Guidance in Tier. I would like to call as chairpersons Dr. Ipshita Mojumdar, Dr. Shilanjan Roy, panelist Dr. Shubhradeep Datta, Dr. Shamshad Alam, Dr. Manish Kumar, and moderator Dr. Dilip Kumar sir.
May I request Dr. Sunandan Sikdar to be there on stage, and Dr. Srinivasa will go and take this tier session forward. So before we go step by step, let's have a discussion on echo, how T should be done before we go for a tier procedure, and that is an essential part. Subrasekar, Dr. Pranavesh Subrasekar, you can come. Arindam.
So good afternoon, and thank you, Dr. Dilip, for kindly asking me to talk, which is very close to my heart, because structural heart intervention is a team effort where multiple people contribute and everybody should understand the procedure. So I'll just put some thought. If we see the T guidance for this mitral clip procedure, it has multiple steps starting from baseline evaluation to puncture to taking the guide catheter to then placing device, and every point the imaging comes to cornerstone. So it's not moving. It was playing there, why not playing here? Movie is not playing. Please check. It's not playing. This is an important component because this discussion of mitral regurgitation should be clinico-imagical, where the clinical cardiologist should understand the symptom. It should be severe MR clinically. There should be a large heart.
Ideally, there should be a mid-diastolic murmur which indicate there is significant MR. Heart failure admission, this is a real our case. The patient was nearly 80 year, multiple admission with pleural effusion, heart failure and getting treated. In echocardiogram, the classic markers are cardiomegaly, dilated left heart chambers, large MR jet with a dense Doppler, large regurgitation area and volume, and importantly, pulmonary venous systolic flow reversal, because the corruption of the data in the echo in pulse Doppler is less than color Doppler. So pulse Doppler is highly reliable. In X-ray, we always see the venous congestion and cardiomegaly. So always the T is important in confirming all these things. This is the main image which should be kept in mind for the operator as a team, that how the mitral valve behaves. In anterolateral is a superior, posteromedial commissure is inferior, and T is a dynamic understanding. Always we should keep again the age-old Carpentier classification, that the normal leaflet motion is suitable, but the best one is excessive leaflet motion, what we see in the mitral valve prolapse in the A2, P2 region. The restricted motion of the leaflets in the systole and diastole, they are not suitable. In restricted systole only motion in type 3B, still it can be tried. So anatomy, the person who is analyzing these patients should have an understanding which valve is ideal. So location wise, A2, P2 physiology more than 4 centimeter square, valve area, posterior leaflet length more than 10 millimeter, because it will be easy to grasp, and there should not be any calcification. The gap between the flail segment should be less than 10, and flail width will be less than 15, like, and leaflet mobility should be ideally normal. The classic multiplanar view, we try to see all the leaflets with Jones leaflets, all scallops should be analyzed, length, the tenting, the gap, segment wise, and then mentally we develop a understanding. We should also see the LA appendage for any clot. So this is 0 degree, 45 degree, and we change this retroflexion and antiflexion to understand anteroposterior, the scallops. Pulmonary venous Doppler, there should be a systolic reversal. We can appreciate this systolic reversal very well. Only if it is eccentric MR, we may not get the jet from the pulmonary vein. So that is that only in spite of severe MR, we are not seeing any systolic reversal in this particular frame. Otherwise, we are seeing systolic reversal everywhere. So after getting an idea, then we do the 3D and 3D T along with color Doppler. We are seeing there is A2. So this is that anatomical location. Always we keep in mind aorta in anteriorly, the mitral valve posteriorly. So here A2 segment is prolapsing, and that's what we have understood in doing our TE. So Dr. Dilip has already mentioned the puncture, TE guided, posterior-superior, biplane, and it is echo as well as getting this image in the fluoroscopy, a good puncture. Now electrocautery wise, it's very safe and very easy for an expert operator. So after that, the whole procedure shifts focus to the transesophageal, and with aided guidance of fluoroscopy, we can appreciate the system has gone in 2D and 3D, and fluoro is always supporting our location inside. We are taking these 3 steps, taking the device in, opening, grasping, having a good grasp. This all goes simultaneously in 2 view, and we can appreciate here the device is open, trying to catch apposition, holding, and we are trying to see the leaflet. There is good grasp, then closer, and then we see there is we have created 2 orifice. There is not much of MR. So this is that assessment list checkpoint. there should not be significant residual MR. There will be some MS, but the gradient should be ideally less than 3 to 4, not more than 5. The pulmonary venous Doppler again comes handy. There should not be significant pulmonary venous reversal. The leaflet position insertion should be optimum. There should not be effusion and very rarely LVOT obstruction, which is less common though. So every step should be confirmed very diligently, because operator as a team trying to work on this procedure. So finally the release of the clip, we can appreciate that very nicely the MR is mild, 2 holes which are very nicely taking flow inside. This is a less common. We should always check also for the AHD what we created. Usually that is small and hemodynamically insignificant. So final checking, we can see the clip is very nicely in place, mild MR. And transthoracic always gives another perspective to the story. So it is an holistic type of imaging. We should not only fixate it at TE, because transthoracic gives another dimension to it. So the key to success, 4 step, 4 confirm clinically severe MR, then analyzing the whole valve. The whole procedure goes through these steps, which is TE and fluoro combined, and then checking whether we have done right things, so right patient, right anatomy, and right guidance. So that's what I want to tell from core of my heart. He who knows what to be done, when to be done, and how is to be done guides the hands that act. And I don't feel I am a good guide, because I have still not learned the procedure. Thank you.
Dr. Singhi, so you have been assisting with this TR for some time. So how do you feel about ischemic versus non-ischemic MR? Is there any difference in your imaging?
I think I have supported, we had done 2 cases, at least I was there, and both the cases had more of prolapse component with LV dysfunction. Yes.
Post CABG cases, how do you think?
That's what I am telling, I am learning.
Yeah, okay.
So as I learn, I can possibly tell better. Dr. Dilip can put some more points.
So we will go with the presentation. Can we have Dr. Biswajit Majumdar and Dr. Kajal Ganguly sir on stage, please? So the one or two questions from you. What's the role of MPR reconstruction of your echo? I think that is very important. MPR views when you just like the flow and the 3D and the MPR images, especially tricuspid valve imaging, we require a lot of these images.
Tricuspid valve is not very good in construction because of its anatomy. Mitral valve is very easy to reconstruct 3-dimensionally, and the newer Philips machine, which we don't have, gives that light view very nicely for mitral. Tricuspid is more, we do get image, but more 2D orientation understanding. When I compare the mitral versus tricuspid, at least I see both 2D and 3D combination to understand where is the pathology in compared to mitral. Mitral is relatively easy. That's why possibly it has taken more. And tricuspid, 3 valves, 3 location attachment, 3 leaflets, and they are often not like a clear-cut leaflets. Mitral valve has a distinct 2 leaflet. Tricuspids are in continuous curtain. So they are not similar. Possibly better imaging will help us to understand the tricuspid better. In 3-dimensionally I am talking about. Yes, for valve I have not seen that to get promoted in the literature also. It is good for other intervention, but for valves I think transesophageal only coming to the limelight. It requires better footprint to catch more. The intracardiac echo do not have that much of footprint to get whole of the valve. Correct.
One addition, sir. Since I do a couple of tricuspid interventions, For a tricuspid to get the 10-fast view, you need to do a transgastric. No other views will be able to give you the 10-fast view of a tricuspid. So I think if at all, if you want to do tricuspid intervention program, you should start doing more transgastric views and align it. With the valves like Evoke coming in and PTVR coming in, I think time to up our
But the question was eyes versus the T eyes. I don't think will give that much of
Ice
view.
is very comfortable. You don't require the patients to be, even ventilated. It can go through the other groin. You can see the go inside. You can puncture where you want. You can maneuver your catheter for, especially for tricuspid interventions. It's really, really good.
It will show the valve where you are putting that 2D dimension. It will say, but showing the valve leaflet.
It shows.
No. It will show. Definitely, it will show. We used to do eyes guided AHD regularly in Chennai. I am telling the valve leaflets, total thing seeing as we see in 3D in transesophageal, we will not be seeing that good in the eyes. Eyes will give us a good guide.
It's the same reconstruction.
I think Dr. Srinivas was mentioning, if you really want to do tricuspid, the transgastric view is the money view. Without proper transgastric view, you cannot do these anterior leaflet, septal leaflet, where to go, where to catch. But other things about eyes, ALA closer, the TAVR, the mitre clip, now 4D eyes is also available. Those can be done, but for tricuspid, I think again the transgastric view is impossible with the eyes.
So one of our speaker dropped off, so I had to chip in again for this tier, and basically we'll go with a step by step and some evidence where we need to mitral tier, and we will also have a panel discussion. All those who are here, we'll have discussion on the evidence which have been generated on tier and the tricuspid tier. So tricuspid tier is also coming big way, and tricuspid valve is no more a forgotten valve. So the results with TRISCEND 2 trial, I think it's very encouraging. It's very encouraging with almost 96% reduction of leaks. Only thing is you require more of pacemakers and bleeding complication, but the results of valves are really, really good. In long term, that can be more better. So we'll go with tier in functional MR. And you can see here a dilated LV and a leak which is happening, patient is decompensating, and this is a secondary or functional MR, and these are the mostly the cases of transcatheter edge to edge repair which are being done. So when we look at the prognostic correlation of secondary MR, so these secondary MR these are an independent predictor of long-term mortality. So you can't say that no, it's a MR which is there because of dilatation. It is eventual, and it should happen. Someone who doesn't have MR with similar LV, similar dilatation, they fare well and they do well than those who have significant MR, and that is why there is a lot of kind of targets where it has been used so far. So right from annuloplasty to edge repair to kind of valves which are there, TMVR, native TMVR, and they are still in pipeline, but tier therapy has really come a long way, and basically it exploits the idea of FHRS stitch, and the FHRS technique. It started in 1990s. It's edge-to-edge technique was first described in by Dr. FHRS. 1,500 cases reported in the literature, and it was especially it was there reported in degenerative MR and also some functional MR where T3 the coaptation was a problem. it creates a tissue bridge. Then came data from Everest. It showed that even in degenerative MR, we can. It started with degenerative MR with TR that it really works, and the Everest one roll-in phase of and plus roll-in phase of Everest 2, it showed that the leak reduction can be achieved with more than 85 to 90%, and this is the survival at 30 months, 96% survival, freedom from death, surgery, and MR2 plus was 63% at 36 months. So on this data, next evidences were built, and it also showed reversal of remodeling. these leaks have got two kind of presentation. One is what we call proportionate MR, and one is called disproportionate MR. So proportionate MR, there is not much role of edge to edge repair, because the kind of annular dilatation and LV dilatation which we see, we expect some MR to happen. And here the ERO is not very high. LA is hugely dilated, so as the LV, and this is a kind of MR which is not significantly more and which is not leading independently to the problem. There is a disproportionate MR where ERO is high, MR is happening. You can see the and the LV is not that much dilated, and there is a kind of a valve which is having some tenting and prolapsing, and these are proportionate MR, and here disproportionate MR, and here if we use TR, it can be beneficial. Also, there is a concept for atrial functional MR or ventricular functional MR. So same way, if atrial functional MR, atria is hugely dilated and ERO is not that much. So here again, like atrial fibrillation, if we do it TR procedure, it's not going to be very rewarding. But someone who has got a MR jet with a valve which is not coapting well, LV is dilated, but LA is not that very high dilated. It is not a substrate of atrial fibrillation, and then you get a good benefit with ventricular MR and secondary MR, disproportionate MR, you get better. So we have COAPT versus MITRA FR, and we know the difference. COAPT gave us mortality benefit. COAPT gave us a NNT of 9, something like that. So it was a hugely successful kind of study. Based on that, TR got recommendations. But what was the problem? Problem was MITRA FR utilized the European recommendations for severity of MR, and COAPT adopted US recommendations for severity of MR, and there the EROA was more than 30 as compared to more than 20 in MITRA FR. So these patients had a severe leak, and these patients were monitored well. The LV end diastolic volume mean was 101, here it was 135. It was kind of all in MITRA FR, these were last patients, kind of proportionate MR patients, and in COAPT it was something like disproportionate MR patients. LV not that dilated, ERO is very high, so MR is contributing to the problem, and then the results were really good. So this you can see here, COAPT had a disproportionate MR, MITRA FR had a proportionate MR. So we needed something which can be in between and which can be deciding that which way we should go. And there came the RESHAPE HF2 trial, and the primary 2-year clinical endpoints showed reduction in heart failure hospitalization and clinical benefits on KCCQ grade as well. And RESHAPE HF2, if we compare with COAPT, MITRA FR, RESHAPE HF2, we can see that RESHAPE HF2 was in middle of COAPT and MITRA FR, and they also showed benefit. And when it comes to proportionate disproportionate MR, RESHAPE HF was, even as patients who were sicker, grade 2 NYHA class 2 to class 4, and it was also falling something like MITRA FR, but it did show benefit. And from there the idea came, no, the TR therapy is really making the difference, and it caused more and more recommendations. So COAPT ineligible patients were not there, we should not be using, but COAPT eligible patients like ventricular FMR, LV ejection between 20 to 50%, ERO of more than 30 or 40, and severe MR, moderate to severe MR, we can go with TR therapy. And we have also evidence as a bridge to transplant, we can use that. So these are the recommendations, and you can appreciate the primary MR. If the patient has a ejection LV end systolic diameter of more than 40, ejection fraction less than 60, and at least 3 of them, LA diameter more than 55, LAVI more than 60, atrial fibrillation, pulmonary artery pressure high, secondary TR more than more than moderate, then we can go ahead with TR procedure. And if the patient has a functional MR, then also it is now a class 2A indication. So it's the class 1 indication if the patient has a COAPT like patients, and this is ventricular functional MR. So you can see here, this is class 1 recommendation. TR is now class 1 recommendation in those patients who fall in a COAPT criteria. And in degenerative MR, it is a class 2A indication who has got surgical high risk. So this is the anatomical suitability for leaflet malcoaptation, for kind of catching the leaflets, and so there should be sufficient length. So we have to measure the leaflet length of posterior mitral leaflet. If it is more than 10 millimeter, it's good. And also we see the gap. If the gap is more than less than 10, then chances of grasping is better and chances of results are better. If the flail width and flail gap is more than 10-15, then chances of grasping the leaflets and reducing the MR is very less. And there is also one concept, coaptation length, which is more than 2 millimeter. If it is less than 2 millimeter, it's good. And mitral area has to be a little larger. If you have a mitral area is less than 4, then it's a problem for us. It may not go and navigate into the LA to LV. So this was a case which I think Anil also showed, Dr. Anil showed, and this patient had a severe MR, and you can see the NFAS view, and basically it's a T-guided puncture. You can see the posterior. It's just a lower border of the fossa and posteriorly. So we have to go posteriorly, lower border of the fossa, and it has to be electrical electrocautery used, because you can't be sure with these needles. If you puncture the posterior structure or roof, it can be a problem. So just a nick with electrocautery, you get into LA, and then the torque which you had given to make it more posterior, it has to be relieved fast, because if you with that same torque you go in, you will go hit the posterior wall or roof. So once your electrocautery goes in, then you untorque, you keep it now become normal, and then you advance a wire or a little bit of sheath here, and then you can take the wire inside. Your sheath goes in. If it is SL1 sheath, it goes in, and then change the catheter from by taking the stiff wire into the pulmonary vein, and then you take the MyClip guide catheter, and then the clip goes in, clip delivery system. There is a call of sandwiching or straddling. We call sandwiching in MyClip, and sandwiching in MitraClip. What we do is we just place this marker of MyClip in between the two radiopaque markers of the guiding catheter. So we are clear that how much clip component is out, and then we can start bending and try to go. So what we call give M and anterior posterior torque. And after that, everything happens with echocardiography guidance. You avoid the the LA lateral structures, and then you negotiate slowly to the mitral valve. You see the orientation in two projections, outflow and bicommissural view. You can see here, these are the two views. This is the bicommissural view, and this is the LV OT view, outflow view. And it's not a very very difficult thing to understand. You see, this is apex. My arrow is seen, and you can see this is the apex. So your direction, this is medially. This is not correct. So you have to dive like this. You have to dive just to apex. So there we see we are giving medial, lateral, anteroposterior. We see the anteroposterior orientation in this view. We see the medial lateral orientation in this view. So we are very clear which way we are going in. We have to target the apex. So if you are targeting like this, you are not going right. You have to go like this. If you are targeting here, going like this, it is not clear. It has to go like this. So what we call diving in, you have to dive in the middle. So it should not be medial, lateral, anteroposterior. Anteroposterior you see in outflow tract, outflow view. Medial, lateral we see in the bicommissural view. So once we are confirmed that our direction is correct, you see towards apex, you see towards apex. These are X-plane. The machine will give you, you make one projection, other projection machine will give you. You don't have to put two projections one by one. So by side you will see both. And you can see give the turn to anteroposterior and medial lateral. And then we go inside, then we see the NFAS view. NFAS view shows that the clip is like this, 12 to 6 position, because the valve is moving like this, two leaflets. If you are like this, only you can grasp. If you are like this, you can't grasp. So we see the orientation here as 12 to 6. 12 to 6. If you don't see 12 to 6, it means you are not going to catch the leaflets. So if the leaflet has to be caught in middle, it has to be perpendicular to the leaflet plane. And there you see here 12 to 6 orientation. Once go you in, you catch the leaflet, and then you see that MR is coming down, you deliver. So this is another case which we did, which required 2 clips. And similar procedure, we go inside, we do maneuvers to dive inside. You can see 12-6, you can see the 12-6 orientation. If this clip is like this, 3D, if it is like this or like this, we can't accept that. And again, you can see the diving, it is now looks good. So we go in, we dive inside, we grasp the leaflets, you see the MR which come down, and then another clip we had to give because the MR was still there, and then 2 clips, and the patient, this was the first MR, and this is the last result which we got. All the patients are doing well. So this is how we do step-by-step trans-catheter S2H repair of mitral, and we can have discussion on that. Thank you so much. Sir, the size, the clips comes in 2-3 dimensions only. One is short and long, and one is medium and long. So you have to choose them. If the jet is very broad, you can choose the kind of long and the broader one. And if your leak is sleek coming from one place only, but it is a large, then you can take a shorter device. Sir, this is all T guidance, sir. So we are pretty sure where we are going, and these are small tips and tricks that you have to untorque, then you go electrocautery, then you can take a wire, then you can advance little bit, and you can see in 3D and other images, you can see exactly where is the, it is not touching the lateral wall or posterior wall or the roof.
Few more tips I'll like to add it. So, for example, we saw that he's doing a TE puncture. So when we are doing a TE puncture, we select such a point which is trying to be coaxial with the mitral valve, correct? So what we need is we need a depth or a height of around 4.5 centimeter. We go to a height of 4.5 centimeter. How do you gain the height? Actually, heart is not straight like it is like an angle. More posterior you go, you get mitral valve is like horizontal. So from the mitral valve away posteriorly by 4.5. For a disproportionate MR like this, atria will be 6 centimeter and above. So 4.55 centimeter will not take you out of this. Only thing is if the septum is very floppy, it will be denting, and you can go out. Otherwise, generally it does not happen. You'll be able to puncture it. So puncture should be with some counterclockwise torque so that it just punches. The moment it punches, stop there, put in a sheath inside, take that needle out and put another wire, Ampert's wire or anything into the left upper pulmonary vein. Then you're done with that, then you can untorque, then take the sheath. Simple phenomena is now we are going to track our entire device towards the LUPV. LUPV is slightly posterior, mitral valve is slightly anteromedial. So this is anatomy. So it's going like this. We have to bring it like this. So you start rotating our M knob. So it will start medially coming in. So as it comes medially, it is actually going posterior. So you put an anterior knob, it moves towards the anterior. From LUPV and LA appendage, you start coming down to the middle of the mitral. By that time, you would be 90 degrees and you'll be across the mitral. Go on an NFAS, rotate your knob in such a way that your open arm are exactly perpendicular to the flyer leaflets, and that you confirm in both bicommissural view and LVOT view. So depending on where exactly is the prolapse, either it can be in a A2P2 segment or A3P3 or A1P1. So depending on that, you need to do the movement. Sometimes the catheter moves a lot, basically because patient will be deeply breathing. So at that time, you tell your anesthetist to reduce the tidal volume. Sometimes we ask the patient, them to give a slightly more deeper breath and hold. So deeper breath will actually inflate the chest. It will pull the catheter toward the medial side. Shallow inflation, it will go to the outside. General practice, what I do is I ask them to keep the tidal volume around 300 to 400 ml for the 10 minutes time so that my device is very, very stable. Then dive in. Once you dive in, identify this thing, then identify the leaflet grasper, which is the side. Either you can do an independent grasper. I don't know my clip as an independent grasper or not. I use more of a miter clip, which has got an independent grasp. I check for the grasper, then catch the thing, then leave the tension. Because most of the time what happens is when you're pulling, obviously MR looks like normal, it is gone. But when you release the device, you see that there's a leak by the side of the device. That is because you are keeping the tension on the leaflet, and the moment you release, it actually cinches off. That's why that leak comes. So if you had released the tension even before releasing the device, you would have known like this is not a perfect placement. So Dr. Dilip was trying to show you that 12.6 or 11.5. In that, if you see it was 11.5, it need not be always at 12.6. It is about the jet. Wherever is the broadest jet, that you need to identify. And that identification and relief of the MR should be based on when the device is not having any tension. If you ensure this safe practices, then things will be much. So simple, go up. So then go lateral most wall, then pull the device back, M knob. Once you are there, align it either by breathing efforts or by adjusting the fine knobs, P or manually rotate it. Then dip down, then release, come. It's just that once you start doing some devices, it's quite easy. Actually, it's much easier than any other structural intervention. It's just that knobology is more complex initially. That's
Thank you. I think, yeah. So it's a wonderful, session on TR, and I think we got some clarity. So we will move on to the presentations, case presentations, and these are basically the most important stuffs. From presentations, we know like last case of Dr. Anmol and many other cases. So once you see nightmare cases or case vignities, we learn so much. So we'll have panel to discuss, and we have presenters. And then we have a 6 o'clock, we have a small presentation on expert position paper, which has come. So 10-15 minutes discussion. Dr. Jabir will be joining us online, and we'll have a 8 to 10 minutes discussion on new position paper. And from India, we had some 6-7 authors, and we were the part of that public position paper, and we'll discuss that for 8 to 10 minutes, and we'll start our case presentations after that. Thank you so much.
Okay, so we'll be coming back with the case presentation after 5 minutes of tea break, and the first case is by Dr. Arindam Pandey.
So we will have now case presentations, and we have 7 case presentations lined up, and we have a 10 minutes discussion on expert position paper of MRA. So Dr. Jabir will be ready in 10 minutes, and 10 minutes we will discuss a case. Dr. Rana will present, and we can invite the chairperson panel. Dr. Arindo, please come, and Subrato, Dr. Subrato, please come on stage. Saurabh, kindly come. Dulab. Prakashda. In case presentations, you can give more feedback and suggestions. Rana, please.
So good afternoon, and with due permission from chairperson and other panelists, I'm going to present this case. So this case is about a 80 years female and she was hypertensive, hypothyroidism, and she presented to us with shortness of breath for last 6 to 8 months, along with chest and upper back pain for last 2 to 3 months. Her ECG was sinus rhythm, and along with there was LVH and LVSP, particularly in the lateral leads, and her cardiac enzymes were negative, and other routine investigations was not that remarkable. But her echo showed the severe aortic regurgitation. Ejection fraction was in the tune of 55%, and definitely there was a dilated left ventricle, and along with that there was dilated ascending aorta. So with scenario and very elderly female with kind of echo finding of severe aortic regurgitation with some ascending aorta problem, with ejection fraction also subnormal range. And you see also this is the post-operative echo, what you can see is chest X-ray. We assume some of the mass or whatever it is in the left side. And this is that's when after, we also did the CT of this patient, and you see here, there is a aneurysm in the thoracic aorta. So, there was also another aneurysm in the ascending aorta also, but arch of aorta was fine. So one aneurysm in the ascending aorta, another aneurysm in the thoracic aorta, but that aneurysm was distal to there was 10 millimeter margin from the left subclavian artery, and the end point was also above the diaphragmatic hiatus. Her angio was normal. So since cardiac surgeon was also involved, actually patient was admitted under the CTVS, and so we have a combined decision that let us go for the aortic valve replacement first, along with the aortic dilatation repair, and then we'll plan for endovascular repair of thoracic aorta aneurysm. Also, there may be some kind of other views that we can have aortic valve replacement and other kind of graft in the. So, but this was done is the AVR and aortic dilation repair, and after that patient was referred to us for the repair of the thoracic aorta aneurysm. So we, as a routine, whatever we do is for the large bore access. So we take the access from both left femoral artery and the right femoral artery. Femoral artery was fine. There was little tortuosity on the right side. Otherwise, the diameter was fine. And so, after putting the 2 Pro style on the right femoral axis, we took the standard wire and everything was done. So we can see here there was aneurysm on the thoracic aorta, and thus endovascular graft was positioned, and the first endovascular graft was deployed. After putting this graft, you see there is another aneurysm below that, and we also covered that aneurysm with another graft. But after that, everything was fine. There was no lateral site hematoma. Everything was fine. We just wanted to close but you see after this final shot, to see the femoral artery, you can see here that the right side there is definitely diminished flow, and that's why definitely it is not, you see, although there is no hematoma from the outside, BP is fine, but definitely there is almost no flow on the right side of the femoral artery. So since there is no flow, so what we have said, either it is a case of dissection or it is local thrombosis. So what we did the first is that since we have a wire from the left side, so we cross that wire through it on the right side, and we first tried to dilate it through the balloon. And even after balloon dilatation, you see there is no so much improvement. It's still diminished flow. So now we decided to put one stent here. So since there was no such leaking or that, so we decided to put a self-expandable bare metal stand there, and it was the size of around 8 millimeter size. So we put the stand here, but you see, after putting the stent, again there is a leakage in the lower stented part. But yes, profunda femoris is patent. So again, what we did is that we again took a balloon and we dilated it, prolonged balloon dilation. And after that, we took again another shot, and you see there is no such, you see, any leakage. Branch profunda femoris is also patent, and there is no such, you see, other issue. And so with this, we did this case. Thank you.
So, what could be the reason of no flow? Mike.
Yeah, it was ESG guided. It is above the profunda femoris, below the inferior peak gastric artery. And there was no such calcification.
Yeah, it was post-dilated. Stent was post-dilated, no?
Yeah,
Ultimately.
stent was post-dilated.
Why there was no flow?
No, you see, there's maybe many reasons, but I think what we thought that probably since you are doing the IVR, it's a 20 French teeth size, so probably it is a sheath-induced dissection. Most likely, it may be wire-induced, it may be
Dissection,
induced.
most likely dissection
Yeah.
and perforation both. You had a perforation, no? Leaking? No.
Yeah, it was leaking. Yeah, it was leaking also.
So it was
which was
basically-
visible. Which was visible when put the stent, then it was visible.
Yeah, so either a thrombus or a dissection or a closer device induced no flow can be seen with large bore access. Any other comments? Yeah, it was not only perforation, it was perforation plus dissection. So once the flow was established, then only he can see the perforation. The initial thought was it was a dissection, so balloon dilatations. The balloon dilatations would have worked. There is no need for the stent. Bond C dilated. There is establishment of the flow. Now we can see the perforation.
So the initial puncture was USG guided. You can see the micropuncture, see and all. So what could have caused the dissection or perforation?
The large sheath.
So
sheath induced.
it's a 22 French device which goes in. The 22 French device can scrape. There is a plaque, and then it can just cause some dissection. The first idea after this no flow was there any thrombus which has formed, or there is a dissection? These are only two reasons, and there was no kinking in the vessel. So there was two
Exactly.
prostyle, but there was no kinking. So, and it was in the iliac, externally iliac. So we went with balloon to see if there is a thrombus or not. We maintained the ACT. We did the ballooning. Then we saw that there is some trickle of blood, but it is not thrombus, and it was still looking like dissection. Then we put a bare metal stent, not a cover stent, because if it's a dissection, it just has to seal the flap. So once the flow came, then the prostyle
Leaking,
which were there, normally you see some bleeding, and it can be tackled manually also if it is not very spotty, or you can give an angioseal device, because it's 22 French. It's not in tower we take 12 French, 14 French. It's a 22 French. So sometimes it requires 2 angioseal, so 2 prostyle and 1 angioseal. So here we just did a prolonged balloon dilatation, and that seal was totally, that leak was settled. So, yeah.
Nice case, sir.
So just wanted to ask that in the morning we had one talk that the bleed is better appreciated in CT scan. So suppose if in such case happens where you have balloon tamponade up, is there a routine protocol where you will do CT for see for any bleed is there still residual?
Yeah, if the patient is symptomatic, then definitely do. The patient is rock steady after that, the hemodynamics normal, puncture site normal, and there is no hemoglobin drop. Why to unnecessarily go for a CT? So suppose the patient is not very stable, you feel that still ooze is going on somewhere, then you need to go for CT and you to find out what is the reason.
Subhrata?
Dr. Saurabh.
Sarup.
Yeah.
Sarup.
I just want to know what is the what's the ACT at that time after the procedure? What was the ACT you maintained during the entire? Yeah, because since you have taken a 22 French sheath had gone in, So definitely the chances of thrombus formation is very high. So what in such cases?
See, the idea
when
is to routinely, whenever you're doing the date before closure, just give the protamine and just
No. So I just want to know that what should be the ACT levels while after the procedure gets over, when we are able to secure the bleeders, if there's some bleeding, we can give protamine. But apart from that, during the procedure, when large sheets are in situ, what should be the ACT levels? Because it has to be a mandate. There has to be a mandate that.
See, for any procedure, it should be at least for above 200. If you don't want to add something to prevent
So
that
we will
coagulation.
try to keep it between 250 to 300 during any
but
procedure.
at least above 200, admits it as minimum. I
Yes.
think you should keep it.
Yes. So I think that is also very important because every 30 or 40 minutes, that is a guidelines which says that when you are going for structural procedures with a wide bore axis, 22 French you are taking. So every 40 minutes you should do an ACT and we should try to keep the ACT between 250 to 300.
300, yeah.
And that should be an ideal. That makes your life much easier. No thrombus formation and unnecessary complications we can avoid. And yes, as Sir said, that when you are accessing a wide bore or closure is often difficult. Well, we usually go for Manta or a per closure or 2 per closures are required. So it's a bigger sheath which compared to what we do use in TAVI.
Right. Thank you.
So to all cardiologists, I just wanted to ask one thing that when you are doing per close device, is it mandatory the practice that some say don't give protamine, some say give protamine. So what's the practice in consensus if we can come around?
So if there is a leak after the pro style, sir, you were still telling something, Dr. Prakash, you were telling
Protamine.
Protamine, should it be routinely given when we are closing the means like we have done protamine heparin reversal should be done or should not?
I think 50% correction is not harmful most of the time. It should not be full corrections. Full correction is dangerous because if you put a stent, it can go into thrombotic state immediately thereafter. I would say you can correct 50%, then you can go for this device closure or the stent graft. But surprisingly, you did not use
it
stent
is
graft
always
here.
not mandatory that you
It's
have
not
to
mandatory.
give. Yeah.
You can work on the heparin, but don't give an extra heparin.
Yeah.
Yes.
But there's a kind of a practice which is not homogeneous, it's heterogeneous. So we, after 7 French angioplasty, even left main and all, we don't hesitate in giving protamine, even if there is a slightest of bleeding more, which is not anticipated. So that is little not harmful, I tell you. So you can definitely 50%, as Prakashda says, you can definitely go, and you can go even further. That doesn't create much of problem, provided your sheath is out.
And sir, morning, Dr. Sunavne had suggested that we keep this stiff wire in C2 before taking everything out. Before
Yes,
we should
stiff
check it
wire
out.
is very important. When you do manta, the depth has to be located on the same wire. So a normal wire you take, a JR catheter you take, a stiff wire you take, like Lenderquist, because we are working on Lenderquist in endovascular procedure. And then on Lenderquist wire, you take the manta, the sheath, introducer sheath, depth locator, sorry. And then you see the depth, how much depth is there, and you keep it, the depth in your idea. And once you are closing in the last, then only wire is there, and your manta is going on, the same depth, on the same wire you have to go. And it's a good idea to do the last final job on stiff wires, because if you have to reintroduce a large bore dilator with sheath, these normal wires can give way and there can be some trauma to the vessel wall. Yeah. So
And
stiff wires are very good.
And sir, is there a routine practice or only for selected cases on ipsilateral side on SFA we will keep the V18 wire?
So V18 wire, I think this is getting out of fashion slowly and slowly. A small puncture will do, because we have encountered one problem. V18 wire was caught in our pro style switcher.
Yes, sir.
So it's not a good. I think people are doing away with this practice.
Okay.
So V18 wire had one experience. We were doing one case. So there was a vascular closure. Means there was almost it was occluded the right side. So on the contralateral side, we went with a V18 wire. We were able to deliver a new sheath. We were able to take the cover stent. So that really makes your life a bit easier, faster, easier.
But yeah, so you can manage without that.
We had one experience for V18 wire. So V18 wire can be taken onto from the contralateral side if we are expecting a complication. V18 wire.
Thank you. Thank you. We can go to the next.
One question, sir. Like
Few of the cases I have faced, once in during my residency, once my practice also. Like once some perforation happens in the iliacs, takes some time to balloon occlude, then you arrange a cover stand, you covered it. Some amount of bleed has happened inside. After that, patient recovers, but many develop a sort of sepsis sort of situation afterwards. Have you?
No, I think sepsis is not happening. Maybe bleeding is happening. That's what Varun was telling, and Dr. Devduta Bhattacharya also case showed. Sometimes small twigs still bleeding. So you go for a CT in these cases. So sepsis will take 24, 48 hours to set in. But if the patient is going downhill, you must go for a CT.
So
I
actually,
think
sir,
go
regarding
to the next case. Yeah, because last comment. Yeah.
yeah, so
TAVI or whatever large bore procedure we are doing, I think we are concentrating on how we are going to do this procedure. But at the same time, we need to have a clear strategy of bailout even before we get in. So in our head, okay, this is the step for the TAVI procedure I'm going to do. But if something goes wrong, what are the equipments I need? That has to be clearly in plan and probably written down so that the entire team is aware that if something goes wrong, what all the equipments are ready. As Dilip says on the other day, in the morning, that yeah, you said a cover stand is there, but what is the size? You don't know. So you have to make sure that's exactly all the equipments are there. If something goes wrong, you just go by the bailout strategy. So that is a very routine. That go for the TAVI procedure and at the same time write it down your bailout strategy.
Dada, we'll start. We'll do the case presentations after a short 8 to 10 minutes talk from Dr. Jabir and on expert position paper of MRAs. So that was published and we were part of that. 8 minutes, 10 minutes. So may I request Dr. Arindam Pandey, Dr. Priyam to come on the stage, please. And better to stay back here, sir. We'll continue with the case presentation. Priyam, please come. Manish, please come. Dr. Manish Kumar.
Boss. Think, the latest technology about the vascular access, we have last barrier almost crossed. Then how do you go integrate from the same puncture? You go retrograde. How do you go integrate from the same puncture? So there is a special paper in JAC. This time there is a special device, little costlier one, that can access integrately after you finish the retrograde. Suppose you have complications on the same. Javed is there. Anyway, Javed.
Yeah.
So
Hey, Prakash bhai, kaisa hai aap?
Badhiya hai.
Welcome, sir.
Thank you. So I think, I don't know whether it's correct to interfere in a very high-end interventional discussions going on, especially regarding the TAVR, its complications, large bore vasculature. But I'll complete it within 10 minutes time,
No, sir,
Dr.
I
Asra.
think it's a well-planned event for us. This is a paper which we want to the awareness level has to go a little big, and that's what we have kept this for 8 to 10 minutes about this paper which has come up. It was so well written, and it gives a lot of new perspective. Dr. Jabir will give us insights on this.
Jabir and Dilip Kumar's name is also there.
We are all there.
Yeah, Dilip is a part of it. Dr. Dilip, thank you so much for this opportunity. I'll quickly walk through the most important things of this thing. So it's good evening, and I would have loved to be. I would love to be a part of your meeting. I would have come, but it's a long distance journey. Next time, I'll definitely make it. I'll physically come, Dr. Dilip.
Thank you, sir. Thank you. So we are. Yes.
MR overactivation is a hallmark of heart failure and reduced ejection fraction. This overactivation of mineralocorticoid receptors, which are found in the myocardium, in the vascular cells, in the endothelium, in the renal cells, many part of the body, these MR receptors are present, and cardiomyocytes is an important area where these receptors concentrate. So what it does is it induces inflammation, fibrosis, hypertrophy, and apoptosis, especially in the heart, vasculature, and kidney. And this leads to problems which produces fibrosis of the heart, remodeling of the heart, progression of the heart failure. Along with it has a crosstalk with the renal tubular fibrosis and may be a pathogenesis or may act as a pathobiology behind the cardiac and the kidney crosstalk. So it may play a role in the renal dysfunction also. So MR activation, it binds to the mineralocorticoid receptors in the cardiac cells. It promotes inflammation, oxidative stress, and collagen production. Ultimately, it leads to fibrosis. That means almost a permanent loss of the function of that myocardium along with increased arrhythmogenicity. And it increases the pro-inflammatory cytokines, particularly interleukin 6, which promotes fibrosis. And oxidative stress by increasing the NADPH oxidase, elevating oxidative stress and driving fibrotic changes. And the galactin pathway, which is a key protein, that is a galactin 3 in fibrosis. So blocking the galactin 3 or MR can prevent or reverse fibrosis. So if we block the MR receptor overactivation in heart failure, it reduces the fibrosis, or it may prevent the development of fibrosis and progression of fibrosis. So helps in reverse remodeling, prevention of sudden cardiac death, arrhythmic death. This has been demonstrated in many of the studies. So recommendation on preventing disease progression in heart failure and reduced ejection fraction. We should consider early targeted therapeutic interventions to prevent the progression of cardiac fibrosis in patients with heart failure and reduced ejection fraction, of which one of the most important therapeutic agent is the mineralocorticoid receptor antagonist. So in this position paper, we have considered only two: the steroidal mineralocorticoid receptor antagonist, spironolactone and eplerenone. The major data is from the rails in the spironolactone, 30% reduction in all-cause mortality, 35% reduction in heart failure hospitalization. FSCAI post-MI heart failure, 15% reduction in all-cause mortality, 13% reduction in cardiovascular death. Emphasis heart failure, 37% reduction in the composite endpoint of death and heart failure hospitalization, and 24% reduction in the all-cause mortality. The major problem that we face is hyperkalemia. But you look at the hyperkalemia with a 25 milligram of a dose of spironolactone, that is the major dose achieved in the RAILS trial. Large majority could achieve only that dose. 13% potassium more than 5.5, 20% if it is 50 milligram dosage, and 75 milligram dosage in very few, it was 24%. And only 5.5% with the potassium more than 6.6 millimoles per liter in the eplerenone trials, and more than 6.6 millimoles per liter potassium is an indication to stop. So when to start? That is as simple. It should be started at the earliest after diagnosis of heart failure, in the hospital, just before discharge, or OPD based diagnosed at the time of diagnosis if possible. Early initiation during hospitalization or soon after the diagnosis provides greater benefits than delayed use. And one of the trials of eplerenone, that is the EPTES trial, post-MI heart failure, they found that if you start this after 7 days after the diagnosis of heart failure in post-MI, there is no benefit in any of the endpoints. So start early, start at the first opportunity. It improves the survival, it reduces the hospitalization, and it helps in better adherence to therapy. So initiate MRAs early in eligible heart failure and reduced ejection fraction, preferably during hospitalization or within weeks of diagnosis. And if you delay it by more than 30 days, there is, the data says there is increased mortality, heart failure, hospitalization. So never delay it more than 30 days post-discharge. Recognize that early MRI use reduces all-cause mortality, CV mortality, sudden cardiac death. One of the studies showed 47% reduction in the relative risk reduction in sudden cardiac death and heart failure hospitalization. And do not withhold this drug unnecessarily for concerns about renal function or hyperkalemia without a clear contraindication. But if you look into the real world, there is a gross underprescription, there is a high drug discontinuation, there is a spelling mistake, high drug discontinuation rate. And the evolution HF has shown that when you look at the discontinuation rate of the different GDMT, the highest discontinuation rate at 1 year, 34% was for mineralocorticoid receptor antagonists. Dose adjustments based on EGFR. EGFR more than 50, spironolactone consider straight away 50 milligram, eplerenone 50 milligram once a day. EGFR 30 to 49, spironolactone start with 25 milligram every other day, or eplerenone 25 milligram once daily. And then depending upon the potassium levels, we may gradually increase. EGFR less than 30 now considered as a contraindication to therapy because of the limited safety data. But some of the patients, or I have now, we have adequate exposure with these drugs and experience with these drugs of more than a quarter of a century in heart failure and patients with reduced renal function by an excellent surveillance on potassium, and also by looking at the potassium excretion. Sometimes there are people with tubular disorders where the potassium excretion is more, their potassium is low despite the renal failure and heart failure. We may be able to start and continue, even escalate the drugs in selected population, but only under a close surveillance on the potassium level. Dose adjustment based on serum potassium, I think that is the most the excellent figure in this article. Spironolactone, if the potassium remains less than 4 millimoles per liter, increase straight away from 25 to 50, from every other day dosage to a 25 milligram daily. Eplerenone also from 25 to 50, and is on 50, you can increase up to 100 milligram per day. Potassium between 4 and 5.4, no dose adjustments. 5.5 to 5.9, be careful. The restriction of potassium containing food, or it should be a low potassium diet. Any other drugs which can conserve potassium, if it is not essential, should be stopped. And spironolactone from 25 milligram daily dosage should be reduced to alternate day. From 50 milligram, it should be reduced to 25 milligram. And eplerenone also same way, half the dose. More than 6 is a contraindication. We have to stop the drug. But now we have the sodium zirconium silicate available. If we cannot continue this drug without adding a potassium binder, whenever we reinitiate it, even at a lower dosage, if the potassium goes above 6, the only option is consider this drug along with use of sodium zirconium silicate, may be expensive. Dose optimization, the dose optimization is based on, or the monitoring parameters are eGFR, potassium. MRA therapy with eGFR more than 50, we have already discussed. The standard dose, if he is on 25 milligram, increase to 50 milligram straight, and same way for spironolactone as well as for eplerenone. Less than 30, avoid the therapy. Between eGFR 30 and 49, if the patient is on 50, you can reduce it to 25. If it is 25, you can make it alternate day. Less than 4 potassium, up titrate. 4 to 5.4, same dosage. More than 5.5 to 6, that is 5.9, reduce the dosage and a closer surveillance on potassium. More than 6, stop, and sometimes we may require potassium binding agents. The creatinine and potassium monitoring at what frequency? After starting at 2nd week, 4th week, 8th week, and 12th week. So for 3 months, first month 2 times, 2nd week, 4th week, then 1 month. That means at the 2nd month, then the 3rd month, and then every once in 3 months. Or in patients with renal dysfunction, for example, if the eGFR is between 30 and 49, we may have to consider more frequent potassium monitoring. Maintain or increase dosing whenever possible to improve the survival and reduce hospitalization. Thank you.
So wonderful. I think, yes, this paper re-emphasizes the role of MRAs because it reduces sudden cardiac death. It reduces the reverse remodeling, very strong antifibrotic, agent. And it also doesn't allow the potassium to come low. That's why I think sudden cardiac death benefit is huge. So thank you, Dr. Jabir, for showing us. Arindam, being a co-author of this, paper, what's your, take on important takeaways from this entire position paper?
So this is a fantastic paper, but unfortunately what we see, the MRA are the group of molecule which is discontinued to the highest extent out of 4 different pillars of heart failure. So probably this paper will play a huge role. I will request everybody to go through the paper, please. There has been clear-cut mention what are the situation when you actually need to reduce or discontinue the drug, how you are supposed to monitor the potassium, what are the additional advices you are supposed to give. And this is probably one of the most comprehensive paper about MRA, which will serve a lot of purpose.
Absolutely, absolutely. So before we close down, yes,
Jabir, one question. So
yes.
if I give you a molecule which will block the synthesis of aldosterone itself,
yeah,
would you
the
like to give?
aldosterone synthase inhibitors.
Yeah. So suppose you have this aldosterone synthase inhibitor on board for hypertension and patient has developed heart failure. Would you still like to give MRA or not?
I don't know the answer, Dr. Prakash, to be honest, because there is one advantage of aldosterone synthase inhibitors. When we use aldosterone receptor blockers, actually the serum level of aldosterone increases. Whether blocking or reducing the total aldosterone, circulating aldosterone in the body is beneficial than blocking the effect of aldosterone, we don't have a data.
Right. Thank you, Dr. Javid.
Yeah, I have one question.
To close the session.
Just one question.
Yeah,
Just one question.
So we have, so how to give, or the patients below EGFR, below 30 are totally scaled out. We should not give them.
As per the guidelines, it is not recommended because of the lack of safety data. But we all have been using it. So it's a clinician's judgment. For example, a patient with CKD, EGFR less, the potassium is 3.5. If you can monitor them correctly, and if it's a patient who will listen to you and come for regular follow-up, I think we can start it. But only thing is the surveillance and the potassium should be good, especially with the tubular disorders.
Sir, I have one question. So in the real life scenario, how many percentage of the patient with reduced ejection fraction you are using the eplerenone 100 milligram? And what's the data? The 50 milligram and the 100 milligram. So how will differentiate the mortality benefit? And number two,
as you rightly pointed out, if you look at the data on the FSCAI trial and the emphasis data, it is basically the 50 milligram dosage. Those patients with a low potassium, you can increase it into 100 milligram because this is a weaker drug when compared to the spironolactone regarding potassium conservation. If you ask me, is there any difference between these two dosages regarding the endpoints? We don't have a data on it. Even for spironolactone, 25 milligram was the major dosage used in the RAILS trial with all the benefit. So a lower dosage at any dosage is better than no dosage. Whether the correct dosage or the maximum dose used in the major clinical trial gives additional mortality or morbidity benefit, the data is not clear.
Because.
So thank you, Dr. Jabir. I think we close the session here, and wonderful insights. And we again request to have this paper, and everyone please go through that paper. And CIPLA was very instrumental in, making things happen. And it was the work of Dr. Michael Baum contributed heavily. Dr. Jabir and our senior experts also contributed, to great extent. We were not very big contributors, but we had our inputs there.
Right.
So thank you so much, Dr. Jabir.
Thank you so much for this great opportunity.
Before, because sets in his slide, Saurabh, one question, not to Arindam. This MRA receptor prevents fibrosis. If you have a liver fibrosis, would you give MRA receptor blocker?
No experience in
No
liver
experience.
fibrosis. No.
Which organ in human body do not have MRA receptors? Question anyway, so liver do not have significant amount of MRA receptor because
Good afternoon. Good afternoon. Chairpersons, good afternoon, Dilip. Good afternoon, Dr. Ganguly. And thanks for inviting me. Now, I would request you all who are presenting here, please be interactive because I had some problem doing this case and I would like to have a discussion with you and see if you would have done it differently, right? So this is a gentleman who was a 75-year-old gentleman, is diabetic. He presented in the emergency with acute shortness of breath and severely acidotic, and that was lactic acidosis. After many years, I have seen metformin-induced lactic acidosis in this gentleman. And ECG showed left bundle branch block. Echocardiography showed severe aortic stenosis with LV ejection fraction around 40%. He was managed with IV insulin IV fluid. His renal impairment was there a little bit. And once stabilized and acidosis was corrected, he was taken for TAVI workup. Now, this is the CT scan parameters. If you look at it, that annular diameter was about 24, maximum was 26, and area-wise, it was 572, and you see the perimeter derived, it was 85.6. And you can see that coronary heights were pretty satisfactory, and the peripheral arteries were also very good to approach femorally. But this was the valve. Look at this valve. It is heavily calcified, and the right coronary cusp and left coronary cusp was fused. RCC and NCC was fused, and there is a significant chunk of calcium at the LV outflow, LVOT. Now, this is hockey puck image, and you can see that calcium, heavily calcified with LVOT outflow. So my question first, which kind of valve we are going to choose? Is it a balloon expandable or self-expandable? Saurabh, if I get
We'll
some comment
start
from
with
you.
Arindam. Saurabh. Okay, go ahead, Saurabh. Don't mind. Arindam, which valve?
Okay, since there is a lot of calcification in the LVOT, my preference will be to go for a balloon expandable valve. Not self-expandable valve in this case. And predilation strategy will be, yes, I will predilate prior to the deployment of the self-expandable valve. And yes, predilatation is a must, but sizing,
and
I have to see.
This is the size. So you get the annular diameter of 24 minimum and maximum being 26. So looking at the calcium and the distribution of the calcium,
yes,
what kind of balloon size do you think you should be choosing in this particular case?
With this, I can. What is the annular size? Can I see? Annulus, what is that?
Sorry.
24.
Annulus minimal diameter is
So,
24.
Yes, I will upsize to one size.
So you want to choose 25, yeah?
25,
okay.
yeah.
Yeah.
The minimum diet is 24.
Any comment, Dilip, in this particular case?
I'll upsize it.
These calciums are like knife, and if you are aggressive in predilatation, if your balloon size is little, higher size,
So mine will be
it
more.
will just go into the, it can go anywhere. It can go to septum, it can go VHD, it can go rupture, annular injury will happen, conduction block can happen. And you rightly pointed out that self-expanding platform is good here. You should not be going with balloon expandable. It can cause severe injury.
Yeah.
And also, usually we see the balloon, predilatation balloon, with the, the minor axis. You see 24, 28, you see the 24 only, okay?
24.
I will be even conservative in this case. I will be even conservative in this case. Dr.
Srinivas, my question first, then your comment. Which self-expanding valve you do use? Which self-expanding valve would you use?
All right,
Yeah.
okay. Yeah.
The functional bicuspid.
Functional bicuspid with a RAFE, heavily calcified LVOT calcium. I mean, textbook wise, typically self-expandable. However, I have a different thought. If I put a self-expandable in this, the valve opening will be exactly this oval. It will not expand completely, and there will
Right.
be significant paravalvular.
Yes.
And we'll be forced to do a post-dilatation, which will
Yes.
again be as traumatic as this thing.
Yes.
My strategy for this is I'm going to do a pre-dilatation. Pre-dilatation will be an average area size. So average was 27.
26.
Probably I'll take a 25 balloon for
Right,
this.
okay.
Do a proper dilatation, 1 or 2 dilatation. Ensure that it is opened well.
All right.
I don't want to go to 26 completely. 25 should be good enough. And once you have an adequately open, then I'll use a balloon expandable valve. If I'm using a Merrill, it is 27.5. If I'm using an Sapien, I'll probably do at 26 only. But the initial implantation, what I'm going to do is I'll remove 1 cc or 2 cc from the implantation. So it will never be as robust as fully non-compliant balloon. It will act like a kind of a semi-compliant, anchor that, leave it for some time. and then go for a double tap technique and ensure that there's no PVL.
Right.
Which,
I appreciate your
again,
comment.
my question-
I appreciate your comment. You will come to know why I said that.
Because which self-expanding valve would you use?
If
It's
at
a
all,
high
if you have to
radiation.
use a self-expandable one, I
FX.
want the one with a
FX.
very high radial strength, and that's
So that's why I
obviously
use
the
Metronic valve. I use the Evolus platform I use because of the high radial strength.
Yeah.
Now,
but despite that, it may not expand, and it will be oval like this.
No one can ensure that things will not go wrong here with balloon expandable, because you see this is chunky, not only chunky calcium, it's just
It is
projecting
a
there.
rafe calcium,
Yeah,
but it is projecting, but it is not spicule.
Severe LVOT
That's what
calcium.
I
We
said.
have burned
You have
our
done
fingers.
much
so
more
we have-
Versor calcium.
Right.
I have just one question.
Priyam, yeah.
Just one question. So, considering it's a TAVI summit or structural summit, so though it is very highly calcified, so we know highly calcified, this kind of patients are bicuspid patients, very high risk for TAVI. So why don't you send the patient for surgery?
now this patient, as I said, now I give you the profile already. He's diabetic, he is acidotic, he has got LV dysfunction, right? And
Patient is 80-year-old.
he also had a previous stroke, which I did mention.
Okay, Sumanto,
And
if
there
you
are
have
lot of
IVL, if you
comorbidities.
give 20 millimeter
75.
IVL balloon, would you use IVL?
Yes.
As there is a severe calcification is there and LVOT calcification is there, that there is a chance of that may rupture. That's why probably. Yeah, shockwave.
IVL assisted tower is one of the important
IVL assisted
techniques
tower.
which we should consider in this kind, especially if you are planning for a self-expandable.
Right. So for the juniors, so as there was LVOT calcium, we generally didn't use in a normal protocol the balloon expanding, because there is a chances of rupture of the LVOT area if you're going for a balloon expandable. That's why we generally prefer self-expandable, particularly when there is a LVOT calcium for the juniors. But of course, I appreciate it.
My question, if it ruptures, what is your guess where it will rupture?
So no, the annulus can get ruptured.
That's a good question, sir. It will be exactly opposite to that calcific raphe. It will be into the NCC. It will be in the membranous. All you have to do is one more valve with a longer cuff, and that will be solved. So it will not be a detrimental one.
But when
Second, nowadays it's not heavy calcium or the LVOT calciums are not an absolute contraindication.
No, I'm not saying not absolute, but
It is
generally
the
that is the
parameters
practice.
around which we plan our
that
things.
is the practice.
So one more question to Dilip. If there is LVOT calcium on the septal side, would it prevent the pacemaker?
Not prevent, it will cause further chances of conduction problem is there, because this will go down, deep down, it will migrate. And whichever, if it is because this position of the calcium is important and the extent of the calcium is important. So the position wise, it's LVOT, quad septum going down, so it can cause heart block, it can cause deep, annular injury to rupture also, it can cause VSD,
So-
it can cause.
Okay, Srinivas, would you use a valve? Let me phrase the question. Would you use a valve which has got inflow little on the, decreasing size and outflow? Do you use that?
This? No, sir.
No?
In this case,
Do
definitely
you
no.
use a tubular valve?
We want a tubular valve.
Okay, go ahead.
Okay, now I decide to do pre-dilatation and I choose for a self-expanding valve. And we choose a 25 millimeter maxi LD balloon after crossing. And now Dilip, this is the 25 millimeter balloon. And are you happy with the pre-dilatation with this balloon? What I have done?
See, this is what happens. Like if you see the calcium is on my right hand side. The balloon opened on the left hand side. So this is what we typically see in the coronary also. The balloon always goes to the opposite to the calcium effect. It does not go down or push on the calcium. So only if the calcium is circumferential and equally distributed, only then the balloon might stay in the between. This is typically, this is what is happening.
So this is typically that what you appreciated, that what happened to us. So when we start to deploy this evolute valve, it was not opening up on the left side because the calcium was actually preventing that, exactly what you said, that there will be a lot of paravalvular AR. So we couldn't deploy this valve with this kind of calcium. So we said, okay, let's try further pre-dilatation. And we took the same balloon and you can see that it's not pushing the calcium at all, right? Then we were a little bit brave actually. And the next thing, we took a upsize balloon with an Atlas Gold and you suddenly see that the calcium moved. Momentarily, we thought that annulus is ruptured. Yeah. So there was a lot of panic.
So if you see,
right?
so
Now,
if you see, that is actually the raphe calcium which broke and moved along with the leaflet. It
Yeah.
is not an annular rupture.
No,
It
no,
is just a
no,
leaflet.
I know that. But initially, now it just popped up. We thought, okay. Then immediately look at the pressure, and then we said, okay, the pressure is there. So patient felt a little bit uncomfortable, but eventually he was stabilized, and we managed to put the valve in successfully. But now I will ask you to look at here. So there is something moving up and down.
Yeah.
So the calcium was embolized from the valve down to the aorta.
Exactly.
Right?
So this,
So now, anyway, we implanted the valve. There was a little bit of paravalvular AR. So we again did the post-dilatation with the 26 balloon. And we accepted a final result with a little AR there as well. I would say it's a kind of grade 2 AR still there. But we accepted that.
It was a little high implant. It's almost 0.
Yeah, because,
3
yeah,
millimeter. You
little
can see
high
a
implant,
first
I know.
Yeah.
We were pretty much panicked at that time.
3 millimeter down.
Right. I'm talking about the non-coronary cusp, you see. Yeah.
I think it's probably fair enough.
Yeah,
It's not too bad. Yeah. Now, what to do with this calcium, which is in the aorta, right? Now, very difficult to do anything with this calcium, which is in the aorta. And then we put the pigtail from the radial down and put another pigtail from the groin and try to bring that calcium down to the left groin so that it becomes much more accessible to us to take it away percutaneously. So this calcium got migrated, means we took it down towards the groin, and you see the calcium is lodged here on the left common femoral, left iliac artery. That is the calcium, right? Then what we tried to snare it up. We put a mullen sheath from the other side and took an end snare. But what's happened? It caught the calcium, but we couldn't put that calcium inside the mullen sheath. It was all the time, it was falling apart because it was such a big chunk of calcium. It was not coming through the sheath. Then, of course, when you are desperate, you call a friend. And we put the calcium further down where it can be accessible for our friend, surgical friend. And then we called the friend. The friend managed to do the cut down on the groin. It was in the accessible area. And what we got is a calcified leaflet which came down, and then it was surgically repaired, and subsequently patient did well and went home. I followed him up after one month with an echo. There was a grade 2 AR which I have accepted. Patient clinically did very well. All this edema and everything is gone. Patient's breathlessness is completely gone and is very thankful. So this is an example of the difficulty we often face with severely calcified valve. And we need to respect the calcium and plan accordingly. Now here that calcium actually hindered the expansion of the valve. That caused a lot of paravalvular AR. We were kind of bravely tried to break that calcium, and that caused that embolization. And this is a rare case of calcified leaflet got embolized into the peripheral system. I was lucky that it didn't go to the brain.
Exactly.
And it is important to maintain a good friendship with a surgeon. So always come to the cath lab and open up then and there. Thank you very much.
Very nice.
Very nice case. Any last comment from the panel?
Two questions. Number one, how ECG changed or behaved?
Sorry?
ECG. I mean, patient had an LV.
No, this patient eventually had to put a pacemaker afterwards.
That day?
No, 2 days later.
2 days later. And number two, how the ejection fraction behaved?
Ejection fraction is better.
Improved.
Improved.
I mean, how many days?
It's 50% after 1 year. After 1 month. Sorry.
1 month.
Okay.
Yes,
so now
still grade 2 AR. So if the AR progress, probably we can put a vascular plug on that for the
give
paravalvular.
Manjaro.
Yeah.
So one question.
Okay, thank
so
you.
one question, sir.
Yes,
because,
Priyam's
sir,
Thank
comment
you.
was very valid.
Sir,
If it is high risk for
so one
surgery,
question
it's
to
high
him.
risk
One
for
question.
TAVI also.
Yeah.
You can ask Dilip.
These cases,
By the time
if it is high
Arindam
risk for surgery, this case is high risk for TAVI as well.
Yes, definitely.
So Dr. Priyam's question and comment was very apt. First comment was why not surgery?
Yes.
So it's high risk for surgery, but it's high risk for tower as well. It was luck which favored
No,
all
no,
of
I
us.
fully agree. This
exactly.
is high risk
So,
for both.
I mean, this is what we learned, sir. Over the time when we started initially using the self-expandable with such a heavy calcium bicuspid, our peripheral complications, strokes, and other things were very high. And calcium embolization used to be common. We used to see that leaflet suddenly jumping out. Whereas it had been a balloon expandable. After the initial expansion, you would have expanded the entire valve with a post-dilatation. That cage would have holded the leaflet there only. Embolizations are less common, less traumatic also. Especially with the current
As
Basilia valve.
Arindam is getting ready. Saurabh has a question
Sir,
to the panelist. To the panelist.
Yeah, sir.
Not to him, to the
Yeah,
panelist.
okay. My only question to this is that when we are doing this self-expandable valve deployment, what should be the post-dilatation in such cases when there is heavy calcification of the LVOT? That is number one. Do we upsize or we keep the same size as the valve or we downsize? Number two, if there is a paravalvular leak happening, so what should be our strategy? If not, then what should be our strategy?
Right. So Arindam, you have to answer his question while you deliver your case. Okay.
Okay. Fantastic
So,
case. You should publish it. I have never seen a leaflet calcification coming out in hand. This is a case to be published in literature.
So
for
you
sure.
should highlight what is double tap, what is the definition of double tap in self-expanding valve, what balloon you use, what type of balloon you use, how many times you inflate, eccentricity or concentric appearance of the valve. Those questions has come in his mind. You have to answer that after you finish your case.
After I finish my case. Okay. Okay, fine. So I'll be showing a nightmare case. So basically, I'll not be showing the procedure in detail or the pre-op because otherwise the discussion point will little be diluted. So my case was a 67-year-old gentleman, severe aortic stenosis, bicuspid aortic valve, had moderate coronary artery disease as well, which we thought to be kept on medical management, CKD not on hemodialysis, COPD, hypertensive diabetic. He was very, very symptomatic, orthopnic, hardly, slept for a single night for last 2 months before the procedure. So taken for TAVR at that time, these Boston Scientific valves were still available. So it was an accurate Neo2 valve. So we can see it, the groin, though mostly we do ultrasound guided puncture, but this patient we did some injection because we are gaining good experience with Manta device closer. We thought we'll close this patient with single Manta. So that was the plan. So we took this shoot, and this is the procedure. You can see closing was not much of issue. It was good calcification, bicuspid aortic valve. In most of our bicuspid aortic valve, of late we are actually pre-dilating, and this is how we deployed the accurate Neo valve. And once the valve is deployed, we realize that valve has migrated. It is not even 0, it is minus. So, and there was significant paravalvular leak as well. So at this point of time, we thought what to be done. Options which were available to go for another, balloon expandable valve inside this valve, because this significant aortic regurgitation, probably we cannot just let the patient go home with. And another option which we did our case, because always the issue of cost comes in TAVR. If you use another balloon expandable valve, then the additional cost will go up. But otherwise, as we have good liaison with the company personnel, if you ask for another valve, they will give another valve free of cost. That is not very uncommon. Many of our previous cases we have done so. So if we take another self-expanding valve, then it is not possible to go through it. So what we did, we actually snared the valve. So we snared the valve out, and for that we had to take additional puncture from the left groin. We already had a large bore access from the right groin, then another access for the pictal from the left groin. So we had to take another additional access from the left side to take the snare in. And with this snare, it was not very difficult actually to take out the valve. We could actually took it out very easily. And you can see through the same, entry on the right side, we took another valve, and this time we were very, very careful to position it rightly. Otherwise, we could have sent the patient for surgery. So at this point, the second valve sat properly, and we can see we went through the, second valve through the existing previous valve, and it went little up. And when we took out everything, it came little down, but there was adequate space. So we thought complication very nicely managed, and already it was quite, long procedure. People were thinking what is happening. In between, when we went out, counseled the party, and we thought we'll go ahead and close the, access. We deployed a manta, and we realized, I'm sorry, the lower panel actually obstructing. We had a very significant stenosis of the right femoral. Very significant stenosis of the right femoral. So this is the manta device. As we are using manta, you need to have the, depth, before the procedure begins. So before you do anything, you should take the proper depth to have a, good deployment of manta. You have two sizes of manta, 14 and 18 French. So this manta, after this manta, there was very significant stenosis of the femoral. So what we did, we dilated the, manta interstitial with peripheral balloon, and that actually served our purpose. The flow is now good. We thought second complication well managed. So we are very happy. So on the left side, we now have two axes. One, the previous axis of the, pigtail, and an additional axis for the snare. So we went ahead and deployed a angiosyl. An angiosyl. Then we thought, let us take a picture, and this is the third complication, the same patient. Now the left side has totally occluded. You can see the femoral side has gone now, no flow at all in the lower limb. So this was probably the toughest complication. So what we did, we went through ultrasound guide to get additional puncture in the thigh. So there was no flow, only ultrasound showed us some lumen, and in that lumen we punctured through ultrasound guide, but that was not sufficient. We saw that we are in lumen, we gave some dye, but it was very, very difficult to cross this, totally occluded segment due to angiosyl.
You had a radial axis also, right? You
Yeah.
didn't try from above?
We should have, but
I thought you had a radial axis. While showing the snare picture, there was one catheter
no,
coming
actually
from the right
now I
radial.
am giving the dye because we had two axes. One of the axes is
But
closed.
you had a right radial axis also, right, in this case?
No.
No? I saw some catheter. Just go back to a couple of slides before. That where you were trying to snare the device. See, there's one more wire going in. Oh, that's a looped
No,
wire.
that
is
is,
looped wire,
yeah.
not the radial.
No, radials were not there. So this was the toughest part of the complication management. We tried to pass the wire, and you can see it was not going. So we took coronary wire, and after really spending around good time, 20-25 minutes, we could actually wear, and then we ballooned it, and we waited. This time we thought we'll just wait and see what is happening. And after ballooning, the flow has come back. But there was some leak because you don't have anything to press in the femoral, thigh. No bony landmark. So still we gave good compression. We thought enough of vascular device closure. So we did good compression, waited, and after some time that leak has disappeared, and the additional puncture which it had, that was also closed manually. So that's it. Thank you.
That's it. Who would have gone to radial, left radial? PM, would you have gone radial to rescue the left femoral?
Radial will be difficult. Of brachial.
Brachial in
Why not radial?
Left radial is good enough.
Left radial, left.
Either. So my question is that why your device was was displaced? Why it was your placement was perfect? I saw the picture. But it was finally it was come forward. So, any specific cause you can look at?
In an accurate neo, I've proctored few of the cases when the device was there. Accurate neo, the radial strength at the lowest portion is actually very, very small. So you need to have it slightly deeper. There is a radio opaque marker which has to be kept at the annulus, that is for the tricuspid valves. When it is for the bicuspid, where the leaflets are quite lengthy, so you should ensure that the upper crown which has been opened is always pushed down the bicuspid before the release. Otherwise, the valve is going to behave like this and it is going to pop out. And when it is already up and anchoring at the leaflet level, it's easy to snare and put a new device. Given a cost constraint, that is what we all do. Whenever this embolizes, we take a snare, pull it out, if possible to DTA, if not possible, ascending aorta. So that's what you did, and that is perfect. The second time when you did, actually you kept a pressure on the system before release. That's why it stayed in place. If not, even that would have embolized. But since you had a first device which was already pulled out in ascending aorta, that can act as a guard, not to embolize very much out. So in that way,
what is your experience of follow-up of this kind of patient embolized? Because I'll tell you the follow-up of patient I did not mention. Yeah. So how they behave, you know, another additional wear, does it increases the thrombogenicity or something like that?
I've had around 3-4 cases. As of now, all of them are okay. The lowest follow-up I have is around 3 years. Yes, longest follow-up is 5.5 years. All of them are okay.
So this patient had LV dysfunction, ejection fraction was really low. After 6 months, ejection fraction has came up. It become almost normal. Then what happened? Patient developed ischemic CVA. They used to live nearby the airport. The son was so keen in treating his father. He created a green field to have clear traffic to take the patient to a hospital with ischemic stroke. He reached the hospital within a span of 1.5 hours. And we thrombolized the patient, but the problem is the weakness improved static. It was very fantastic improvement of power and all. The voice came back, but the night of the thrombolysis day, the patient developed a hemorrhagic CVA, and that is how the patient actually died because of hemorrhagic stroke.
Dr. Jain from Bhopal, let me welcome my friend, junior friend. If the first valve migrated too much towards the coronary or towards the second valve, what will happen?
Migrated towards the towards the
going towards ascending aorta or descending aorta.
Yes, sir.
The valve has migrated towards the root of the aorta. Okay. If migrates too much down below, what will happen?
Sir, conduction system disturbance will happen.
No, Shubham, what will happen?
Migrated into LV. No. Whatever the earliest migration, what we saw is this thing. It's the same kind of no. Whatever the device is embolized into ascending aorta.
Ideal place will be the descending aorta. His valve, first valve, has migrated downwards towards the LV. So what will happen if it migrates too much?
Towards aorta, root.
Yes, towards the annulus, towards the LV.
And we cannot pull it out. With snare.
What happened? What happened? They're angry or they have
they wanted to skip the question. That's why
I want some space for some other people. Chilanjan has come.
Anyway, quick. Yeah. What will happen? Please, any answer, Saurabh?
The valve might rotate and occlude.
No, it will not rotate. Rotation happens only in LV. It cannot rotate in the aorta. So basically, it will occlude the coronary artery. Ultimately, it will be behaving like a carton. There, the coronary obstruction.
Coronary occlusion, especially.
Am I right?
Correct, sir. Yeah, coronary occlusion is one. AR we saw because obviously valve is not.
So that
concrete.
is the only danger you have left in him if it migrates.
It can disturb the functioning of the valve also.
So coronary, if
it is not obstructing the the entire. The SDJ is high, SDJ is larger and commodious. It is not going to create problem with coronary, but it can create problem with the function of the valve. It can go a little down.
I have just one question. So instead of trying to snare the valve, the displaced valve, is it possible to place that step another valve in the valve?
No, that will cause coronary occlusion, no?
Yeah, the skirt which is there, 18 millimeters, 14, 15 millimeter, it has come up higher. The coronary height is 14, 15. So if you put another self-expanding valve down, so the skirt length become how much? Height become much more.
Actually, sir, coronary obstruction not only depends on the heights, but also the
You can be
capacities
lucky.
of your sinus also. So not
So
always that you obstruct the coronaries.
why we don't do that is for 2-3 theoretical reason. In this particular anatomy, we know that sinuses were roomy, STJ was roomy, the blood flow can actually still happen, coronary protection will be there. But to track a device which is already angulated and which is actually floating over there means that we may not be able to tackle one. Second, when you're trying to push through, the previous valve itself can cause aortic root injuries. We don't want aortic dissection to occur over there and make it more complicated.
Arijit, suppose this valve has migrated badly towards the LV and has caused coronary obstruction. What will you do?
Sinus is good, we can do that.
Now, what is the rescue? It is behaving like a dead space, no? That between two valves, the coronary is not getting flow. What do you do? Send it to the surgeon or any other thought?
If at all, if it is serially and both the valves are in between and the coronary is in between, so coronary flow will not occur.
Yeah. So
you'll have to
put a
allow the blood flow.
self-expanding stent. Self-expanding stent.
So first and foremost is you should put an impella. If you don't have an impella,
You
pull
have
the
to
yank
pull
it
it
out.
out.
Yank it out.
You have
That
to
will
take it
save the
out.
patient. Otherwise, patient will
So there is a new device called Ono device, which can.
But Priyam's concept was also not bad. If the sinus is roomy, we can still go for second device inside that. Initial teaching was with there is a migration little bit, we can put the second device to stabilize that as well as take care. If your coronary risk is not there, if you find that the coronary's height is okay, but and it is very large, sinus valsalva, and the aortic diameter is also very good, SDJ is also very good, so you can definitely go and deploy
And
there.
the second valve should be a balloon expandable.
Yeah.
Where
So you
a
have to
deflectable
snare it out and put it in the descending aorta. In descending aorta, the valve function is dysfunctional. Suppose the valve is not opening, then you put a self-expanding stent on the TAVR. Otherwise, just leave it alone. Now we go to Anindo Mukherjee. Where is Anindo? Anindo, then Arijit himself. Arijit goes. So Saurabh has disappeared. Washroom.
He got scared of your questions.
So I am not a structural operator. So a day long we had a lot of Dr. Arijit Ghosh.
चल चलो
ना मैं स्लाइड में मैंने देखते बच्चे ने हाँ पीपीटी उधर लोड किया था
Gopal is here. I can ask him a question. So Gopal, Saurabh was asking what you do when you see a PVL, significant PVL, after implanting a self-expanding valve. Mic to daw.
We can do a post-dilatation.
Post-dilatations. It has worked. It does not work.
How much you can do and how much you cannot.
Does not work.
Then if the post-paravalvular leak is very much, then probably we have to implant another valve in that.
Another valve. Good. What else?
Or the post-valvular leak, we can plug it.
What is Tootsie Roll technique? Tootsie Roll stent, you know? Tootsie Roll technique, you put a covered stent behind the valve and put an AVP through that covered stent. Because that place, is very difficult to understand whether you have gone through the start of the valve. So if you put a covered stent behind the, that it has gone behind the start, and put a covered stent, and then you put AVP inside the covered stent. There are other methods. Srinivas, any good points?
Yes, sir. So generally nowadays we don't put a covered stent, sir. We use a 3D TE. It is going to be TE guided. Take the guideline or the sheath completely inside that, see it in a 3D view, and then start deploying the AVP. That should be enough. Of course, we can have a lot of other techniques which we can discuss if there's any PVL cases.
Right. Rajit, are we ready? Yeah, start.
structural one. So the thing is that this was a 75 years old female. I went for a primary angioplasty of the LED. So these are the usual things that we keep on doing on while we perform primary angioplasty. These are all very run-of-the-mill cases. We keep on doing these things every day and day out. So these are the regular stuffs. So again, the predilatation one. Flow was not coming as it happens in any primary case. The stent was deployed. It was post dilated. And this was the final result after a repeated thrombus aspiration, giving various aliquots of slow flow regimen through the suction catheter, and this is what I could achieve at the end of the procedure.
What suction catheter you have used? Penumbra?
The Medtronic one. No.
Oh, routine.
Routine
Garden variety.
manual suction.
Garden variety. If you have laser, would you use it?
You know the milieu of my cath lab the most. Why are you asking this?
Anyway, just asking for the audience.
No.
Any quick comment, Dr. Jain?
Sir, some off-label techniques we use puncture balloon and put it distally, or microcatheter we can push the distally for improving perfusion.
So everything was used. Everything. I'm just not discussing these things.
Right. So slow flow, no flow, and
as we keep on managing it. So
suppose you are doing TAVR, there is no flow in the aorta. What are the things you should think of?
Check for the orientation of the valve first.
I don't have an idea. No flow in the aorta.
Yes. I mean, the blood is like stagnant now. Obviously, blood pressure has come down. So what are the possibilities? Hypotension during TAVR.
Hypotension during TAVR, the most common cause that we fear is an annular rupture. That is
annular rupture.
Yeah.
What else? And I'm not
We
taking
might
your
have-
class.
we might have occluded the coronary
So
arteries
this
as
can
well.
also happen during TAVR. Since that
No, we can occlude the coronary arteries as well.
coronary artery is very good. Coronary obstruction
Coronary
it can
obstruction
happen.
might lead to
You
this.
can go into cardiac arrest. The free wall rupture.
Yeah.
Free wall rupture by
And
the wire.
wire can rupture the
Yes.
LV.
Rupture.
These are the things.
Anyway,
that might happen.
this is a different subject. Any quick comment? Hey, Saurabh, what is Tootsie Roll technique? What is suicide? Yes. So what is suicidal LV?
Suicidal LV is like that as we keep on discussing in PS. He's also
No, what is suicidal LV?
sudden
Sumant, what is suicidal LV?
Sudden hypotension after
LV. No flow in the aorta. TAVR, successful TAVR.
Probably you would have heard about suicidal RV, something similar to that.
yeah.
It is a contracted myocardium, and we have all released the obstruction. Suddenly it goes into a contraction. There is no end diastolic volume only to feel.
As it is there in PS. Yeah.
Same thing can happen, like hypercontractile LV. Suddenly there is release of the valve, and there is enough of preload in the. So LV is contracting with empty state and vigorously contracting, and there is no forward output as such. Okay, what is Tootsie Roll technique, Saurabh? Tootsie Roll.
Let him complete the case. Case still going on.
Oh, case is there.
Yes, sir. Yes, sir.
Yes, sir.
Arijit, go on, carry on.
I thought you are presenting.
No, I have not. This is.
He said it's a
this is not
structural
coronary
case
product.
started as a coronary.
The patient was stable,
go ahead,
transferred
go
to the
ahead.
CCU, and suddenly developed.
Pansystolic murmur.
So on examination, there was a. You want to? Oh, show me the problem. Yeah.
VSD, what did you do VSD?
No, that is not a perf. I have thought about it, but that is not
No,
the
it's
part.
not
It
part.
might be an intramural kind of. We are not bothered
It's a
about.
natural venous drainage.
Might not be very natural. Might not be very natural.
VSR, I think he's
So
going
can
to
it be a
show
harbinger
us
of
VSR.
VSR?
No, I think it is a natural septal
No,
draining
might
into the
not be natural.
small
Might
island
not
of.
be natural.
Anyway,
Looking into the viability on, there is very high risk of VSR probably of
why? Primary.
Likely, yeah. Arjit, please
No, it
go
was
ahead.
not a delayed presentation. It was not a delayed presentation.
The patient developed VSR
Carry on,
later
carry
on.
on, Arjit.
Oh,
So this was a VSR,
okay.
and it was written in the title as well.
Yes. Closed, huh?
I am not going to do this. What is this?
That sign of squeezing and squeezing. Sign is what you're trying. Yeah.
I spent a lot of time getting confused whether it is a muscle bridge.
No. If you're seeing it after this is typically because
They're
in the
very
distal
typical of
LAD,
a
I think Kamal Sood from Ahmedabad described, and he owns this sign, Kamal's sign of VSR.
So this is the winking coronary sign.
Correct.
Very good.
This mimics the muscle bridge.
Kamal Sharma, correct. I told Kamal Sood, it is Kamal.
So this is mooted by Dr. Kamal Sharma, and this has a sensitivity of almost 67% with a specificity of 100%. These are the various mechanisms which has been put forward. So this is basically what we do after we see a post-MI VSR. Post-MI VSR, hemodynamically stable, follow up for more than 7 days, delay the surgery, the patient is safe. But if the patient becomes hemodynamically unstable, he might be a candidate for surgery or might not be a candidate for surgery. If she's or he is a candidate for surgery, we should be embarking upon emergency surgery. If not, we should be thinking of some percutaneous closure devices. That is what we ultimately had to perform. So according to the guidelines, we went for an IABP in that evening as well, but somebody might argue that we could have been gone for a device which would have increased the cardiac output even more, because IABP has can increase the cardiac output not more than 0.5 to 1 liters. So this can be an argument, but this was widely discussed with the patient relatives and they did not agree for an impeller. So an IABP 1:1 was deployed in that evening as well. She was doing well, and we were hoping that she will be coming out of this immediate hemodynamic crisis. And the day 2 was very stable for her, but things started deteriorating on day 3. She started developing atrial fibrillation, required more and more noradrenaline. There was a drop in iron output. She was getting into cardiogenic shock. So this was the day 3 echocardiography, which showed that there was an LV apical ballooning as well, and the shunt increased. There was an increased sloughing of the VSR segment, which was not quite evident on day 1 echocardiography. And this was the transesophageal echocardiography which was done, transthoracic echocardiography. The relatives agreed for a VSR repair. She was intubated and the procedure was done under transesophageal guidance. So this is the status of the VSR on the day of the procedure. So we calculated the VSR approximately to be 19 to 20 millimeters. We had oversized the device. We had used a muscular VSD device, and we took a diameter of more than 2 millimeters. So this was the Serra LifeTech device which was used, and the right jugular vein and the right femoral artery was the routes which were used. The rent was crossed by a JR catheter which was snared from the right jugular vein. And the device was deployed. I want to mention one thing, that during the initiation of the procedure, the patient had a cardiac arrest. We revived her out of the cardiac arrest, and then we started the procedure again. So we managed to position the device across the VSR, which was confirmed by the transesophageal echocardiography. But again, she went into a cardiac arrest. We were successful in placing the device, but as the patient did not make it, even after a prolonged CPR, just for logistic reasons, we decided not to deploy the VSR device, just to bring down the cost, to be very honest with you. We had extracted the VSR device even after deploying it.
He was having cardiac arrest due to electromechanical problem or bradycardia or with
She was having bradycardia.
bradycardic arrest, not
during the procedure.
So one of the common reason what we see is whenever you are doing a post-MI VSR device closure, that too within 1 week before there is a fibrosis, the very kind of pull, AV malformation, which is actually pulling the septum up, causes patients to go into brady arrest or within kind of an almost asystole. So generally we try to relax the tension. We don't want too much of tension, and we try to oversize the device by at least 30 to 40%. Our idea is just to reduce the shunt, not to be a very perfect, and over the time it will slowly get aligned, because these tissues are very necrotic. And
Very necrotic. Asystole, no. Sometimes when you do the CSP, left bundle branch pacing, once we screw push the lead inside the septum, many times I've seen people have gone into complete asystole. So this tension is something happens to the bundle, as Srinivas was mentioning. Too much of tension perhaps does something on the conduction system.
She was having bradycardia.
Bradycardia. Not bradycardia means the sinus. It will go into complete asystole sometimes. Ultimately, brady and asystole.
Not a sinus bradycardia.
Yeah,
not a sinus one.
It is either a sinus or kind of an asystole, because that mechanical pressure.
It's a very difficult substrate, so I think
difficult actually.
I think
That is
the
where
story. Yeah, go ahead. Yeah. The story is same everywhere. Whatever you do in this world, the mortality, even in the West Center, surgical or.
So this is the natural history of MI VSR. We are so helpless at this day and age. If you don't do anything, the mortality will be close to 90%. Actually the patient survives based on her or his natural selection. It is nobody's credit. The more closer you intervene in the first week, there will be high mortality. As the patient stabilizes, she will be having lower mortality. So it is all about natural selection. If God saves the patient, he is saved. In majority of the cases, whatever you do, there will be a very high mortality. So
if you have this RAWS device, the new device, VSD device, much softer. Do you think that will make some change?
Actually, it is not about the device. Basically, it is all about the whole process. It is an extensive myocardial infarction. Majority of the patients are in cardiogenic shock. I fortunately could pick up the patient quite timely within 2 hours of the event. But in majority of the patients, the diagnosis is delayed. The patient goes into cardiogenic shock with multiple organ failure. This might be the majority of the patients have these things as the reason of their death. It is not about the device.
So how did you counsel the patient? Did you tell him that you're 90% chance of dying?
Yes. But despite those things, she is a doctor's mother-in-law.
Okay, so the doctor has bet on 10%.
He has bet on 10%.
I have a question. So a lot of confusion regarding the revascularization. Had it been that you picked up the VSR before the angioplasty?
Now, Arindam, the only thing that I do in my practice nowadays is I rule out aortic dissection. I check for the mechanical complications.
I
understand.
understand.
These are the only things I
so
see.
if you pick it up before your angioplasty, because in the protocol, many of the time we are on, run, middle of the night, the patients are coming for primary. Sometimes we miss. There is no harm in missing it. But if you pick it up before your angioplasty procedure, then what is your revascularization strategy?
How can you pick up a VSR on the 0 hour? The VSR develops only after third to second.
No, I'm talking about before taking the patient to Cath.
No.
So no. What is the revascularization stat?
Generally, what we do
Yeah.
is, if at all in our hospital, we have a 90 minutes door to
No,
door.
8 hours.
The moment
8 hour
they come to-
presentation. How can the BSD develops in 8 hours?
No, it can develop even within 8
No, no,
hours.
so
It can
patient has
develop.
come as a delayed presentation, has come to ER, you do a screening echo,
No, I
our
do it.
resident picks up a VSR and also ECG shows a evolved MI.
Well, that is
So
already
what do you
the
do?
problem.
So
That is
you
what
quickly
he's
do
trying
an
to say.
angio and send it for a CABG VSR.
Yes,
repair.
yes.
That
Devanuda.
is-
We had
a Yes, patient-
Yes,
we had a
comment.
patient-
Devanuda first.
Yeah,
Devanuda.
I'll give you a phone. Yeah, please, sir. Sir is one of our most experienced old. He did the fast BMB. BMB is one of the structural procedure in Calcutta.
I've got two questions to you. One is you have done the angioplasty after 8 hours, and after 2 hours, patient develop this VSD. So how common is it for a VSD to develop after 10 hours after myocardial infarction? That is one thing which is bothering me. The second question is, you have done this device, tried to put in this device at 48 hours. Now at 48 hours, I have seen many OTs of VSD actually. So it is just like jelly. There is no fibrosis at all at 48 hours. So is it safe to put in a device
that
at
is what I
48
have shown in
hours?
the natural history.
Or do
That
you
is
think
what I
that
have shown in the
surgery should
natural
have would have been the better?
We had a patient, just one thing, we had a patient who came within 12 hours. Before we took for Cath, we found an apical VSR. We did, and it was since an acute presentation, LED was completely occluded. We took high-risk consent, went for angioplasty of LED. We discharged the patient and kept reviewing the patient. After 6 weeks, we did the VSD closure, and patient is doing fine. It's 1.5 years.
So that is what I am trying to say, that the God has saved her.
No,
Yeah.
one thing,
natural
no.
selection.
No, one thing is that it is very unlikely to have a VSR within 8 to 10 hours. So that is very important. So we have missed the timeline.
I think your
So
question,
there,
your patient
that is
has
the
more
most
questions
important.
than answers.
It's almost
Now,
we can-
I have not.
I
What,
think
sir?
the person
move
who
on.
has lived for 6 weeks would have lived ever without VSD closures.
So I would like to ask your experience regarding referring this patient to the surgeons. So how receptive do you find the surgeons opening up these patients after having a post-myocardial infarction VSR? I found that our surgeons always try to delay things if he stabilizes, blah blah
6
blah blah
weeks.
blah.
They will
So
ask
he doesn't
me
want to
6
touch this.
We have to run with the time. Saurabh Das, Black Cat, Black Leopard बोलूँ এখন থেকে তো একটু ডাইনোসর
Thank you, everyone, for giving me opportunity. Dr. Dilip Kumar, sir, and our respected IBHRE, sir. So this is not of any complications. We just did a infrarenal aneurysm was there, and we did a EVAR for that. It was a difficult procedure. It took us almost 3 hours. Maybe we'll be, over the years, we'll get it down to 1 hour of doing this procedure. So endovascular aneurysm repair, we all know it's a type of minimally invasive endovascular surgery which is used to treat the pathology of the aorta, most commonly an abdominal aortic aneurysm. When used to treat a thoracic aortic disease, the procedure is then specifically termed as TEVAR. So for aneurysm, less than 5 centimeter surgical intervention is not indicated. However, the patient should be kept under constant surveillance. In European nations as well as in US, the aneurysm diameter of more than equal to 5 centimeter is generally considered as an indication and for aneurysm repair. Here, although early surgical repair of aneurysm has been seen of less than 5.5 centimeter has been shown to offer no advantage compared to the surveillances. So type of EVA, we all know that it's a simple EVA. If it is a infrarenal with good landing zone, we have got a chimney EVA. If it is just juxta-renal aneurysm, just be below the infrarenal zone with good landing proximally. And one is fenestrated EVAR, which has been discussed, which is a more complicated case, which needs a lot of expertise and all, because we have to secure all the vascular structures in and around. So what is the most important thing? Because before we go for any procedure, the most important thing is a planning. So what I have seen is planning really solves 50% of the battle is won over there. So nearly 80%.
You have a case?
Yeah.
You have a case?
Case?
Do you have a case?
No.
No. No case?
No case.
Okay.
Slowly. Yeah. Case, please.
That's what I'm saying now. Go to the case.
Yeah, I'll go to the case, sir. Okay.
Go to the case.
Okay, just give me 2 minutes. Nearly 80% of the procedural success is on CT angiography. Because why this is important? Because we need to see certain areas when we do TAVIs or we do any structural, we have to see certain parameters. Similarly over here, we have to evaluate the neck length. The neck length is basically the distance is just below the infrarenal zone, the lower part of the renal vasculature. So it has to be around 15 millimeter ideally. Any size less than that, if it is 10 or 11, and it is a hostile anatomy. Angle, neck angulations, because over here we do a center line in reconstruction. So everything has to be taken from the center line reconstruction. If the neck angle is less than 60, it is a preferred. If it is more than 60, 70, it is a hostile anatomy. Diameter is very important because that decides the size of the endovascular, the graft stent. The conicity is a hostile anatomy because it becomes very difficult to choose the device. Circumferential thrombus, if it is more than 50% of circumferential thrombus, it's a contraindication. 50% of circumferential calcification is also one of the contraindications. We have to see for the ileal tortuosity, the calcification, the ileal diameters, these are all important, and also we have to see the access vessel diameter because it has to be around 7 millimeter or more, because we are using almost a 22 French sheath. So this is this is the diagram which you can see. The neck, the length of the neck should be more than equal to 15 millimeter. The diameter of the proximal neck has to be between 18 to 32. So this should be the size. The proximal neck angulation has to be less than 60, and the length of the distal anchorage zone has to be more than or equal to 15 millimeter, and the landing zone, that is the diameter of the landing zone, has to be around 8 to 22 millimeter. So without much delay, as I mentioned, it has to be always a central line in reconstruction. Whatever measurements we have to take, we will never take an axial. The sizes should never be axial CT. It has to be orthogonal measurement. A 3D workshop has to be done. A central line reconstruction is a must. So this is what was our case. It was a big saccular aneurysm, involving both the iliac vessels. You can see it is a big aneurysm. There's a lot of tortuosity across both the vessels, access point. So this was the angiogram DSA which we took. So again, ideal anatomy is, I'll just skip this one. Okay, the device selection has to be 15 to 20% size we increase for aneurysm. So how we decide? We see the diameter, the maximum diameter of the neck, and then we oversize it to 15 to 20%. And that is how we should do. And if it is a conical, which is a hostile anatomy, we have tapered, the life take has got tapered graft after, if it is, we are dealing with a conical aorta. So I'll not go with this endoleaks. We know there are type of endoleaks, type 1, type 2, type 3, type 4, type 5. If type 1 is mainly involved, okay. So this was our case. It was a case of undergone a CABG3 grafts, Lima to LAD, and D1 sequential graft was there, and RSVG to OM3. There was good LV systolic function of 60% infrarenal aneurysm in CT. Patient came to ER with excruciating abdominal pain. The finding was, CT finding was there was a big infrarenal saccular aneurysm involving both the bilateral common iliacs. Okay, so this was the CT finding as I spoke to you. Here the 24 is basically the neck length and the size of the neck length, which is important, which is more than 15. So it's an ideal anatomy, and the distance hence from the infrarenal zone to the bifurcation was around 101, and that is almost 101, almost 101 millimeter. And then we measure the length of the aneurysm of both the iliac vessels. So the plan was, what was the plan? This is, if you see the DSA, the plan was to deploy your Ancora. First of all, what we did, we took it very coolly, step by step. We took a 22 French sheath across the left groin and we did a pre-closure with 2 prostyle at 11 and 2 o'clock position. And then on the contralateral side, we took a 18 French sheath, all were ultrasound guided. Exact puncture was done above the profunda, bifurcation of the profunda, and below the inferior epigastric artery. Idle punctures to see whether the anterior wall is not having any calcifications, so that the closure becomes much easier later on. So we used a 18 French contralateral sheath and with Manta post closure, which was, and then we planned for an Ancora 30 by 12 by 160. So 30 is the diameter, 12 is the length, total length is 160 basically, and the body is around 12. So from distal to the left renal artery, from left axis is using a Lunderquist wire, and the contralateral side, the plan was to use a right Ancora iliac extension on 14, 12 and 160 up to the external iliac. So the plan was also, because as it was a bit short and the aneurysm will not be covered by the original device length, we thought of going for an ipsilateral extension cuff, which was 14, 12 and 10. 14 is the proximal part, 12 is, as it is tapering, 12 is the distal part, and the total length was 100 millimeter with the overlap of 3 centimeter overlap was there, so that we can easily close the big saccular aneurysm. So the procedure went like this. So first we deployed the body with the ipsilateral as well as the contralateral limb. You can see in the first picture. Again, okay. And then when we saw, it was still, there was a leak happening across the large saccular aneurysm on the left-hand side. So we thought of doing an extension, putting up an extension on a device which is 100 millimeter to do an overlap of almost 3 centimeter overlap we wanted, and we did that. It is already deployed over here. So this was the result. So, but you can notice on the second picture, there was a mild leak across the overlapped segment. So we used a Coda balloon, that is a very low pressure balloon which helps in, proper, or, delineates the graft stents and pushes it way further, and it gives a good anchorage. So with a good post dilatation with a Coda balloon, we were able to achieve, this was the result. There was no leak across, and we were able to close the both the saccular aneurysms. So left was huge, and this was the CT. The next day we did a CT. This is basically a per close, which I won't be going in detail. We all know how to do. We do use 2 per closures. There's one at 11 and
right.
one at 2 o'clock. We don't
stop.
want to go in that. So this was the procedure when...
okay, you can stop here because the prostyle you are not going to discuss.
No.
Are you going to discuss prostyle?
Sir, only Pearls I will be discussing. Okay. Pearls. So Pearls is whenever we are doing a infrarenal EVAR, first respect the neck. The neck is the proximal landing zone, we should respect it. Please determine what is the length, what is the diameter, or what is the shape. If it is cylindrical, it is a good anatomy, you can go ahead. If it is conical or a reverse conical, it is going to create a lot of problems. There may be, don't oversize or don't undersize. There is always a chance of popping out, or a type 1A leak, endoleak can happen. Pearl 3 is identify both the renal arteries is before deployment. Don't go high up and don't go much below. Straighten up the tortuous vessels. As I mentioned that on our right hand side it was a tortuous vessel, so straighten up with stiff wire, like we used a Lunderquist wire. And never deploy during patient movement, because if there is a lot of movement happening or deep respiration, please ask your anesthesia for a brief apneic phase. And Pearl 6 is always maintain a wire position, don't lose your wire. That is otherwise smaller things can land up you in a bigger trouble. Treat the type 1 and 3 endo leak. As I mentioned, there was an endo 3 leak. This type 3 leak we had when there was an overlapping segment. So we immediately went, and with a Coda balloon, we were able to seal the leak. It should observe the leaks. If on table, repair it, come back, so that the patient is not going to suffer. And observe mostly the type 2 leaks, see for it if there is any aneurysm sac enlargement. Perform balloon.
I think, Saurabh, what is good presentation? You have to do a good job, not only to the presentation, to the time.
Yeah, done.
Done. We have crossed almost 5 minutes. Anyway, quick comment from Silanjan.
Excellent case, I should say. Beautiful planning.
Mike kotha bolo. Mike.
Yes. So excellent planning, and Shodav has also beautifully discussed everything from planning, what are the important steps, the nitty-gritties, technicalities. I have got no, primary experience about ever, only theoretical knowledge. So it's very good to see that.
So I ask you theoretical knowledge, a question to you. What is the cutoff for treating abdominal aortic aneurysm? 4.5, 5, 5.5, 6?
Cutoff
Oh, sorry.
Saurabh, before that.
7:30, okay. Saurabh, are you listening? What is the cutoff? In your case?
Sir, 5.5.
In your case, what was that?
It was used 13. 13 was the
diameter.
Diameter 13.
30.
13.
1.3. No, that's the iliac. I'm talking about the abdominal part.
Abdominal aneurysm was 13 centimeter. That's what you said.
13 centimeters, sir.
13 centimeter abdominal part?
Abdominal part.
Not the iliac?
Not the.
What was the iliac part?
The iliac part, I'm talking about, there was an aneurysm across the iliac part. It was 13 centimeter, the diameter.
13 is the iliac part. What was the aortic part? Was there any aortic aneurysm?
No,
there is no aortic aneurysm.
It was infrarenal, sir.
Okay, only the iliac. Okay, only the iliac. Suppose one question to you. Suppose there is a recurrence of this iliac aneurysm. So what you will do?
We have to first
due to leak.
Yeah, we have to first can find out the phase of because there are two portions. One, what happened during the procedure, because he had to put a bridging stent. That area is vulnerable. That area might leak. Another is the entry point where you have deployed that largest area. That also area can tip in gradually, can cause leak and increase in the sac size. Both has to be optimized.
So it is type 1A and type 1B. What we do is we do a balloon.
No, not here. I'm telling.
Recurrence.
Once
in this case, yes, I'm telling about the recurrence. I'm telling
you
about
leak. Type is mentioned.
So
these are the two areas that are more likely to fail.
So type 1A, type 1B, type 3 is very common. Type 2, if it is there, wait and watch. If not,
Rana,
then we can.
Rana is done. Gopal will.
Gopal.
Yeah.
Okay, thank you, Saurabh. Gopal and Dilip.
The age of the patient.
Age of the patient?
68.
68.
Why didn't you do internal iliac occlusion?
Yeah, so we actually.
Actually, this case can come back. Basically, because we are not occluded.
Yeah, so we have not occluded the internal iliacs. We started with the plan of doing internal iliac occlusion, but it was so huge we couldn't locate that.
Okay.
Yes, so we thought
But-
if it happens, we'll see.
But on a CT, we could
Direct
see-
puncture. No, there was no retrograde filling. There was no retrograde filling, and IRs can do that if there is a reverse retrograde filling of the aneurysm sac. Then they can directly puncture that and they can do something. So we left it there and we did the procedure. We were unable to go and see where is the internal iliac. It's such a huge structure. Gopal, yeah.
Gopal.
Yeah. First of all, thank you, Dilipda, for arranging this first summit in the Eastern India. So, this was a 83-year-old lady, diabetic for 30 years, hypertensive for long time, 10 years, recently admitted with acute decompensated heart failure. She had bilateral severe osteoarthritis, restricted activity. So echocardiography showed that patient having a severe aortic stenosis and LV function was normal. So this was the analysis in the CT showing ascending aorta around 29. The perimeter of the aortic annulus is around 68 and good ASO means sinus of Valsalva. And comment was tricuspid valve, moderate aortic valve calcification, moderate calcification of the coronary arteries, and mild calcification observed in the sinotubular junction, and both arch of aorta and descending aorta have mild to moderate calcification. So this was the valve. The coronary heights was quite adequate, 15 mm from the RCA and 12 to 13 mm from the left coronary artery. This was the cusp overlap view showing the proper LVOT can be visible at just epicaudal view, RAO1, caudal 29. Moderate calcification in the aortic leaflets. The iliacs not very bad, 8.5 mm. Femoral artery around 7 to 7.5 mm. Not much calcification in the iliacs and femoral arteries. So depending on this CT, we choose to go ahead with Hydra valve. So we crossed the valve in a routine way like AL with straight tip glide wire, then exchange with safari wire. I forgot to put the pre-dilatation video here. I just pre-dilated the valve with Atlas balloon. Just after the pre-dilatation, patient developed complete heart block. The TPI temporary lead was in place. The heart rate was around 40 to 45. So we started deploying the valve in that very slow heart rate. So after confirmation, we started deploying the valve, and after 80% deployment, we assessed the hemodynamics. It was quite okay. So we deployed the valve. So this was the angiogram after the deployment. There was some paravalvular leak present, but we accepted as the patient was 83, hemodynamics was good. So we did not post-dilate the valve. So we stopped here. And later, day after the procedure, we put a permanent pacemaker for heart. So before doing that, we check the groins and it was adequate. So we close the groin with a single park close device and with manual compression. This is the post-procedure echo showing not much paravalvular leak. The gradient came down, mean gradient was 9. So comprehensive CT evaluation is essential for successful Hydra TAVI planning and valve selection, and careful imaging guided planning resulted in successful TAVI. The case was not very tough for people like you, but only thing this procedure was done in my center that was not very equipped in that place is a tier 3 CT. So thank you.
Wonderful case.
Right. So what is the definition of small annulus for Indian Asian patient?
So valve area less than 430 millimeter square is considered
Indian.
small annulus.
Asians, Japanese?
I'm not sure.
There is a criteria called extra small annulus.
Smaller. They have
One
different.
is 430 is the small
430
annuli.
European.
380 is extra small. So that.
So is it a small
Yes, sir.
annulus?
It was extra small.
Any quick comment? Otherwise, we'll go on to the last.
It was
Thank
not
you.
a small
could have
annulus.
post-dilated
You
that.
used a 26 hydra, and how can you say it is small? It is normal annulus.
But it is a
Anyhow,
small annulus.
It was not, sir. It was
Three-
area
three-
was
308 something.
The CT was showing
389,
359.
389 or something.
389.
Ah,
sir.
he has used a 26 valve, sir. How can it be small?
Criteria
annulus?
wise, it was small, so he took a larger valve to make a larger UA.
But anyhow,
yeah,
wonderful case.
wonderful.
I
Thank
mean,
you.
nicely
Thank
done.
you, sir.
Wonderful. So this last 3-4 minutes, I think it's just a token of word of thanks for all of us. Before that, I present a case which was a Hydra case, and I had trouble which was not very expected. So we'll quickly go through. Yeah. Can we have the presentation? So this was, a 75-year-old diabetic male, severe aortic stenosis, and you can see here the area was 434, LVOT 23.4, RCA height, LC had no problem. So it looked like a day-to-day normal case, and sinusoid valsalva was roomy, tricuspid, and you see the calcium. The Gopal just showed a case, and you'd have appreciated a lot of calcium in the aorta. Here there's a small chunk of calcium here and a little calcium here, and that was okay. The leaflets were calcified, but not the annulus and the LVOT. So I didn't foresee any much problem here. But once I went in, you can see here the cross section, the calcium was not at all much. And once we went in, here the valve was not negotiating this curve. So it was hitting that small chunk of calcium. So we thought what needs to be done. We took an extra body wire and then a peripheral balloon to assist this in negotiation. Still it was not going. Then what next? We took the snare. So the snare from the another groin, and then you pass your wire through snare, confirm that you have gone through snare. You just hold it and see that it is through that, and then everything happens through this wire. So you are through the snare, and once you recross this, then the snare is up, and this is pulling the device. So there is no navigator here, like in balloon expandable. You can change the angle. You can navigate, and here there is no navigator. So, but Hydra is a very flexible valve. It generally negotiates. So we had to use snare in this case with very small chunky calcium. That was the point of presentation here. But when I was presenting this case in Kochi meeting, the proctor, one of the European proctor told me that is not the calcium which created problem. That was probably the Hydra valve. From some batches of Hydra valve, they had this problem. And if you would have taken the different valve, it would have gone. And so then I really, got back to case. And I remember that I took the second valve. I asked them to change the valve also with the snare. So these things can happen, and you should be ready to have to deal with all these kind of small problems, integrities, and a snare, cover stent, a sheath has to be there. And one or more 2 points which I need to clarify. The size was, which balloon size should be used for pre-dilatation, which should be used for post-dilatation. When we are using pre-dilatation, it has to be minor axis of the annuli, maximum up to 1. But nowadays with the low risk tower, the study, now there is a more aggressive pre-dilatation is happening, especially for self-expanding valves. Second is, what is the largest side in post-dilatation? It has to be mean plus 1 maximum. So whatever the size of annulus is there is a minor major axis and a mean is there. So mean plus 1, that is what you should be having as a balloon which should be post-dilated. That sort of asks the question, and this is the answer. So with this,
if
Dr.
your
Prasad,
snare doesn't work,
sir?
If your snare doesn't work, then what?
Then I would have chosen for another kind of valve, balloon expandable with navigator.
So Hydra is also coming with a newer iteration, which is a spineless and more flexible.
Yeah.
So hopefully that will not be there.
Yeah.
Similar kind we used to see it in a core valve at times. Nowadays with the evolution,
that was a problem.
gone.
Hydra doesn't have this problem. Hydra some batches problem. It's a very flexible valve. It happens more with
core valve or a evolute platform, not
No,
ProPlus.
let's talk about this case. The Hydra did not go even after using snare. What you can do?
No, if we snare, we pull, it should go number one. And if it is
It
not
did
going,
work. It's not going. I'm just
Not
hypothetical.
no, sir, there is a very hypothetical question. If it
Then-
doesn't go, then we can
Then
change
we'll
the
go a right
platform.
carotid or right subclavian if you
Yeah,
want to use the
even
same
then,
valve.
yeah.
Alternate X. If you are asked to do the same case from the same axis,
Yeah.
is there any?
Yes,
So
we
there is
can we can use a large
Yeah.
sheet, sir.
Yeah, so the
and
Python
place it across.
There's a
the
longer
and
sheet
cross.
is there, which can
No,
But
not
in
double
India-
sheet.
in India it's not-
Python Z seed.
That's it, yeah.
But in India
developed
it's
by
not yet available, na, sir.
developed by Bharat Dalvi, I think. Bharat
But
Dalvi.
in India it's still not available easily, sir.
Python Z is available, sir.
Oh, okay. In
Python
Bangalore
Z
it's
from
not there.
Merrill.
Ah.
The long sheath, as he is mentioning, you put a long sheath. Anyway, very nice case.
Thank
I think
you,
we have
thank you, sir.
enjoyed thoroughly.
Thank you.
Especially
Good
me.
conference. Thanks for inviting me. Thanks to
to-
Dr.
Thank you,
Dilip and entire team.
everyone. I think a big round of applause for all those who stayed back till the very end, 7:45, and we started at sharp 9:30. Sharp 9:30. A second before, not more than that, not later, I think. And we are finishing right on time. And I thank all the faculty which came, which guided us, the discussions and all industry friends for being there. Audiovisual, Sunil is exceptional. And I think, thank you so much. And it's time for a long, big picture on this stage with everyone. Thanks again. Thanks, everyone.